Recording in progress.
Live.
Dr. Zubin, please proceed.
Yeah. Good afternoon, everybody, to all our delegates, and our esteemed faculty, and welcome to the World Congress of Anemia 2022. The World Congress of Anemia in 2021 witnessed an audience of 9,450 plus doctors globally, and it was built across 9 associations. Today, it is supported by the World Anemia Forum and is an environment that puts the expertise to work in translating global science into recommendations and observations for clinicians. The theme for the second World Congress of Anemia is iron deficiency anemia, and we look at the tools for effective prevention and control. With no further ado, I would like to go ahead and introduce our first, the president of MOGS. Could I please have the slide? Yeah. He is someone very close to me and my professor, Dr. Niranjan Chawar, professor and head of unit department of obstetric and gynecology at Sion Hospital in Mumbai, also president of MOGS year 2022-2023, and the joint treasurer of FOXI, the FOXI secretary, and the Mumbai Obstetric and Gynec Society treasurer in 2019-2020. Good afternoon, sir, and I would like you to take us forward and introduce all our chief guests.
Thank you so much, Zubin. It's a wonderful Saturday afternoon in India, and it's evening in California, and we are 2.5 hours behind in Uganda, Kenya, and 4.5 hours behind. Dr. C.N. Purandare has already joined, and that's in Dublin, and this is going good. And the World Congress of Anemia has been founded by the World Congress Forum, the World Anemia Forum, and Dr. C.N. Purandare was a witness to this in 2019 when we had the AICOG in Bangalore. And that's how the Academy of Global Obstetrics and Gynecology came together hand in hand, and this is going great. My parents always said philanthropy starts at home, and with my days as a municipal doctor, added with the COVID experience last 2 years, my life motto has become only education and reach for all. This can only happen and can be offered with such stalwarts coming from transatlantic, trans-Pacific. You have Arabian Sea, and it's amazing to see so many people being joined together. Without much time, I would like to briefly welcome and introduce WCA. WCA is a project which we have started, and this is the second world conference we are keeping. This time we are having 14 organizations coming from all over the globe and trying to understand how we can reduce anemia, do the prevention, and we can have certain targets of hemoglobin, achieving the goals in the lower middle income group countries and those affecting the nations which are affected by the anemia. In Mumbai, I am serving in Sion Hospital, which has about 14,000 deliveries a year, and we have about 30 to 40% of patients coming with anemia. I cater to the largest slum area of Asia that's known as Dharavi, and still 31 years I'm in there, the incidence of anemia or PIH is not reducing. And that's what we are here today to discuss, how we can go through and we can reduce this. We need to do a lot of things, and I'm very, very happy to be there along with CN sir and Madam, the President Figo elect, and Chiara Betres as the chief guest. And our guest of honors, none other than our FIGO president, Madam San Francisco, coming live, Dr. Jean Conry, ma'am. She is the past president of the American College of Obstetrics and Gynecology and doing a wonderful job for last one year being the president elect and then now becoming the president. Her main program, and yesterday we discussed on this, that we need to target this low middle income group countries, and there is a critical situation where we need to have that awareness of anemia. Thank you, ma'am, for coming. Thank you so much. I would also welcome you now to address the August gathering together.
Thank you so much for inviting me to be part of the Second World Congress of Anemia with a very important focus on iron deficiency. Professor Niranjan Chauhan, president of the Mumbai Obstetric and Gynecological Society, Professor Mangis Tuaskar, the general secretary, and then our very important masters of ceremony, Dr. Garima Sharma, Sidrajot, and Zubin Sherar. Thank you for all the work it takes in coordinating the efforts that we're seeing here today. I'm honored to be part of a very distinguished group of dignitaries. We know that we've spent decades focused on maternal morbidity and mortality, and most certainly have seen successes, but not to the level that we should, given our knowledge base, given the awareness, and given the global dedication to improving the status of women. I cannot help but believe that making certain women begin a pregnancy in the state of good health is critical to good outcomes. I strongly believe that it is women's health across the entire lifespan, from adolescence through maturity, that must be our very important mantra for every woman, every time, at every single contact in our healthcare systems. We must assure that women and their health is optimized. And this goal is only achieved if we set an expectation that routine preventive healthcare is a goal that all women should expect and be provided. In many parts of the world, and you've said this so eloquently, the optimization of healthcare involves a recognition of the prevalence of anemia. We know that anemia impacts about a third of women worldwide, but if we look only at Asia and Africa, we see anywhere from 50 to 60% of the population being impacted by anemia. So making certain that anemia is diagnosed, is evaluated, and treated across a woman's lifespan, and most importantly, adolescence through reproductive years, it's a consistent message that we all need to provide. So at this Second World Congress of Anemia, please help us translate the science. Please help FIGO advocate for change. Please help us all educate more effectively. And finally, help us strengthen our healthcare systems so that we can bring about the change that makes well woman healthcare routine and expected for women, regardless of income, regardless of their country. That's what our expectation to improve the health and well-being of women. So thank you very much for inviting me to be here. Congratulations on the work that you do.
Thank you for that wonderful address which you have given today. It's an honor for all of us, to host these leaders, and it's a blessing for all of us, the all audience. Our objective is very simple. It's awareness and prevention and anemia across therapies and communities. Thank you for your valuable time. So much. Thank you so much, ma'am. Now I call upon Dr. Shyam Desai, our managing trustee of Mumbai Obstetrics and Gynecological Society, and our guest of honor for today. I would request him to give his address. Thank you.
Very good morning to all of you attending this webinar. It is indeed a very important topic that is being discussed because anemia affects almost 40 to 50% of the population, especially in the underprivileged countries. Anemia can cause several problems in the general well-being of the patient, and it can also lead to a lot of other affiliated disorders such as infections that can debilitate the patient even further. I'm happy that the MOGS, under the presidency of Dr. Niranjan Chauhan, has taken up this very important topic with the World Anemia Forum. I believe even the one in 2021 was very well attended. And this particular topic cannot be ever over discussed because it is such an important topic. It is repeatedly seen in our patients, and it is very easily treated because it is usually because of iron deficiency as well as malnutrition. I wish this Congress all the very best.
Thank you so much for those wonderful, encouraging words, and I am very happy that Sir has now become the President-elect of the South Asian Federation of the Obstetrics and Gynecological Society, and we will be very eager to hear him later on to talk on reducing incidence of iron deficiency anemia in Southeast Asia. Thank you so much. Now I call upon Dr. Nandita Palshetkar, ma'am. She is the Foxy representative to FIGO and presently the president of SR. She has hold lot of feathers in her hat, and she was the Mumbai Obstetric president, the Foxy president. She has been the IAGE president. Right now, Dr. Nandita Palshetkar is going to come live from Aurangabad, and I welcome her to give her address. Thank you so much, ma'am.
Thank you, Niranjan. Thank you so much. And I think it's a wonderful event which you've got together, and you've got all the luminaries here. I think Dr. Jean, Dr. Kiara, I think there are so many, Dr. Carmen. I'm on my mobile, so I really can't see everybody. But I think it's, the need of the hour. The anemia is something that we can correct and prevent mortality and morbidity, and that is something we have all worked for. Initially when anemia was in 90% of the people, but the latest survey is showing that it has reached 50%. So I think it's the effort of everybody that is really important and has helped our country to build up this hemoglobin. And now more and more, we during my year, we did the Guinness World Record where we evaluated nearly 3 lakh women. And that is what is important. Each one does a little bit and contributes to uplifting women. And what you are creating an awareness and creating this platform, I think it's so very important because anemia affects everything and everywhere. So Niranjan, once again, I congratulate you, and this is a fantastic endeavor, and I wish you all the best. Thank you.
Thank you, Dr. Nandita, for joining us from Aurangabad. And it's really great. Your year of the All Maharashtra Obstetric Gynaec Society last 2 years was really good. You touched the nook and corner of Maharashtra, not only Maharashtra, but all over India. And we are very thankful for you being joining. And I reiterate that yes, you have said is absolutely right. We need to work on that. And that's why we are going to be here today with wonderful people who have come from all across the platforms and the organizations. Thank you so much. Now I call upon our own Dr. Sanjay Gupte from Pune. He is the Foxy representative in the year of 2021-2022. He has been the ex-chair of the ethics committee. Sir is also a lawyer, and he has been holding a lot of hats, and we are very proud of him. Very medical legal consultant and absolutely good. Has authored 8 books and chapters of more than 40 books, more than 150 publications. Sir, you're an icon in yourself and always guiding us. Thank you for joining in spite of your busy schedule. I request you to please address the August audience.
Thank you, Dr. Niranjan, for organizing this wonderful forum, and I'm very happy to be on the second World Congress of Anemia, especially among all the dignitaries that are present here. The one message I would like to give, and this, Dr. CN, remember that together in 2010, we went to the government of India and convinced them that the parental iron is something very important in our country, if we are to make difference in improving the anemia situation. And fortunately, they agreed to us, and then that came into their planning, and now we have that parenteral iron available. Now, what we have done further is that recently we have published a large series in international journal about an FCM being used in pregnancy, and we have proved that injection FCM is absolutely safe to be used in pregnancy. And I think that will go a long way, especially in countries like ours and in LMICs, because many patients come to us directly during pregnancy with severe anemia. And that's the only recourse, because you can't wait then with oral iron and hope that the hemoglobin will increase. And since FCM is now available to us, I think we should definitely encourage all our members to use it, because it has been proved to be safe. There is a protocol how it is to be used and when it is to be used, and that we can discuss this later. But that would be one message. Thank you so much. Thank you for all the dignitaries, especially our FIGO president, Jean, for being there as always, very enthusiastic in our work and leading the FIGO greatly, and Dr. C.N. Purandare, Dr. Ann, and all the other dignitaries. Thank you so much.
So wonderful, Dr. Sanjay Gupta. Thank you for giving that idea, and I am sure your trial, which has been published, has gone really good, and you have to understand, and everyone has to understand, that the parenteral iron therapy is the only thing which is very important right now, and we are going to discuss it further. Thank you so much, sir. Now I call upon my chief guest, Dr. Ann Beatrice Kihara. She is the president-elect of FIGO 2022 and 2023. Later on, she's going to be the president from there onwards. She is also the president of the African Federation of Obstetricians and Gynecologists since 2020, and the past president of the Kenya Obstetrical and Gynecological Society from 2013 to 2017. She has been also a consultant since 1999 and a senior lecturer in the Department of Obstetrics and Gynecology in Nairobi since 2006. Her special interest is adolescent and youth health, leadership and advocacy, and she has got more than 100 publications in peer-reviewed journals. Madam is a women's health advocate, and we welcome you to address this World Congress of Anemia. Welcome, ma'am. Madam, can you please unmute yourself? Thank you so much.
Namaste. Greetings to all of you, wherever you are and wherever you're tuning from. Particularly appreciate the organizers of WCA and the leadership that they thereby exists, MOGS, FOGC, and even FIGO, who's hereby represented. I will request my slides to be put on.
Dr. Kihara, the slot for the talk is slightly later. May I request you to kindly give your chief guest address?
Okay, I'm really appreciative, having come from a low middle income country where anemia really plagues us. And it plagues us right from when I'm pregnant to when the baby is born to throughout my adolescenthood, and particularly as a young girl who begins menstruating. What is the key problem? Nutrition. Nutrition. And nutrition which is malnourishment, either from undernourishment or, as we have it now, from inappropriate overnourishment. My prayer is, as we go through this discussion today, is we can have a tangential shift, not to have a life curse, but really look at a life course that gives hope to women and even into generations that come. Thank you so much.
Thank you, ma'am, for that wonderful address, and we look forward to be doing a lot of efforts in your tenure also. And WCA is going to organize the next. I would like to announce in April somewhere next year, and I'm sure ma'am Jean and sir everyone will be meeting, and we will be having a lot of discussion on that. And I'm surely the incidence is going to come down in the next 1 year. What we plan to. Thank you so much for being there.
Thank you.
Now I call upon my guru and my mentor, Dr. C.N. Purandare sir, uh, very affectionately known by all of us in Mumbai Obstetric Gynec Society as CN sir. He has got a lot of degrees, you can see, and he has been holding the fort of Foxy, the FIGO, and a trustee presently of the Mumbai Obstetric and Gynec Society. He's also done a wonderful job in ICOG and getting MRCOG, MRCPI for our Indian students so that they can go down to Dublin or UK, and really that has the next generation has really liked it, because that's what the next generation needs to upgrade their knowledge, and they have gone in Europe and being studying there. And he is also being the editor emeritus of journal Foxy Jogi, and the emeritus honorary professor of the SATE of the Grand Medical College and Sir JJ Hospital, Mumbai. Sir, I welcome you to please address as a chief guest for the WCA. Thank you, sir.
Thank you very much, Niranjan, for giving me this opportunity. I'm feeling bad that I'm not being there in Mumbai for all these functions that are happening, but I am always with the Foxy and MOJs for any functions that are being organized, conferences. Anemia is a major issue, and we have worked on it for such a long time, but yet not reached the level that we could reduce the anemia and reduce the maternal mortality because of anemia. We still see women, I'm sure in Sion Hospital, where you're delivering 14,000 women, see women coming into labor unattended before with 4 grams and 5 grams hemoglobin, which is extremely difficult to handle when they come in with such low hemoglobin. We have worked very hard on this at government level all these years, and even adopted villages to go ahead and make sure that the patients are looked after and the anemia is controlled. We started the anemia eradication program, which is on as far as government is concerned, but still not being able to cater to the entire population in India. And this situation is existing everywhere, whether it is Africa, Asia, Oceania, anywhere where the low middle income countries where the control of anemia is essential. We found that even though the tablets were given free to all the patients by the government, patients never took those tablets. They felt that going home, they would give the tablets to their children or to their husband who require energy and so on. And they didn't take it themselves when they were supposed to be taking it, and which has resulted in increased maternal mortality in the country. Then came the parental iron therapy, which we tried, and as Sanjay said, we have done research on that as well from Foxy. And the most important thing that came out of it is that instead of looking at women to be given tablets and hoping to take those tablets, maybe first time when they come in, if you give parental iron dose and take care of that situation right from the beginning, even if they don't turn up later on for subsequent antenatal visit, at least a full dose has gone in there, and it helps in improving the iron requirement in the mothers. Niranjan, I think you've done a great job bringing this to the World Congress, and that's really what is needed for not only making people aware, the doctors aware what needs to be done, what is the latest that is available that can be looked into. But at the same time, we need the population to be made aware of this. And I think the media now, which is so very efficient in carrying it through, I think MOJS, Foxy should make sure that the media gets involved in even a small clip which goes on. People keep on watching TV all the time nowadays at whatever level. Mobiles and everything is being used for watching TVs and programs. The important programs, even every program, important program, if a small half a minute clip is put in to how important it is for nutrition as well as the iron to be supplemented for improving the. So again, congratulating you, and I'm sure at the FIGO level, Jean is there, and Chiara is going to take over next year. FIGO is fully supportive of these initiatives, especially in the low middle income countries, and Anne is well aware of what the situation there are in Africa. So take this forward in a big way. Thank you very much.
Absolutely, sir. Your message is very clear and loud that we need to also not only disseminate the knowledge amongst our fellow obstetrician and gynecologist, but a small half a minute or a 1 minute clip to the audience and to our patients is surely going to make. And I'm sure Suvarna and myself and Madhuri and my secretary will be doing on this task, and we will work on this. And I'm sure in the next 1.5 months we need to have certain things which are being also broadcasted over the social media sites, so how the patient can improvise herself to be not having suffering from anemia. So that was a very important key message being given by Dr. Niranjan Chavan, and I'm sure in the next 1.5 months we need to have certain things which are being broadcasted over the
May I
social
request
media
Dr.
sites.
Zubin to kindly take the proceedings ahead?
Yeah, so we'll move forward with our traditional lamp lighting and a small prayer before we start our scientific program. Thank you so much. I think we are moving a bit ahead of time, but should we start off with our scientific program?
Yes, please go ahead, sir.
Yeah, could I have Dr. Suvarna's slide, please? Yeah. For the first session, we'll be doing it in association with FIGO. Our chairperson is Professor Suvarna Khadilkar. She's professor and head of Department of OBGYN at Bombay Hospital, Mumbai. Also editor emeritus at JOGI 2021 onwards, and also the joint secretary of MOGS in 2020. Good afternoon, ma'am, and I would love for you to introduce our speaker for this session.
Thank you so much, Zubin. At the outset, I would like to congratulate and thank Dr. Niranjan Chavan for this fantastic conference on anemia, the second World Conference on Anemia. I feel very proud that I am a part of MOGS and such good activities happening here on this platform. And I can see so many distinguished guests, my own teacher and mentor, Dr. C.N. Purandre, Dr. Jeannie, Dr. Annie, and there are so many, Dr. Sham Desai, and all the guests of honors who are here. I really appreciate their presence and their guidance in this area. And it's my privilege to introduce our chief guest, Dr. And the speaker, Dr. Annie Chiara. I think most of her introduction has already been done by Dr. Niranjan. But I must say that I have personally met her at Dubai, and what a wonderful person she is. More than, being a president-elect, I think she comes across a very friendly and very, very committed person that I observed about her. So I really welcome you, Dr. Annie. I just do a quick formality of your introduction. Everybody knows how much work you have done. She is the president-elect FIGO 2021-23, president of African Federation of Obstetricians and Gynecologists since 2020 to date, past president Kenya Obstetric Gynec Society, consultant obstetrician and gynecologist Kenya since 1999, senior lecturer in Department of Obstetrics and Gynecology, Nairobi. I think so many other accolades and achievements are there in the whole list. She has more than 100 scientific publications in peer-reviewed journal. That's a significant number. And we are really, really very much privileged to have you speak about anemia. I'm sure you will give a very good picture of what is there in Kenya as well as now all over the world. India is also fighting the same problem. The girl, child, and women of family are never given good nutrition. As Dr. Purandare said, even if they are given iron tablets, they give away to their male family members and they themselves remain anemic. So we are very eager to hear you, ma'am. So over to you for your talk. Thank you so much.
Namaste. Thank you very much. I'm really humbled and really appreciate this opportunity. So I'd now like to ask for my slides to be put up.
Exactly. I tell you.
Ladies and gentlemen, I know I have been asked to discuss about anemia, and I decided to look at sub-Saharan Africa and look at really what is happening for girls and women as an example of a low middle income country. So I want to welcome you all and also request we all pay attention because this is a certain problem for us. Next slide. So my outline is simple. We'll look at a bit of epidemiology, a simple pathophysiology, and look at the life course approach. And then look at some of the risk factors and some of the solution pathways that I perceive that are possible beyond even looking at it from an obstetrician and gynecologist's view. Next, please. So globally, in 2019, the prevalence was 30% in women of reproductive age, equivalent to 500 million. The prevalence in non-pregnant women is at 37%. Since 2000, the global prevalence of anemia, unfortunately, has been stagnant. So we can begin to flag, what are we not doing right? And where should we really go? Next. Now, moving on, we cannot talk about a woman without the child. And again, we have realized in 40% in children less than 1 year, you have the prevalence of anemia yet again, giving 269 million children. So my question begs all of us, if it is coming from the mother to the child, what then really happens within this life course? Since 2000, anemia of children under 5 years has slowly decreased from 48% to 40%. But again, this has become stagnant. The prevalence of anemia, when you look at the under 5, particularly in the African child, it is at 60%. Next, please. So I see a dark hole, and this is how I've represented this slide and highlighted what you see in Africa. You have the concentration in most African countries where you have anemia of women in reproductive age as high as between 40 to even up to 60+%. In some areas, they even have outliers that go up to 80%. We're slowly followed by the Asian region. Least of all, we actually see anemia's prevalence to be much, much lower in the high-income countries. Moving on. The black hole continues. When a woman does become pregnant, again, you have a concentration of between 40 to up to 80% prevalence of anemia, slowly followed again by the Asian region. What are we not doing right? Next. And yet again, the prevalence in the children, because we cannot talk about the mother without the child. The prevalence again extends from as low as about 28 to as high as 60 to 80%. It is a black hole, anemia. Next. So what happens when you have anemia in pregnancy, maternal malnutrition? You're prone to infections, abnormal placentation, premature rupture of membranes, preterm labor, obstructed labor, hemorrhage, and even death. Neonatal complications include prematurity, low birth weight, neonatal anemia. You're even more prone to infections, and you fail to thrive. However, there is an opportunity we shouldn't overlook. The first 1,000 days of a child, which is up to 3 years of age, we have developmental plasticity, and we should look at that as an opportune entry point. What happens if it persists in a child, as I have reflected from the epidemiology? Cognitive and motor development really become a problem, and the learning and the IQ is highly affected. So are you surprised? Anemic children do not even perform, and in some cases are unable to gainfully contribute to the development agenda in low middle income countries. The other problem in sub-Saharan Africa we cannot overlook is it often occurs with other comorbidities such as communicable diseases of malaria, HIV, and extreme helminthiasis prevalence. Next. So what does WHO guide all of us? And I think this is an important slide. Reduce by 50% the anemia of women in reproductive age. Reduce by 30% low birth weight. Increase the rate of exclusive breastfeeding for the first 6 months. Reduction by 40% of the number of children under 5 who are stunted. Do not increase childhood overweight, and reduce childhood wasting to less than 5%. Let us bear this in mind as we continue. Next. So the pathophysiology of anemia, I've just given a very broad overview, but we really have about 5 or 6 areas. Failure to form hemoglobin, acute episodes of blood loss, genetic defects that we do see, infective and immunological conditions, metabolic conditions, and malignancies. Next. But COVID affected all of us and continues to affect us globally. What really happened during COVID? We had a lot of malnutrition, and the reason being women who commonly are also the subsistent farmers in a lot of our communities were not able to till the land. They did not have gainful employment or were unemployed, and therefore socioeconomically were compromised. Basic needs became a major problem. When I speak basic needs, it means water and sanitation, food, clean air, clean energy, a big problem. But I also see COVID as having taught us salient lessons where I think the awakening on health became extremely important. And we should therefore have renewed commitments to policies and programs, particularly now, that really look at especially those in the last mile. Next. When food is scarce, women and children are always hardest hit. Next. So, nutrition matters. for posterity, for prosperity, and for development. It is a universally important public health issue. In 40% of the world's adults, we are beginning to even see overweight issues. 52 million worldwide are suffering from acute malnutrition, with each year around 20 million severely malnourished and 9 times more likely to die. Unfortunately, 60% are found in Southeast Asia and sub-Saharan Africa. By the time they're hitting their reproductive age, 1/3 of them are already anemic. And unfortunately, malnourishment does not just affect the mother, but has an intergenerational effect. And we must rethink how to address it. It is estimated in all forms, it costs the society up to 3.5 trillion per year. And now we're getting escalating overweightedness and obesity. That costs US dollars 500 billion per year. That needs to change. Next. I have given this example from my country. This is a staple diet where we actually call it kicking the week on. And it just basically consists of some little greens, but principally a big mold of some carbohydrate issue. This is what we see in a lot of African diets, and even, I want to say, in most of our communities. There is importance to have diversity of diets, particularly during pregnancy in low-middle income countries. Unfortunately, they tend to be of high caloric value and minimum in qualitative issues. But this is a socio-cultural issue, which only makes it more complex to address. But more attention, too, needs to be given to the hidden hunger, the micronutrients that we actually put or have on our plates. Next. So I asked myself, is it a life course approach? And should it be a life course approach and not a life curse approach? And when I think of the life course approach, we need to explore the biology, the social issues, the behavioral issues, the environment, and even political factors. And when we look at the areas we must focus, there is the newborn, the neonate, the infant, the child, the adolescent, the youth, and women in reproductive age. And I dare say, we must also remember they're the elderly that we all tend to take care of in the continuum of care across generations. There is something I call the obstetric transition. If a girl starts as an adolescent and is anemic, the probability it will carry into the pregnancy. We do know we have the physiology of anemia by the time the lady gets to about 32 weeks. But what if she starts with a HB of 4? It just culminates into more adverse anemia. So we need to really think, even with the obstetric transition, how do we address anemia and in the low middle income countries? The resourcing of programs and strategic leverage in entry points that have been offered to us, which I have alluded in the life course. And we must also address the poor health promotion and preventive strategies. It's not good enough to just have surveillance, screening, and treatment, because that may be too late. And unfortunately, in 90% of deaths with anemia, it occurs in low middle income countries. Next. So this just displays for you different leverage points in the life course approach. How do you have interventions right through in the cyclicity of where you have the woman moving from childhood into adolescenthood, into a mature reproductive aged woman, and back again into the cycle. Next. So I asked again, what are the direct causes of maternal death? We all know, and we all know what to do. But just let's have a reflection. Severe bleeding, did we start as anemic? Hypertensive disease, did we start as anemic from the obesity? Unsafe abortion. Do we actually die from unsafe abortion, or is it the anemia related from the hypovolemic shock? Infections, are they culminating more and more from anemia? Obstructed labor. I tend to think anemia really is the underlying blame for all these conditions. Next. Look again to the neonate on my extreme right in green. I've reflected what kills neonates: prematurity, intrapartum related events, sepsis, congenital anomalies, and please remember folic acid is critical, meningitis, pneumonia. That's the neonate. Move across to the other side. What is killing the under 5? Again, pneumonias. We have intrapartum related issues, prematurity, NCDs, meningitis, malaria. Is anemia to blame? Is anemia to blame? Next. So I went into the risk factors and I started with what I think is really the cornerstone as to why anemia still persists: nutritional anemia. But again, I have to remember, women may be coming from a situation of heavy menstrual bleeding even prior to pregnancy, anovulatory cycles, some forms of family planning methods, and what in FIGO we do know as the palm coin causes of menstrual bleeding. Then we have the dilutional anemia. It is physiological during pregnancy. And then we have pregnancy-related early and late causes, where women display pica, hyperemesis gravidarum, ectopic pregnancies, gestational trophoblastic disease, abortions, placenta previa, abruptia placentae, multifetation, intrapartum, prevention and management of postpartum hemorrhage. I cannot belabor. We're all obstetricians. We do know what we should be doing. Unfortunately, are we really able to estimate blood loss? We still grapple with that, even despite having the V drape. Then we have the fetus. As I said earlier on, what happens in the mother carries on in the baby. So fetal alloimmunization, infections, vasa previa, structural abnormalities of the vascular system, we must all be cognizant of. Next. Communicable diseases, malaria, TB, HIV, and its related opportunistic infections. Poor water and sanitation. We still grapple with this in low middle income countries. Hemoglobinopathies, sickle cell, G6PD, coagulopathies, diseases such as Crohn's, celiac disease. These are things that we have. And increasingly, even having people who are undergoing gastric bypass surgeries. But I want to also remember obesity. What is really happening with the obese? We talked of undernourishment, but we also have a flurry of overnutrition that is not healthy. We have increased hepcidin levels, which mediated by chronic inflammation of obesity. And this has a negative regulatory effect on the intestinal iron absorption by blocking the iron carrier molecules into the cells. So we need to remember, obesity is not health. Next. Environmental toxins, very important, which are even coming up with disruption of the hormonal milieu. Malignancies, and particularly in our setup of LMICs, reproductive tract cancers and leukemias. A poor health system and poor clinical governance aggravating our situation, where little focus seems to be given to prevention and health promotion, and more is being given to care treatments and diagnostics, still questionable. Inappropriate correction of anemia, and I will allude to this later on. Then lack of gender empowerment. It's not enough, ladies and gentlemen, to take knee-jerk movements. We need to get beyond just the anemia of that day, but actually look at how you can change the ladies' social determinants. Next. So I have a conceptual framework. Please click it again and again. And I've said we have determinants, we have malnourishment, we have now pregnancy, all leading to anemia. Then compounded by the following, click, communicable diseases, non-communicable diseases. Please click the slide. Communicable diseases, non-communicable diseases, next. Click again and again. Right, so you have the compounding from both of those type of diseases, but above all, biomedical and behavioral issues, and then environment and climate change. We will never address anemia if we cannot look at the woman in this comprehensive outlay. Next. 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 Here I'm displaying what? A woman gets pregnant on the extreme left. She can be healthy, normal weight, appropriate gestational age, no problem. She can be malnourished. And in undernourishment, the risk of even eclampsia and type 1 diabetes exists. And you will find even in the baby, these disease entities carry on. If she's overnourished, again, obesity, overnutrition, type 2 diabetes, and on the extreme right, look at what happens to the baby. They are addedly increased of having a problem with adiposity, issues of fertility, metabolic syndrome, cardiovascular disease, and obesity. It becomes a vicious cycle. Right from in utero, you have the fetal programming that determines outcome of your child. Next, please. Next. Next. So let's move to prevention, promotion, and protection. The adolescent period becomes the next critical area. We begin to have pubertal changes and the onset of menstruation in the girl child. And this is what we've been advised to do, intermittent iron supplementation as a norm. School feeding programs have been put in place even to facilitate reduction of anemia, particularly in some low-income countries such as mine. But what happens when you now have anemia that's already diagnosed? That's a girl who should be having a daily dose provided to her. But does that really happen? And particularly when we are saying over 40% in prevalence must then get the therapeutic dose. I doubt if it happens in most of our LMICs. Most of us keep those drugs for when the woman is pregnant. And even if she's given them, or even if the girls are given them, depending on the type of preparation of the drug, in some cases you will even find they don't want to take it. It has a metallic taste, it's unpalatable, and adherence issues becomes a problem. All right, next, let's move to the next slide. So in the continuum of care, preconceptual care, it's an entity we know where you are supposedly giving comprehensive counseling, particularly on healthy eating and keeping physically active as you prepare for your pregnancy, or as you stop using the family planning method that you had been on. But how many come in for preconceptual care? The minority, not the majority. So you get to be pregnant in low middle income countries, but how many visits do you make? Comprehensive contact becomes the second layer of a problem. You probably find women will come for one visit. And even that one visit, do you dish out the hematinics to assist her? Do you do the antenatal profiling to actually get to know the magnitude of her problem? These are our real grappling issues. And do you also make her realize the importance of averting a maternal and neonatal and into childhood problem? Yes, we do give the hematinics, but I'm really beginning to ask very deep questions. Is iron enough? Vitamin C helps with the carrier molecule of iron being absorbed. Do we even think of giving that? Folic acid has got issues that relate to blood formation and even averting congenital anomalies. But are we even giving that iron and folic acid. And in our setup, where we have helminthiasis, communicable and non-communicable diseases as layers of problems, is it enough, or should we be giving micronutrient complexes? Next, please. Then comes the baby. Assuming you did not suffer from the direct causes and the indirect causes, you can see for all of us the vitamin loading that is actually being propagated from the mother to the baby. And we've even noticed from the epidemiology at the beginning, the problem doesn't seem to be really the first 6 months. It's from the 6th month when this baby begins to feed on its own, we begin to start seeing problems. Unfortunately, when you get mothers who get multiple pregnancies too soon, too often, too many, I don't believe that you have this vitamin environment that is supposed to be there for the baby. We need to have a rethink, even the inter-pregnancy interval and provision of family planning as part of management of anemia. Next. So I have put a care bundles with nutrition in focus. And most of us are now talking about reproductive, maternal, neonatal, child, and adolescent health plus nutrition. Click again. And this is what I have said. We cannot try as gynecologists to work alone. I've only alluded to what nutrition does, but we must remember there are other causes that may be giving anemia to this woman. And therefore, we must work with the hematologist. Be prepared, prevent, predict, recognize, investigate thoroughly, and respond. And even in the recovery and review, you must have long-term follow-up. Next. The hidden hunger. What do we have in place? And particularly in low middle income countries, what has been done? We have food base and we're asking for diverse diets. We're also asking for food fortification, and it is being done. Then you have supplements that are available, tablets, capsules. We've even heard about the injection this morning already. But I think public health measures, the communication piece on sanitation, environmental toxins, health education, and communication for behavioral change becomes the critical game changer. Next. I put this slide with deliberateness. In sub-Saharan Africa and most of LMICs, we still depend on blood. We do not have injectable iron. And when we do have injectable iron, it's unlikely to be in the public system, and the cost may also be prohibitory. So we still depend a lot on blood products, blood and blood products. But we have a declining supply. Many more people are declining to provide blood. We do not have national blood transfusion services everywhere. Policies related to transfusion may be wanting. Appropriate infrastructure may be missing. Trained personnel may also be missing. Financial resources to have this voluntary, non-remunerated donor transfusion service may be wanting. But we are more wary about infection propagation with allogenic blood. So we need to really rethink, particularly in sub-Saharan Africa, about the use of blood and blood products. But with every challenge, we also have solutions. Next. I will start with the program, which you can see a drone on the extreme right. This program began in Rwanda, where you want to take blood to the remotest end, where a woman has probably suffered from PPH or antepartum hemorrhage and is hypovolemic. But I think prevention and health promotion is better than cure. There is an urgent need to develop innovative ways to recruit and retain, where necessary, the voluntary blood donors. Innovations in delivery, I've alluded to that, but concerns about these adverse effects has made us rethink alternatives, which we all know. The correction of anemia using pharmacological medicines, And don't forget even the role of tranexamic acid. The use of erythropoietin, oral and intravenous iron to treat anemia, stem cell therapy. I think that's a potential that hasn't been exploited adequately. The use of non-pharmacological measures, where if you are undergoing an operation, then you may give autologous blood transfusion, perioperative red blood cell salvage, and normothermia to reduce blood loss in surgical patients. Next, please. But this slide may be a little bit busy, and I have alluded to the extreme left about the life course approach. But I think it is extremely important we move beyond that. We must begin to think about our role as gynecologists, even in the realm of agriculture, nutrition, and food security. The safety nets that we do have. And in this case, I want us to really focus on that who does not have. The last mile, the urban informal settlement, the rural population, people with other comorbidities. We must focus on those. Looking further on, are we engaging in programs in advocacy as institutions of obstetricians and gynecologists? Are we involved in curriculum review, particularly highlighting the relevance of nutrition, the relevance of environment degradation and climate change? We need to have a rethink because it does matter when it comes to anemia in pregnancy and beyond. Next. This is a slide and an issue that I think we also must think about, social justice. And we have an interrelationship of equity of services, access, participation of both us as clinicians and the community in whom we serve. It's not enough to just say, in my hospital, I have seen percent X of anemic patients. What are you doing about it within the communities? And to realize it is a right. We need to observe them as deserving to have it corrected. Social injustice provides for promoting supportive environments and diversity, closing the gap and reaching the very last mile. Next. Yes, we all do this. You hear there is starvation, there is drought, and we are so generous with offering the little goodies. But ladies and gentlemen, is this a permanent fix or a temporary fix? I want us to have a permanent solution. Next, please. And this is what I will say as my closing remark. Give a woman a hematinic and you feed only for a day. Teach a woman to grow healthy foods and eat right, and you feed her, her children, and her family for a lifetime and beyond. Next slide, please. I want to give you a special welcome to the Paris Congress on behalf of the FIGO leadership, which shall be held in October next year between the 9th and the 12th of October. Please save the date. You are most welcome. And we look forward to working even closer with you all. Thank you very much.
I think that was a wonderful deliberations on anemia, and we came to know that the parenteral iron is not available in countries, some countries still, because in India we have it amply available everywhere, and we are really happy about it that non-compliant patients, those who are intolerant to oral iron, we are really able to tackle the anemia quite efficiently. But it is sad in some countries still it is not available. Secondly, I wanted to ask you, I can see the passion in you, how much passionate you are about women's health and particularly anemia. I just wanted to ask you whether you think anemia also affects the immunity of women and it causes increased precipitations of several different types of infections. So
that
do
is
you
very
see that
true.
also in your part of world?
That is very true. In fact, it becomes a vicious cycle You are anemic, you therefore have hypoxic cells, more vulnerable to infections. Infections set in, or it can start as an infection. So where we have very high communicable disease prevalence rates, then you find there's the propensity to develop anemia and secondarily get even super infected with other bugs.
So the cycle continues.
Yes, yes.
Thank you so much. It was a wonderful lecture. There are a few questions in chat box. Niranjan, would you like to take them or make some comments on this lecture and appreciate?
Yes, for a change, I want to put on record that whenever Indians are traveling worldwide, the guide always says, please be on time. Believe it. We are changing. We are changing and we are before time. And that's the change we are bringing in education, in action, and to reach. And that's what is time around times. So I appreciate, madam, we are going on smoothly. There are few questions. I would like Suvarna to please address them and take the benefit of Dr. Ann Kiara, ma'am.
So shall I read the questions, Niranjan?
Yes.
Yes.
Okay, so I don't know whether they all are directed to Dr. Kiara or they are just general questions. Whatever you would like to take, Kiara, you can take. How to prevent anemia in first trimester is one question.
This is from Dr. Jyoti Shevgan from Aurangabad.
Yes.
I want to believe you cannot talk about preventing it in first trimester. You should have done that in the pre-conceptual period, because then you put the mother in a frame where she can ideally carry the pregnancy. Let's all remember, she's the incubator of a new being. But if you're already getting the new being, you already are at risk. Prepare. Planned pregnancies matter. Planned pregnancies matter. And this is where even family planning, we need to stop looking at it as just popping a pill or getting an injection. We need to actually look at the development and the effect it has when you do not have family planning. Too many babies, too soon, too often, unfortunately. High total fertility rate is still rampant in these same areas. Look at our population demographics. Sub-Saharan Africa, India, we have a very youthful population. How do we move them into viable, productive youth and adults into their reproductive career?
Absolutely. Very well said, Kiara. There's another question whether blood and injectable iron can be given in same sitting. Again, Dr. Geeta Sardar Singh Shevgan. She has asked this question.
I have limited knowledge with injectable iron. I clearly said in the public sector, we don't have it readily available. But from the theoretical framework, you do know, even with the injectable iron, the effect is not immediate. And imagine if I have a bleeding patient, you're having a HB being built up over 2 weeks. It doesn't help this woman who urgently needs an oxygen carrying molecule. So you do need to then have blood. So I want to presume, hypothetically, from my situation, yes, they can be administered together, but you've got to realize the HB change is what is critical, depending on what the patient does have.
Very true. Why some women getting repeated anemia even though treated with complete normal report? Dr. Sapna Naik. Shall we stop here?
We'll end it after this question.
I think other faculties can also answer the questions in the chat box so that we can save on time. But I think that it was wonderful to have you, Dr. Kiara, and very wonderfully covered this very topic, which is very close to my heart also. Thank you so much.
Thank you so much. I really appreciate. Thank you.
Thank you so much, Dr. Kiara. I know you have a flight back from Uganda to Kenya, and it's really amazing to catch up with you virtually, but if not physically. And it was such a wonderful experience for all Mumbai Obstetric Gynecological Society, rather the World Congress of Anemia. And I can see Anahita Chauhan, my next Vice President Suvarna, and the trustee being there from Mumbai Obstetric Gynec Society. And I'm sure hopefully by
Yes.
the end of this year or somewhere around next year, we will see you physically around in presence of our August members. And Mumbai is besides Arabian Sea, and it will be a wonderful weather to be there around and be catering to your hospitality. Thank you for being there, and I'm namaste. That's what I can say.
Namaste. Thank you for having me. I really appreciate it. Thank you.
Thank you so much.
Yeah.
Okay.
Thank you so much, Kihara ma'am. It was an absolute privilege to listen to you.
Thank you.
We'll move forward to our next session. Could I please have the slide up? Could I please have Anahita ma'am's slide? Oh, okay, sorry. This is a 20-second message from our sponsors. Yeah, so our next session is going to be done in association with Foxy. Our chairperson will be Dr. Anahita Chauhan, honorary consultant at Saifi and St. Elizabeth Hospitals, former professor and unit head at KEM Hospital in Mumbai, and the first vice president of the Mumbai OBGYN Society 2022-23. Thank you, ma'am, and I would love for you to introduce our speaker. Ma'am, you're on mute.
May I have Dr. Jayam Kannan's slide, please? Yeah. So, of course, Dr. Jayam Kannan is known to every Foxian, and it gives me great pleasure to introduce her for today's talk. She was the Foxy Adolescent Health Committee Chair in 2013. She has received the Best Award, Committee Award from Foxy. She's an emeritus professor in Tamil Nadu MGR Medical College and managing trustee of the Garbha Rakshaki Group of Institutions, and also the director of the GFC Fertility Center in Trichy as well as Chennai. She has, in the last 20 or 25 years, impressed all of us with her energy, her enthusiasm, and her never say die attitude. And I think this is why she is so passionate about anemia. She's so passionate about young girls and their causes. And we are looking forward to hearing from you, Dr. Jayam. So please, the court is all yours.
Thank you very much. Kindly allow me to share my screen. Yes. I'm very happy to see everybody pink, me also remaining pink. That is what is the talk. The strategies and ideas to be pink right from newborn to the graveyard. As Kara said, Annie said, the newborn is to be taken care of for the individuals. Very happy to say the anemia prevalence, which was in the 1980s, 70 to 80% in adolescent women of reproductive age, and in all these pregnant women, nearly 90%, and non-pregnant even at 60 years going on, is now reduced around 50%. Last year, in Nandita Parshekar period, they took a data from the IAS officers of Delhi. They found 52% of the IAS officers in the secretariat were found to be anemic. What else to talk about? Others is a question. This is a slide which all of us have read from third year of medicine, why iron deficiency anemia occurs. It is the failure to take in, the failure to get into the system, and the increased need and some diseases. Our focus is more and more on the decreased iron intake and the main this thing on the more demand. Our demand is more in pregnancy, heavy menstrual loss, and in areas where people regularly do blood donation also. There are three strategies mainly of iron deficiency. The first and foremost strategy is demonstrated by the serum ferritin level being low. If you want to be pink, this is the first level which has to be looked at it, which is not being done regularly unless you are doing a master checkup. The second one is the reduced blood cell formation. This is one which we know well the iron is required for the lead cell formation, carrier of oxygen. This is done only when we do a routine blood test. The third is the strategy in which we see all our women, instead of being pink, they are all white. That is the iron deficiency, anemia. Actually, in 2017, brought out a very nice article on blood reviews. Please, all of you should go through these articles about the newer insights into what is called iron deficiency and then iron deficiency anemia. The borderline difference between these two things have to be widened so that we don't see iron deficiency anemia, we catch them at iron deficiency itself. We all know he also has brought out the deficiencies can be taken up as a pathophysiological one, can be on the clinical data, can be on the rare inheritance disorders also, where there is iron resistant iron deficient anemia. Even if you give tons of iron, it may not be taken up well. That is because genetically they are iron resistant. These are the people who require regular blood support with blood transfusion. All the other things are known to the august audience who are saying this thing. Now, come to the diagnostic strategy for the pink level. Whenever you think the patient may be iron deficient, check the hemoglobin. Level is normal? No. If it is not normal, automatically it becomes anemia and get evaluated. Level is good. Still patient has got some sort of irritability, tiredness, another thing. Please go for the first stage. Catch the first stage with checking the ferritin. The ferritin level is not good, start giving ferritin. The ferritin level is good. That means she is not ferritin deficient iron or deficient anemia. That means there is some other problem which is there. Look at the other causes and low indeed. This is the diagnostic strategy which has been given by Kamasali. Then, what are the tests for iron deficiency? Is the hemoglobin checkup? Kindly understand it is the peripheral smear first. It shows the low molecular volume, low molecular hemoglobin concentration, and the large cell called the megaloblastic cell. All these low levels are by 30%, the cell increases by 50%. The next test is serum ferritin, which is being done in majority of the metros nowadays. Iron and iron binding capacities are done only in the hematological laboratories or in genitourinary units. Therapeutic response to treatment is one thing which every clinician can look into it. I have given iron for 3 months, but the patient is still the same 7 grams or 8 grams. That means don't suspect the patient has not taken the tablet first. Suspect yourself saying that you have not given the correct treatment for that patient because she requires some other treatment. Then go for the bone marrow, serum transferrin receptor mechanisms, and zinc protoporphyrin heme ratio, which are done in the hematological units. Now, coming to the treatment, if it is iron deficiency, anemia, if you have any chronic inflammatory factors, please go and treat them. If they don't have any of those factors like gastrointestinal problems or anything, that means she is not taking iron properly. Give her the oral iron. First drug of choice in the scenario, as Kamachali puts it, is oral iron. Just don't give iron for 60 days. Ask her to come after 60 days for a hemoglobin checkup. Please call her every week. And tender loving care in anemia is also important. Call her and ask her, are you okay, ma? Are you taking the tablets? Can I expect an improvement? This is what to be asked. First visit, she may not say anything. In the second visit, she may talk about her intolerance, which has to be tolerated by us very well, and we have to give her apt report. If she is continuing it properly, you are satisfied with your telephonic message, continue the drug and repeat the test after 3 months. Now, we have a pregnant woman, as the question has been asked. In the pregnant woman, now I take the first 4 gram hemoglobin, which we see in many of the government hospital setups. If you are seeing a 4 grams per DL hemoglobin, kindly look at the patient and try to give her a blood transfusion while you are checking the patient for other checkups, including hemoglobinopathy. Just because I'm checking hemoglobinopathy doesn't mean that I should not give her a blood transfusion. I should give. Especially she is in the first trimester, that is the treatment. If she is tolerant, if she says that I am not bothered, I am not having any vomiting, then we can think of giving her an iron tablet and then continue the treatment. If she is given the treatment and she goes on to the second trimester, now I look at the second stage of 7 grams hemoglobin. If she has 7 grams hemoglobin, is she in the first trimester, second or third trimester? If she is in the first trimester, I'll give the tablets, make her have the tender loving care, try to pass it on to the second stage. And the second trimester, if she is going to be less than 7 grams, I have to look at it, look at the ferritin level and see whether I can support her with the iron parenteral molecule, which has been extensively studied in India, east and west, south and north also, and we have accepted parenteral iron in pregnancy itself. If she is in the third trimester, less than 7 grams, look at it whether she's above 36 weeks or below 36 weeks. Above 36 weeks, there is no point in saying I'll give a iron parenterally and wait for it. Try to see if she requires blood transfusion, whether she can be delivered also. These are the two things which you have to look at it. If she is above 7 grams in the third, ferritin level, and giving iron and looking at her after delivery. I had a patient at 32 weeks, I put her on parenteral iron, and when she delivered, her hemoglobin 48 hours later went up to 11.4. The government nurse urgently called and asked, "Madam, how is she? I want to record it. I want to call her for giving her iron sucrose." I said, no, her hemoglobin is now 11.8. So the government staff were also very happy. So the private doctor should support the government system of this management and go on to it. If supposing she is not improving with the oral iron or parenteral iron, then look at her for other causes of the problem of anemia. Then the pink health with the diet and nutrition, which has been extensively talked by Annie, we have to maintain an ideal body weight. I am 120 kilogram and I am 8 grams hemoglobin. Yes, the fat will always look at it. And nutritional status in pregnancy and lactation is to be given appropriate importance. Birth weight of the baby also has to be ideal. We cannot afford to deliver a 2 kg baby and say that baby has to have a good iron. And right from infancy, childhood and adolescent, as I have been working in adolescent committee for 15 years, right, as from the coordinator to the chairpersonship, I love to see that adolescent have got 12 grams hemoglobin by 12 years of age and maintaining it for the 12 months always, unless they have any genetic potential. Deficiency diseases are to be prevented appropriately. Diet-related problems has to be tackled with the same tender loving care, talking to the adolescent girls, and also maintain an elderly like me and Anita. We also require iron appropriately and check up every 3 months also. Now, coming to the prophylactic iron and folic acid supplementation, which has the government of India has been time and talking about, even though throughout the world it is also talked about. We have to talk about the adolescent, 12, 12, 12, reproductive women, probably say the same 12, 30, 12, and pregnant women also, and it is a key to be taken up in all these years. Now, coming to the, what is this elemental iron and iron which we give in the milligram dosage? If you have 60 milligram elemental iron and 2.8 milligram of folic acid, which is required for prevention of anemia, you have to give 300 milligram of ferrous sulfate, 180 milligram of ferrous fumarate, and 500 milligram of ferrous gluconate. This is equivalent to that. And it also to be given correctly, as Annie said, everyday dosage. Weekly once at least in menstruating woman for 3 months. Then give a gap of 3 months. Check her again restart it. Probably once a week, this type of a tablet, every patient should be willing to take up, provided we keep a call on the phone with these people, and this has to be done for a social purpose very clearly. If you are given a parenteral iron, we know very well the globally accepted iron is being given. The route is parenteral IV, 1000 milligram in 250 ml of normal saline, in spread over 1 hour. You can give a test dose for 10 to 15 ml and wait. Side effects and these things, allergies have not been notified. I am a sponge administrator of parental line right from 2007 in all my patients. At the same time, we have the other gadgets to be added like deworming, intensive checkup, behavioral checkup also, body maintenance, smart mind also is required. If you are going with a delivery, do not rush to clamp the cord. Allow the cord to stop pulsation, and always treat an anemia with focus on school-going children around the age of 12 years. And the component which I talked about is the ferrous one that has to be given, and the mean hemoglobin level by giving a ferrous and ferric is done here. The ferrous always is in the blue one, shows a very high response. The ferric is in the red one, not near to pink, it is a red one. And it will not go anywhere near the pink one as compared to this one. Madam Anita has promptly come in the pink saree, whereas I have come in the blue saree. So if you give ferrous, you will be like me. And if you are giving ferric, you will be like Anita, madam. Ferric ascorbate is also given. Ferrous ascorbate and ferric is also given. However, we know well that ferrous is the one which is more important. Ferric Fe3 is always the one which is little less absorbed and takes a more longer route way to get the anemia status maintained. So, to summarize, anemia is a global concern. It has a good impact on all the people, more so in women. 50% of the women in reproductive age have poor iron, which has come down. A good chance to make it down to 20%. Residual supplies and others are a risk of anemia are to be looked at before they conceive. Pre-conception is required. Universal supplementation in all pregnant women, even if their hemoglobin is 12 grams, is required. Ferrous form is preferred over ferric forms. Ferrous has the advantage of being well absorbed due to its ascorbate molecule, which Annie was talking about, add vitamin C. So the ascorbate molecule is also very, very important. I hope I have done justice to the CP, to Anita madam. Grow more like Anita madam, and probably if you are with ferrous, take this and become blue. Thank you very much for your patient hearing.
Thank you, Dr. Jayam. I think it was excellent because you literally flowed from what Dr. Ann Kihara said into the next topic, and you did full justice to the topic. I don't think there are any questions, but I just wanted to ask you that if you are giving IV iron, would you prefer sucrose or FCM?
Earlier, before 2018, I was giving sucrose.
Right.
But now I have shifted to FCM. Still, Tamil Nadu government of India is continuing with sucrose. Any person coming with less than 9 grams hemoglobin, the nurse has to have given iron sucrose. Otherwise, she is being suspended from her job. So they hurry up and catch on the neck of the patient to get the hemoglobin level 9.5 at least, so that they get the next month's salary. So in government setup, it is still sucrose. In private setup, like patient like mine, we are giving FCM.
Right.
Thank you. Thank you.
Thank you.
Thank you.
Ma'am, we have another question. What would you say are the indications for giving erythropoietin?
Yes, erythropoietin is the one which is a measure whether the dose that you are giving as a therapeutic dose is really working on the patient. We have started iron, and if you have the facility to do the erythropoietin level after 10 days, if you see the pre-reticulocyte and the post-reticulocyte and erythropoietin level, post level is high, that means your patient is catching up with the iron you give. Otherwise, your iron is not being caught up with the patient. Either she is not taking the tablet, if you are given parenteral, it is not working on her, or the patient has got iron-resistant iron deficiency anemia. This erythropoietin becomes very, very important in patients who are being substituted in renal pathology. Thank you.
So renal cases and older patients who don't really have that much of bone marrow or other liver, spleen, which is working so well, erythropoietin may help in there.
Thank you. Thank you.
Thank you.
Thank you. Thank you.
Niranjan, would you like to say something?
Yes, Dr. Jayam ma'am, what can I say about you? And it's amazing the strategies and the ideation, what you have said to keep women in pink of health is the most important thing what Foxy is doing. And today, myself and Jayam and other dignitaries of Foxy, along with Suvarna, under the leadership of Dr. Shanta Kumari, our president, and the Secretary General, Dr. Madhuri Patel, are doing efforts for eradication and prevention of anemia in our society. And that's what the message you have given, madam, to be doing this wonderful efforts. And I especially thank you, in spite of your busy schedule, you have given this opportunity to us to interact at the World Congress of Anemia, and it's a great pleasure to have you today. Thank you so much, ma'am.
Zubin, over to you.
Yeah. Thank you so much, sir. And thank you so much, ma'am. That was a wonderful talk. We'll move forward to our next session. And this session is done in association with SAFOG. Our chairperson is Dr. Rajendra Sangpal.
Yes.
Yeah. He's the secretary of MOGS currently and an honorable member of the European Society of Gynecological Endoscopy, as well as the chairman of the International Academic Exchange Committee of Foxy 2016 to 2019. Thank you so much, sir. I would love for you to introduce our next speaker.
Yeah, thank you, Zubin. Wonderful. At the outset, I really want to congratulate MOGS and the president, Dr. Niranjan Chavan, for bringing the world together for World Congress of Anemia. It is really my pleasure to introduce my teacher, Dr. Shyam Desai. He is more than a teacher to me, and his illustrious career, and I could see his, I just want to highlight few points. He is a chairman and board of trustee of Mumbai Obstetrics and Gynecological Society, president-elect of SAFOG 2023 to 25, and he is at present a consultant obstetrician and endoscopic surgeon at Hinduja Hospital and Nanavati Hospital, past president of our illustrious organizations such as MOGS, Foxy, IAG, vice chairman of ICOG, and he is been a well-known teacher and well-known endoscopic surgeon for his pioneer endoscopic surgeon in India, and a teacher for more than 30 years, and he was honorary professor at Wadia Hospital for more than 25 years. And he's also consultant at various hospitals, including Hinduja and Port Trust Hospital till date. So over to you, sir, for your lecture. Thank you.
I have not been able to start my video. So they'll have to enable me to start my transmission.
Yes. Zubin, can you help?
Yeah, support. Welcome, sir. It's a pleasure to have you, and you're doing a wonderful job guiding the Mumbai Obstetric Gynec Society as the managing trustee, and of course, as a president-elect, we look forward for your SAFOG tenure, which will be from the next year. I would request Mr. Subbu to please go ahead with sir's presentation from your side, and sir would be speaking from his own presentation. And thank you, Rajendra, for joining, and it's a wonderful pleasure to be associated with you. We are doing a wonderful job, and I'm sure everyone is going to enjoy it.
Yeah, so in fact, I'll try and relate myself. Can I do that?
Yes, sir.
Okay.
Please. Thank you.
But it's coming over here you cannot share the screen while the other participant is sharing. So Subbu will have to.
So you can try it again now, sir. It is enabled.
Okay.
I would request session, if you can share, then that should be fine and sir would be comfortable with it. It's okay.
Okay, I think sir has got it.
Oh, that's great.
Yeah.
Yeah. ID, yes.
Great.
You need to do a full screen. Zubin, please guide sir. Thank you.
Yeah, I think sir has got it.
Okay. So can you all see the slides?
We need to have a full screen,
Yeah.
sir.
So could you go into slideshow mode?
Okay.
Play mode.
Yeah.
Okay. But now what happens is that I see the photographs on the right side, so I don't see the entire slide. Anyway, it doesn't matter. I'll manage. It's okay. All right. Now, first of all, I'd like to thank the Mumbai OBGYN Society, Dr. Niranjan Chavan in particular, Dr. Sangpal, Dr. Anaita Chavan, the Vice President, and all the other office bearers who have done a tremendous job, not only over the last 2 years, but even now the entire efforts of the MOGS have been exemplary. I'd also like to thank the sponsors for this particular program and all the foreign participants who have participated in this very, very important topic of anemia in women of all over the world. And in particular, I'm going to be speaking on the South Asian women. Now, I would like to just remind you that anemia is one of the most prevalent diseases. There's no other disease that is as common as anemia. Almost every second person in these developing countries has a hemoglobin which is less than ideal. And it has been said that the ideal hemoglobin should be 12 grams. But even in our country, in our South Asian region, you would consider even a patient with a hemoglobin of 11 grams as being adequate. But we must not have any patient with a hemoglobin of 11 grams or less in our population ideally. But still, with all our efforts over these years, it is found that the prevalence rate of anemia in pregnancy is almost 50%, around 47%. Not only is the anemia prevalent in pregnant women, but these pregnant women, when they give rise to children, you find that 7 out of 10 children aged between 6 months and 59 months in India are anemic. Why? Because they've got such low iron stores that have been transferred to them during the pregnancy. Approximately 3% of children are severely anemic, 40% are moderately anemic, and about 26% are mildly anemic. So you can understand that right from the word go, these children are having a deficit in the hemoglobin concentration. Now, this is a pictorial map showing the prevalence of anemia. And you can see that the regions in the blue color are all developed countries where anemia is not at all a problem. But the moment you go to Africa and you come to South Asia, you can see the difference in the prevalence of anemia. In India, Pakistan, Bangladesh, Nepal, we have a problem where the hemoglobin is very, very inadequate. Similarly, in Africa, you can see the countries, the ones with the darker red are the ones which have a more major problem. The ones with that orange color are the ones which have anemia, but not to such an extent. But you see in the South Asian region, because I'm going to be concentrating mainly on the South Asian region today, you find that even though India, Pakistan, Nepal, Bangladesh have a problem with anemia, see Sri Lanka. And Sri Lanka has a situation where they have a better antenatal care being afforded to the pregnant women. And as a result, they probably make sure that they take their iron doses as soon as it is necessary. As soon as pregnancy is diagnosed, maybe they must be starting them on vitamins and low dose iron. And as a result, when they reach term, you find that many of them are already in a hemoglobin range of around 10 to 11 grams. Now, this is another bar diagram, and it tells us the incidence of severe anemia, moderate anemia, mild anemia in our developing region. And over here, we have, besides India, the Maldives, Nepal, Bangladesh, we have some other countries which have also been listed, such as Cambodia and Myanmar. But for our SAFOG region, we would consider that India, the Maldives, Nepal, and Bangladesh are represented over here. And we see the incidence of severe anemia. And fortunately, in all these countries, there is an incidence of severe anemia, but it is not that common. The more common anemia is where there is moderate anemia or mild anemia. So moderate anemia is listed designated as in the yellow bar, whereas mild anemia is the blue bar. So therefore, we see that in all these countries, more or less, there's a similar incidence of anemia. And many of these women could have been treated a little earlier, a little better, so that when they become pregnant, at least, they have an adequate hemoglobin. So the incidence in various age groups is listed in this. So we have Afghanistan, we have Nepal, we have Pakistan, India, Bhutan, and Bangladesh. And you find that the incidence in the various age groups, the blue is for children, the red is for women, and in general, not pregnant, and the green is for pregnant women. So you find that the incidence is definitely high in our country as far as pregnant women and children are concerned. So therefore, one has to take remedial steps. And we know what these remedial steps are. So we'll go over very quickly to those remedial measures. Now, when you consider various symptoms and signs of anemia, besides doing the actual hematocrit, you find that the patient would be having a lot of weakness, getting fatigued very often. She would have shortness of breath. She walks 10 steps, she feels breathless. When you examine her, she has a little tachycardia. She has a slightly lower than normal blood pressure. So why do these women in India have a low hemoglobin? One is because of malnutrition. Many of the women, almost 60-70% of women, do not have 2 square meals of food every day. Many of them are not given iron in their adolescence or in the childbearing period, because even though they have heavy menses, they may not be able to sustain that blood loss. Second is that many of these women have intestinal pathogens, and these worms can cause a reduction in the hemoglobin level by causing blood loss. And sometimes there may be some intestinal problems which prevent the absorption of iron and the various ingredients that go along with it to make up the hemoglobin. So therefore, malnutrition, poor poor medical care, less of antenatal care in some of these women in the rural areas, all contribute to a situation where the hemoglobin in pregnancy is less than ideal. Now, one must remember that most of the transmission to the fetus from the pregnant mother happens in the last 3 months of pregnancy. So therefore, the maximum of iron absorption is in the mother in the 3rd trimester. Now, if maternal iron is low, the number of placental transferrin receptors increases so that more iron is taken up by the placenta. Maternal stores being low also results in poor fetal stores, which can cause adverse consequences in infant development. Hence, a routine administration of iron is advocated, and this was published in the American Journal of Clinical Nutrition in the year 2000. Now, when you have a patient who is pregnant and she's anemic, she has a hemoglobin of 6 grams, 7 grams, and we see many of these even in our general hospitals in Parel and in Sion, where you have patients coming with a hemoglobin of 4 grams. And many of these patients cannot withstand labor, and as soon as they deliver, if they have even mild PPH, they go into shock. Now, these pregnant women are also at a risk of undergoing premature delivery, and many of the babies are a little low in birth weight, and the patient herself may undergo a postpartum depression. So there's an association between the presence of anemia and admission and delivery and adverse perinatal outcomes. So we find that a patient who is anemic would have an incidence of cesarean section in about 44% as compared to the non-anemic, which is 36%. A premature rupture of membranes, again, is 2.4% versus 1.6%. Preterm births, 2.7% against 1.27%. Very low birth weight babies, the incidence is almost double. Meconium staining, incidence is fortunately a little less in this particular study. And the NICU transfer is much more common when the patient is anemic. So this has already been spoken to by Dr. Jayam Kannan, as well as the PIGO president-elect. But just to quickly go over it, about 1,000 milligrams of iron is required to meet the iron requirements of the mother and the fetus. And I said it's mainly in the last trimester that this absorption takes place, and therefore one must cover her up with iron at this stage. So the dietary iron absorption is reduced during the first trimester, and therefore it's not mandatory that we give iron in the first trimester. Second and third trimesters are more important. So more or less 120 milligrams of elemental iron daily should be administered. So in areas where anemia prevalence is less than 20%, it is recommended that women take 60 milligrams of elemental iron daily. And these schedules should raise the hemoglobin to at least 11 grams per cent. Folic acid supplements of at least 250 micrograms should be also given according to the WHO criteria. So despite various government initiatives, anemia is still one of the top endemic problems in India. 1 out of every 3 pregnant women have hemoglobin of less than 10 grams. And 20% of maternal deaths are indirectly caused by anemia. So it could be postpartum hemorrhage with anemia, it could be toxemia of pregnancy with anemia, but anemia is the underlying cause. So how can we address iron deficiency? We can address iron deficiency by approaching the food management, supplementation, tablets, capsules, syrup, etc., public health measures, and that includes health education, community treatment, community education, improving sanitation and hygiene. Make sure that you treat the worms, deworm the patient. Then add foods with high micronutrient content. Methods like germination, fermentation, etc. would increase the nutrition value of the food. And then we can also now try and increase the content of iron in the various vehicles that are given to the patient. That is the food vehicles, which is flour, milk, salt, sugar, condiments, bread, and biscuits. And for example, like how we tackled hypothyroidism by adding iodine to salt, we can also supplement iron in the various types of foods. So what has India done as far as tracking anemia goes? And India is the country that all the other countries look up to, because we have, it's a much bigger country. There's a better government at the center. There are people who are looking after pregnant women and the general population all over the country. There are certain pockets which require further assistance. But if you go to Tamil Nadu and you go to Kerala and you go to Karnataka, Maharashtra, Gujarat, you'd find that healthcare is at quite a good level. With some of these other states, we find that it could be improved to a very large extent. So the first program that was launched was in 1972, and India was the first country to have a national program. So we called it the National Nutrition Anemia Prophylaxis Program. So the beneficiaries included pregnant and lactating women 1 to 5 and children between 1 to 5 years. It was revamped as the National Anemia Control Program. And this screened all pregnant women for anemia and provided appropriate doses of iron. The National Anemia Control Program became part of the RCH program in 1997. Now, we also have the National Iron Plus Initiative of 2013 to bring to attention of program managers to the serious negative consequences of anemia, and preventive strategy to lay out iron folic acid supplementation throughout the life cycle. The curative strategy is to define the minimum standard of treatment protocol for facility-based management of anemia. So therefore, to bring about all these services under one particular heading, we had this anemia control program, the National Iron Plus program, which was again targeting school children from the 1st to the 5th grade in school, and adolescent girls between 10 years and 19 years, and supplement for pregnant and lactating women. So the treatment of iron deficiency anemia has been very aptly explained by Dr. Jayam Kannan, where we can first give oral iron supplementation, preferably ferrous, because it is better absorbed as compared to ferric. So you have the sulfate, the ascorbate, the fumarate, and you have vitamin C added, and you have a few of these, the other hemopoietic factors added, folic acid. It helps in the development of good hemoglobin. And of course, if the patient is having a very high or rather low hemoglobin, then they can be given iron dextran, sucrose, iron sorbitol, iron carboxymaltose. So therefore, if you first initially start with oral medication, if she doesn't tolerate it or is not responsible enough, as we said that some women do not take the tablets themselves, but give it to the children. So then you can tell them to, if the hemoglobin does not rise with the oral medication, put them on. Otherwise, oral iron is the first line of medical therapy, as it is a cost-effective strategy to restore iron balance. So the various classes of iron salts could be inorganic, such as ferrous sulfate, ferrous fumarate, ferric ammonium citrate; organic, such as ferric polymaltose; the elemental iron, that is carbonyl iron. We used to use a lot of it at one time. Now we don't use so much. And we have the chelated iron, bisglycinate, and ascorbate, that is with ascorbic acid. So ferrous ascorbate shows a good bioavailability by virtue of its ascorbic acid molecules, and reduces ferric iron into ferrous iron, making it get absorbed as 3 times as much as other compounds. So iron deficiency anemia in early pregnancy should be treated with ferrous ascorbate for the fast rise in hemoglobin. And once it goes up to about 10 to 11 grams, it should be then a maintenance dose that is offered to the patients. Now there's a new delivery system of giving iron, and that is encapsulation of the drug in liposomes. So by putting it in liposomes, you bypass the gastric acid barrier, and these liposomes coated molecules then get into the intestinal tract, and as a result, you have a clinical efficacy increase in hemoglobin by 2.1 to 22 grams per cent. Now, because of the liposomals, the iron is better tolerated. There are very few dropouts, and symptoms of anemia markedly decrease as the hemoglobin increases. A significant increase in hematocrit is seen in these patients. So the bioavailability of a drug, you say is to be judged by the amount of the hemoglobin increase, and we find that as compared to ferrous fumarate, we find that this liposomal iron has a much better acceptance. Now we come to FCM, and that is what we were talking. I think even Dr. Jayam was questioned about this. Would you give iron sucrose or would you give iron FCM? Earlier, it used to be iron sucrose that we used to give because that was available. It was intravenously administered. But now with FCM being made available, we find that it is more effective. And the dosage is approximately 1,000 milligrams to 1,200 milligrams. Now, so therefore, if you have to give injectable iron, then FCM has a much better safety and acceptance and effectiveness as compared to iron sucrose. Now, no longer do we give this iron dextran combination because that could sometimes cause reactions. Now, if you compare the two, FCM and iron sucrose, Ambeli Jose et al. Gave a median rise in hemoglobin of FCM significantly higher over a 12-week period. And the number of doses also is much less, maybe 1 or 2 doses maximum. So the Anemia Mukt guidelines of 2018 the management protocol for pregnant women. If a patient comes with mild anemia, hemoglobin 10 to 11 grams, and moderate, that is 7.9 to 9 grams, the first line of treatment is to put them on oral iron, along with folic acid, and folic acid every day for 6 months. And if she comes in the late pregnancy, then you go straight to injectable, so either IV sucrose or ferric carboxymaltose. If there's no response, maybe she has a refractory anemia, and refer her to a higher center. Now, in case the patient has severe anemia, that is hemoglobin less than 7 grams, you hospitalize these patients. Give them IV sucrose or FCM, and if the patient is very close to term, then maybe you might even want to think of giving a blood transfusion. So this is more or less the way in which we can tackle anemia on a war footing in our SAFOG region, because it is important that we have a patient who comes or goes into labor without hemoglobin of around 10 to 11 grams. Because remember, the maternal mortality, if it has to be reduced, we must have a patient who has an adequate hemoglobin so she can withstand the mild PPH that she may have to undergo. Besides, for the sake of the baby, for the sake of the adolescent, it is better that the mother has a good hemoglobin so that she passes on the iron stores to the baby. Eventually, we have to look at the broader picture. And when we have these captive women called the antenatal patients under our care, make the best use of that time and make sure that you adequately give them iron so their stores are replenished, not only for this pregnancy, but maybe for another pregnancy also in a year or two time. Thank you so much, Dr. Rajendra. It was a pleasure being able to speak with your chairmanship.
Am I audible, Zubin? Yeah.
Yes, sir, you are.
Sir, thank you so much for really doing justice to this particular talk of yours from the SAFOG side. And I must appreciate what you have elaborated about the various ways how we can tackle the anemia, the daily needs and requirements, and the various preparations and the ways of combating anemia in children as well as in mother, and the newer molecules such as ferrous ascorbate having, high efficiency in the beginning to tackle the anemia in the form of oral iron therapy, the newer delivery systems such as liposomal, coated molecules, and also you have elaborated about the ferrous carboxymaltose and its effectivity. Thank you so much for enlightening us. Are there any questions?
We have one question. Dr. Ankit,
any indication for giving erythropoietin?
No, sir, that's from the previous one. The question here is any adverse effect of FCM in the fetus?
Yeah, sir, is there any adverse effect of ferrous carboxymaltose in fetus?
I have not come across any such particular adverse effects. Has anything been seen in literature?
No, not really.
Not that I know of.
One more question is that
very well tolerated, and they said that there are no adverse effects in the mother also.
Yes, and sir, in your practice, clinical practice, have you come across with sudden reactions, adverse reactions when you are giving ferrous carboxymaltose?
No, fortunately, no. But with sucrose, I had IV sucrose we used to give, and we had some patients who are little, got a little reaction to it, and their blood pressure dropped. But with FCM, I have not had any problems.
Oh, okay. Thank you, sir.
Okay.
Really, thank you for being here on this platform and giving your valuable time.
Thank you, Niranjan.
Niranjan, would you like to comment?
Thank you so much, Dr. Shyam Desai, sir. It was a wonderful overview which you have given regarding the women to be treated in Southeast Asia, and especially I like the map which shows that India and African countries are really affected, and the efforts which has been taken by you and the Sri Lankan, our present president Dr. Rohana Hatatua has done a wonderful job, and I'm sure by next year we will help to reduce the incidence and prevalence of anemia in our Southeast Asian countries. Thank you, Rajendra. It was a wonderful efforts by you also to be present today. And of course, they're all our teachers, and we are so lucky that after 3 decades we are still having them with us to guide us all the time. And thank you so much, all of you. Now we go ahead and I hand over the mic to Zubin.
Thank you so much, sir. We really enjoyed the talk. We'll move forward to our next session.
Thank you.
Thank you so much, sir. Our next session is in association with the FOXI Medical Disorders in Pregnancy. And our chairperson is Dr. Rajendra Nagarkati. He's the Joint Clinical Secretary of MOGS, the chairperson of the FOXI Midlife Management Committee, and the chairperson of the AMOGS Midlife Management Committee. Thank you so much, sir. I'd love for you to introduce our next speaker.
Thank you, Dr. Zubin, for the kind introduction. And at the outset, I wish to thank Dr. Niranjan Chavan and the team MOGS this year for inviting me here to this wonderful conference on this so very important topic of anemia. We all know that we all agree, being obstetricians, hardcore obstetricians, that anemia, correction of anemia is so very important to prevent complications in pregnancy, both to the mother and to the fetus. And these can be corrected if we correct the anemia right in advance or right in the beginning. Right from the fetal growth, right up to the points of maternal complications, anemia plays a role. And the title also for today's topic is very aptly given, Fuel for Complications. Anemia is the fuel for complications. And who better than Dr. Komal Chavan, currently chairperson of the FOXI Medical Disorders Committee, to speak on this topic. So it's my proud privilege and honor to introduce my dear friend, Dr. Komal Chavan, who is the medical director of the Chavan Maternity and Nursing Home. She's an honorary professor at the R.N. Cooper Hospital and the HBT Medical College. As I said, currently chairperson of the FOXI Medical Disorders in Pregnancy Committee, a member of the Managing Council of MOGS, member of the Managing Committee of AFG. Recently, she's been elected as the Premises Secretary of the AFG. She's a joint secretary along with me as secretary of the ISOPAP Mumbai chapter, and a big hard worker for the ISOPAP Mumbai chapter. She's assistant honorary Dr. R.N. Cooper Hospital, editor of psychological issues in obstetrics and gynecology. She's won numerous awards. I would say she's one of the most sincere, hardworking and dedicated FOXians that I've seen. And it's a pleasure to be here as chairperson for her talk. She's also recently got the privilege of being in the Guinness Book of Records for anemia, for eradication of anemia, for the Anemia Mukt Bharat campaign. So it's over to you, Dr. Komal.
Thank you so much, Dr. Rajendra Nagarkati. This was really a kind and generous introduction. And at the outset, I would like to thank the organizers of WCA, Dr. Niranjan Chavan and team, everybody who have actually jot down such good topics, really good topics, and the galaxy of speakers from all over the globe. And when we talk about anemia, so much is spoken, but we feel that we still have to do so much. We have been doing social campaign as a part of FOXI Medical Disorders in Pregnancy Committee. In my tenure, we did anemia conclave, we did mass awareness programs, we did even pledges, everything. But still we have so much of burden. And when we talk about medical disorders in pregnancy, we know that anemia goes hand in hand, or there is an underlying anemia all the time. And this was a very nice quote by Mia Hamm. I'm building a fire, and every day I train, I add more fuel. At just the right moment, I light the match. So anemia is just like building. There is an anemia which is pre-existing. A person will get pregnant. Pregnancy will add more fuel to that anemia. And just at the right moment, maybe intrapartum or near term, we really have a disastrous complication pertaining to anemia. So anemia is a major public health problem. It has been a problem more concern for the developing countries. Commonest medical disorders in pregnancy, responsible for significant high maternal and fetal morbidity. And almost 40% of maternal deaths occur in third world countries. Either there is an indirect or direct maternal death. So according to the WHO report 2016, the global prevalence of anemia among pregnant women is 40.1. And in India, the prevalence of anemia has been reported as the range of 33 to 89%. But we see that there is a marginal decrease in the prevalence from 58 to 50%, that as per the NHFS 4, that is in 2015 and 16. And we really feel 50% is also real great prevalence, and we need to do our efforts to decrease that. So when we talk about maternal anemia, we talk about mainly iron deficiency anemia. An estimated death with iron deficiency anemia is approximately almost 326,000, with associated disability adjusted life years up to 12 million. So this is something that it is not only it is impacting the mothers, but it is going to have an overall impact towards the entire quality of life. This is a part of an Indian study, and when there was an analysis done of the cause of maternal death and contribution of iron deficiency anemia, where they found that death associated with IDA were almost 22%. We can see the other how contributing factors are, and anemia is the major chunk of death. Anemia contributes either directly, indirectly by causing solely because of anemia, and most prominently is that anemic patients have a significant amount of postpartum hemorrhage. Also, an Indian study quoted that when we have a study of the near miss cases, hemorrhage was a leading cause, but severe anemia was a second leading cause. So we know where we are standing. We are trying to improve the maternal outcome, but we still have anemia as the leading cause, and which is actually the preventable cause. So we need to definitely prevent this mortality by having a high sensitivity, screening patients, everything. So we need not to miss any of our patients in obstetrics. So the FOXY GCPR classification clearly states that in the first and the third trimester, the hemoglobin of 11 or higher is considered normal. Thereafter, it is mild and moderate between 7 to 9, and lower than 7 is severe. But in second trimester, 10.5 or higher is considered to be normal. So this is the cutoff which we should keep maintaining of our pregnant women when they come in pregnancy. And a very severe anemia category is added by ICMR, that is hemoglobin count less than 4. And in postpartum period, if the hemoglobin falls below 10, it is again considered as anemia. So types of anemia, as we said, IDA is the most common, 90%, but there are other deficiencies like folic acid deficiency anemia, 5 to 10%, B12 anemia, dimorphic anemia, and also the hemoglobinopathies like thalassemia and sickle cell, which are seen in certain tribes in India. Nutritional anemia, common chunk is always mixed. It can be vitamin, mineral, protein deficiency. So nutritional deficiency is a mixed type of anemia, which is very prevalent in Indian population. So what are the factors which are aggravating? I think much has been discussed, but when it comes to pregnancy per se, it is the poor nutritional intake. What happens is that in pregnancy, there are certain food fats, increased demand of pregnancy is not taken care of. There is already an existing anemia because of multiparity, poor spacing, teenage pregnancies, chronic infections, chronic malaria, bleeding piles, menorrhagia, hookworm infestation. All these and the lack of antenatal care, this can be the factors which aggravate in pregnancy. And what happens? More important is we need to know what are the effects on pregnancy on the existing anemia. This anemia further gets aggravated by onset of pregnancy. As the body demand increases, essential nutrients also have to be provided for the fetus. There is an increased metabolism, also enhancement of maternal circulating blood volume. The digestion also becomes very poor. Lactation after delivery, the lactation also has a further drain on the maternal resources. And if there is a postpartum blood loss, even a slightest amount, it will definitely aggravate the maternal anemia. So how will the patient present? We have an anemic patient. Classically, we know weakness, lassitude, dizziness, breathlessness, swelling, left cramps, palpitation, all the generalized weakness and all complaints the patient will come. And we will definitely find pallor, nutritional deficiency anemia, will have glossitis, stomatitis. On systemic examination, there could be murmurs, tachycardia, even crepitations. And so we need to identify as early and pick up the slightest side, the mild anemia needs to be picked up by a thorough examination. So when we talk about the complication, what happens in the late third trimester? That is, there is high incidence of pregnancy complication as PIH, abruptio placentae is more common with megaloblastic anemia, preterm labor, and even PPROA. Anemic patients are more predisposed to infection. They may be preterm predisposed to urinary tract infections, respiratory tract infections throughout the pregnancy. So they require extra care. There is a reduced resistance to infection because there is impaired cell-mediated immunity. And even a slight strain, even an uncomplicated labor may be predisposed to failure. So we need to be very, very precautious when the patient is approaching the third trimester. So this is actually some studies which are showing that how anemia and other medical disorders are related. The trophoblastic, this was a study done of the trophoblastic invasion and apoptosis in the placental bed for pregnancies complicated with maternal anemia, and they found a relationship between the early onset preeclampsia and intrauterine growth restriction. And that was because the spiral arterial movement was increased in anemia, and even the trophoblastic apoptosis was increased, and that led to preeclampsia as well as intrauterine growth restriction. So we need to know that this all is related. And also there was a study in BMC Journal August 2011, the severe anemia was associated with higher risk of preeclampsia and poor perinatal outcome. The greater the severity of the anemia during pregnancy, the greater the risk of preeclampsia, preterm delivery, low birth weight, and stillbirth. So we need to have preventive measures to be taken to decrease the prevalence of anemia in pregnancy. And this was a comparison of severe anemia as well as sickle cell disease and thalassemia. All the other hemoglobinopathies also they compared. And this was a World Health Organization global survey. And when this was analyzed for the relation of gestational hypertension and preeclampsia and eclampsia, they concluded that severe anemia appears to be the greater risk for preeclampsia, eclampsia, while sickle cell disease appears to be the risk factors for gestational hypertension among women seeking hospital care, and this was in the developing countries. So we need to know that definitely these are in the back of the mind, but when the labor sets in, we are more worried about the adverse maternal and perinatal outcome. And why? Because there is increased risk of PPH, which we discussed. Also, there are chances of instrumental delivery because there is maternal exhaustion. The mother may not be able to bear down. There can be a congestive cardiac failure also predisposed in the third stage, and the fetus may get distressed, and that all leads add-ons to the goal of increasing the morbidity and mortality, both mother and the baby. The postpartum period is also not escaped because we feel that if the PPH primary has gone, there can be even a secondary PPH, sub-involution of uterus, that can be prone to infections like delayed wound healing, episiotomy gaps, puerperal sepsis, lactational failure, poor bonding of mother and child, because there is a reduced enjoyment, the patient is totally fatigued, and as the result of that, there can be chances of postpartum depression. So we know the toll is going to go on and on. And the most critical phase in the pregnancy is in the labor. That is during the labor when there is going to be increased cardiac load immediately after the delivery, early puerperium, and the chances of a congestive heart failure and pulmonary edema are really, really high. And the maternal mortality, which is the most end-stage and the dreadful thing, can be commonly caused because of the heart failure or cerebral anoxia, sepsis, or thromboembolism. What about the fetus? I think there was a question also. So the fetus, the anemia on fetus and the neonate is also that definitely we have a preterm IUGR fetus. There can be chances of intrauterine fetal death, congenital malformation like fetal neural tube defects associated with folic acid deficiency like megaloblastic anemia, even low Apgar score at birth. And neonates are more susceptible for anemia infections. So this definitely the anemic infant will have a cognitive and affective dysfunction later life. And what about the mother? If the mother is anemic, will the fetus will be anemic? What happens is that the fetus is actually protected from the effects of iron deficiency by upregulation of placental iron transport. But what happens in the infant age, like after the first 3 months, the incidence of risk of iron deficiency starts increasing. And because of the poor iron storage in infant, as per the Baker's hypothesis, this infant born to the anemic mothers will remain to be anemic. You know, they will be anemic infants, then they will become an anemic adolescent, and that adolescent will enter the pregnancy with anemia, and the anemia will be pre-existing pregnancy, it will worsen with pregnancy, and again that anemic mother will deliver a baby who will again have an anemia. So this is like a transgenerational effect of the anemia, which is going to go on and on the cycle, and we need to really break it. This was during the COVID, because we are in the COVID, so many things. Even the anemic patients were having a severe inflammatory response as compared to the normal thing, and even the organ injuries we said in COVID was going hand in hand with the severity of the anemia. So to summarize, anemia does add fuels to all stages of pregnancy, with the antepartum increasing the preterm delivery, PPROM, preeclampsia, intrauterine death, infections, hemorrhage, CCF, intrapartum prolonged labor, increased rate of operative delivery and induced labor, fetal distress, abruption. Postpartum, we just discussed like PPH and lactational failure, embolism, subinvolution, and postpartum depression, and fetal complication right from the low birth weight to congenital malformation, infection, and cognitive development is hampered, and also increased risk of schizophrenia is seen. So this is just to summarize everything and to conclude that, I mean, anemia, though is multifactorial etiology, iron and folate deficiency are the common, and malaria and other chronic disease needs to be screened, even tuberculosis, HIV, and cancers. And in fact, there was found to be reduction in anemia when pregnant women who came from those endemic areas received malarial prophylaxis. So dietary iron consumption in anemia is expected to be around 26 milligram per day, but absorption is only 5%. So what we have to work on is absorption. Iron therapy has been so well discussed by Dr. Shyam Desai sir, and so we need to know that we need to have more to increase the absorption of anemia, what we are giving. And almost the preterm delivery, as we said, is very common in the low into severely anemic patient. If the hemoglobin comes below 10 grams at 13 to 24 weeks, the incidence to have a preterm birth, low birth weight, and perinatal mortality increases from 1.8 to 1.7 fold higher. So we need to definitely try to correct anemia early pregnancy, not at a later, to prevent the neonatal complications. And women who are even mild anemic, you feel that, okay, severe anemic is bad, but women who are even mild to moderate in anemia are also at risk of dying as anemia, because the woman's ability to survive bleeding during and after childbirth is what is important. And risk of maternal mortality also decreases by 20% for every 1 gram per DL increase in hemoglobin. So we need to slowly use oral iron or injectable iron and try to identify correct anemia as early as possible. And severe anemia, we know that we are prepared for the adverse complication, that is PPH, and other risk of death. So this is really important, and we need to prioritize our mother, give them good antenatal care so that we reduce this incidence of anemia. And I would like to end with a quote. How can we extinguish a fire if we don't first cut off the fuel that ignites the inferno? And we really need to cut off this anemia, and so that we give good outcome to our mother. And I would pledge to eradicate anemia along with the team WCA, and let's make every pregnancy anemia free and join our government to make anemia more Bharat. With that note, I thank you all for your patience here. Thank you so much.
Thank you, Dr. Komal, for that wonderful talk on anemia as a fuel to maternal pregnancy complications. It was an eye-opener when you said that more than 20% of the deaths in pregnancy are due to anemia as the basic causating factor. Yes, PPH and hemorrhage and all these are there, but underlying this is anemia, which we should all address. Anemia can cause complications, like you said, all types of complications, right from infections, PPH, preeclampsia, and even complications of labor. And then also you brought out beautifully the FOAD, or the fetal origin of adult disease, where anemia can cause IUGR and then leading on to the NCDs in later life. So you have brought out all these facts, and it stresses the importance of correcting anemia during pregnancy, and especially the FOXY goal of Sabka Bara, that is at least to reach anemia, hemoglobin of 12 for all and if not 12, at least 11, which you have stressed that is the minimum that should be there for all our patients, and we all as Foxians should aim, should have this as our motto when we are treating our pregnant women. So thank you once again, and it's over to you once again. Over to Dr. Zubin. Thank you.
Thank you. Thank you so much.
I think there were two questions. Do I have the time?
Yes, yes.
I think one question was, how do you diagnose hemolytic anemia in pregnancy? And the second, 1 minute. Yeah, differential diagnosis of anemia, and what is the best iron preparation in all the trimesters of pregnancy?
Yeah, so coming to the first question, that hemolytic anemia, we need to do, we need to investigate. First we need to take a general history. We need to find out whether the diagnosis is usually by blood picture, but clinically something is what we need to find out, and we need to do a basic test. That is, we do our CBC. A CBC is a real great predictor. And we can find out whether what type of anemia it is actually, whether it is a microcytic anemia, normocytic. The MCV level is really very significant, or a macrocytic anemia, and that will actually tell us which kind of anemia we are looking at. The abnormalities in the white blood cells and platelets, if there are, then we need to think about the other factors. But if there are abnormalities only in the red cell, and the reticulocyte count is something which is very important. And if you find the reticulocyte count to be raised, then there can be a severe blood loss, or it can give a suspicion of hemolytic anemia. And when the reticulocyte count is actually not raised to some degree, then you can do all the indices. So when you find out that reticulocyte count is raised, then at that step, you can start going for the peripheral smear, or we can go ahead to investigate for the HB electrophoresis. And that will actually tell us diagnose the hemolytic anemia. Next question was,
which iron preparation is the best during all trimesters of pregnancy? This was by Dr. Hemant Bhatt.
Yeah, so it is best. See, iron preparations come in all, but classically we have been in all trimesters. It's all time. Actually, all iron preparations are good in all trimesters. Actually,
correct.
only
I think yes.
We try to avoid giving iron in even first trimester, but if there is an anemia, we need to treat it. It is only because of the patient compliance which we are worried. But I think proven all iron preparation, including the injectables, are safe in all pregnancies, all trimesters.
Yes.
And one question I can hear is: it okay to correct severe anemia before surgery by FCM? Severe anemia before surgery, actually, if we are giving an FCM, there is a period for the hemoglobin rise. We had done a study also. The ferritin level will at least take around 4 weeks to rise, significant rise. So what happens is that you have a surgery. If a patient is very severe anemic, definitely giving blood if the surgery is emergency would help. But that FCM also will help because there is a long post-operative recovery period. So there is no harm giving. Sometimes we have patients lined up around say 7 gram, 8 gram. You can give them 2 pints of blood. You can give an FCM, no harm if you're delaying a surgery by a week. But definitely you can reserve it later, but it's your call. But
it will definitely help in the post-operative period and the healing and convalescence.
Yes, yes.
Thank you, Dr. Komal.
Thank you so much, Dr. Komal and Dr. Rajendra Nagarkatti. It was a wonderful presentation which you have given. Obviously, if you have an anemia and you land up with pregnancy and labor, especially in the second trimester, there will be a increase in the plasma volume and the reduction in the RBC volume, and that's going to cause a hemodilution, and we need to correct that. And if the patient, that is the normal patients, but if the patient is having anemia already, then it becomes a little difficult job, and that's what obstetricians are here for. I would like to add to the World Congress of Anemia here that we have more than 2,913 viewers from India, I just have got the details about it. And from Nepal, we have 22 delegates being joined. From the African continent, I have 186 members. Thank you, Dr. Kihara Betres and Kenya and the University of Nairobi joining us. From Hong Kong, of the university, and also the Obstetric and Gynecological Society of Hong Kong, 44 members have joined. And from Sri Lanka, SAFOG, we have 12 members. So it's really heartwarming to see so many countries and across the continents members have joined, and it's a really great efforts being done by the 14 organizations to come on one platform to see that we reduce incidence of anemia and cause, and also the effects which we can reduce. So it is a really great efforts being taken from MOGS and Science Integra. Thank you so much, all of you. Zubin, can you please unmute yourself, and we need to go to the next session. We have Ramesh Kumar joining us, and yes, Lo is there. Thank you so much, sir, for being with us, and thank you, Rajendra. Thank you, Komal. I will see you soon.
Dr. Zubin, we are not able to hear you.
Well, we have got 5 members joining from Seoul, that's Korea. Yes, Dr. Shailesh Kore, please go ahead. Can we get the introduction of Dr. Shailesh Kore?
Can you hear me?
Yeah.
Yes, thank you.
Dr. Shailesh?
Yeah, I am there.
Yeah. And the chairperson for our next talk is Dr. Shailesh Kore, professor and unit chief at Nair Hospital, Mumbai. Special field of interest are imaging, fetal medicine, emergency obstetrics, 28 years of teaching experience as a UG and PG teacher, and currently the joint secretary at MOGS. Thank you so much, sir. And I would love for you to introduce the next speaker.
Thank you, Zubin. As in our country, like India, developing countries, like a pregnant woman, the nutritional deficiency is also very common in children. So to talk on the nutritional anemia in children, we have today Dr. Ramesh Kumar. He is President of Indian Academy of Pediatrics in 2022, Honorary Secretary General of IAP, National Executive Board member of Central IAP in 2011 and 12, UG PG Quiz IAP coordinator in 2018 and 19, a member of Environmental Health Technical Advisory Group of International Pediatric Association, and the chief editor of Enrich, the official publication of Environment chapter of Central IAP. So I present to you Dr. Ramesh Kumar, who will be talking on the nutritional anemia in children. Dr. Ramesh Kumar, please.
Chairperson Dr. Shailesh Kore, the chairperson of the Congress, the World Anemia Congress, Dr. Niranjan, the master of ceremonies, Dr. Subair, esteemed faculty members, dear friends. I bring you warm greetings from the Indian Academy of Pediatrics, the national body representing the pediatricians of this vast country. More than 35,000 members currently in our fraternity. And it's a pleasure to represent the Indian Academy of Pediatrics in this esteemed Congress. And my job is actually limited to what would be something like, as our chairperson has rightly pointed out, the key issue in children, the nutritional anemia. I would like to take the privilege of sharing my screen.
Thank you.
Okay. Fine, friends. So I'll be just going through the various aspects of nutrition anemia in children and how the community programs in this country are geared to take up this challenge of nutritional anemia. Well, at this, we have from the Honorable Prime Minister of our Sir Narendra Modi ji, the Anemia Mukt Bharat coming up in the year 2018, where we have, it's just not as anemia, it's a silent epidemic. And it impacts many aspects. And basically, it's a public health burden over the decades. And entangled with poverty is sanitation, hygiene, everything together. This is the anemia or the nutrition anemia takes its toll. And India, anemia is split around in 58% in children between the age of 56 to 59 months. That's the first 5 years. Maybe 53% in the children in the productive age. You can see everything is around 50% or 50 plus. And this is the NFHS National Family Health Survey data of 2018. So NFHS 4 data. So definitely we live in a country, or our country is having such a large burden of anemia. So what do you see the anemia when you see the criteria is in children anywhere below 6 months, we have got maybe the dilution anemia of infancy is there. So up to 10 may be accepted. But anything above 6 to 5 years, we take it as 11 gram %. Children 5 to 11 years, maybe 11.5, and 12 to 14 years, about 12. So all said and done, it's we accept that there is some amount of reduced hemoglobin in a normal child, and we set the benchmark there as 11 gram, 11.5, and 12 in children below the age of 14 years. And this is a red blood cell. Of course, you know the iron and heme and how important are there in the formation of the hemoglobin and taking us through. And the nutrition anemia, where the anemia factor is contributed by the component, the nutritional aspects. We look at basically iron as the major component here, and we have got the vitamin B12 and of course folic acid around. And in developing countries, the anemia issue is different. That could be a different, it's not a major issue in a developed countries. So developing countries, when you say anemia, we say it's something about 40% prevalence. If it is more than 40%, we consider this as a severe public health problem. This is the norms. I'm sorry, I'm running a call. This is the norm set by WHO, and it was in the global database on anemia. They are pointed as a 40% as a. So India, as I have pointed out, on almost all the ages, it's more than 50%. So well, our country stands very much as a in the classification of anemia as a major public health problem. And the MCV-based classification, the previous speaker was talking about the actually hemogram and the MCV, the MCHC, and the red cell distribution width and all the aspects. So well, of course, basically the anemia, we put it as whether the RBC volume is large, whether the RBC volume is less, or it is normal. So there is a microcytic or macrocytic or even the normocytic. So the microcytic, when the RBC size is less, even children, we say that 70 femtoliter plus age in years. That is a criteria. If it's a 5-year-old child, the minimum, if it is the RBC MCV is less than 75, 70 plus age in years. So if it is less than 75, we put it as anemia. Because children basically depends varies upon the age. Iron deficiency, well, of course, a microcytic, if it is there, it's a iron deficiency. We need to rule out a beta thalassemia trait. This is very important. Whenever you get a microcytic anemia, the first differential diagnosis could be a beta thalassemia trait, and of course, maybe even a chronic disease and even lead poisoning, sideroblastic anemia. Lead poisoning is coming down right now with many of the lead products being out of the regular use at household. Whether there is a normocytic, mostly it could be a bone marrow failure or a blood loss or other aspects. And macrocytic is something again comes in the nutritional anemia aspects, B12 and folate deficiency. So B12 and folate deficiency, that's a macrocytic. Iron deficiency, beta thalassemia, microcytic, and well, nutrition anemia is covered by the can be either microcytic or it can be a macrocytic. It has to be anemia has to be prevented at all ages. There is every age is important and every time is important. And you can see the causes of iron deficiency anemia in children are basically the dietary, because prolonged breastfeeding is an important component. Maybe they go up to 2.5 years, and when there is a prolonged breastfeeding, maybe we find that many a time the complementary feeding is compromised. the parents, especially in a low socioeconomic status, the underprivileged population, they go on for breastfeeding them. Then the child may be feeding, and of course, there will be the intake of other regular food items from the family pot, we call it from the family pot, will be reduced. And poor complementary feeding, we need to put a lot of stress on the complementary or supplementary feeds after the age of 6 months. And another important aspects in rural India is maybe basically the excessive cow's milk intake. The cow's milk intake, on three aspects, basically, cow's milk contains virtually nil iron, very little of iron. And secondly, when there is an excess consumption of cow's milk, the intake of other food items will naturally be compromised or will be reduced. The child's appetite is suppressed to a certain extent when the child takes a good amount of cow's milk. And when add on to this is always the burden of preterm and low birth weight babies. They always are the population which is predisposed or vulnerable to iron deficiency, the nutrition anemia. Then worm infestation, cow's milk protein induced colitis, celiac disease. These are all rare causes, which worm infestation, which is mainly overemphasized. But we find that in practice, this is maybe a pinworms and other aspects may be there, but this is not one of the major causes. What we see is mostly the excessive cow's milk intake, preterm low birth weight babies who are not properly attended to, who are not given iron supplements, and of course some amount of poor complementary feeding. These are the common causes in children. The vulnerable age group, as we are noted, is 0 to 3 years in children, one group, and maybe from 3 to 5 years, they may okay. But then the pre-pubertal age group, or 11 to 16 years of pubertal age group, when especially the female children are in the when the pubertal age or pubertal age, the menstrual loss is an added factor, and of course the rapid spurt in growth, the sufficient iron supplements may not be there balancing for the intake of other food items. So this could be the vulnerable age group, 0 to 3 years and 11 to 16 years as far as children are concerned. Symptoms, it can be anything. Mostly, it may be undetected irritability. It can be a reduced appetite for one reason, because we have noticed that iron deficiency, maybe over a period of time, leads to reduced appetite. Pica is another aspect where we need to think about iron deficiency anemia, because pica in two ways it affects. One is pica is the non-edible items, non-nutritious, non-edible items, maybe from the rice, which may contribute to some amount of anemia. And on the other side, whenever the worm infestation can be an add-on factor in pica, and that can in turn lead on to some amount of anemia. So this both ways combined together, what we can say is pica always contribute. Whenever there is an iron deficiency anemia, nutrition anemia, you need to rule out pica, and the worm infestation has to be addressed too. So these are all symptoms that can really be there. Lack of iron can cause fatigue, poor physical performance, etc. And iron, of course, you can see less productivity at work and school. So this can be something which can be very much there. And poor school performance, iron deficiency results in anemia, irritability, fussy feeding. It also reduces their ability to learn and IQ. So that's another important aspects. And they start ingesting inedible items, as I said earlier. It may lead down to pica. So it's a vicious cycle. Pica leading to iron deficiency anemia, and iron deficiency anemia leading to pica. So that starts. You have to break the cycle some point, and you treat with the proper deworming agents and address the anemia. The pica will be out. Maybe it may take some time, maybe 3 to 6 months. The clinical features of iron deficiency you are all quite familiar with. Just to recap, and they may be irritable. The hair, tongue, there be silky, thin hair. The nails may be platinikia, koilonychia. It can be anything. So these are all common symptoms which they present with. Early testing, maybe hemoglobin and MCV, and at the range of around 1 year with any other blood investigation. Investigating iron deficiency, basically you see that the red cell, the hemoglobin, MCV, MCH, they all correspond to the red cell in status, and that could be reduced. the serum iron, that is actually serum iron indicates the compartment of iron in transit in the bloodstream. So that will be reduced. Serum ferritin, that is a storage form of iron. So that also 15 to 300. Now, you know, as the COVID is there, we are always looking at the ferritin as an acute phase reactant. But even in the iron deficiency anemia, also ferritin is the one important indicator where can really make out the storage of form of iron. So that also will be reduced. Maybe even less than 15 or even 12 is usually the indicator. Transferrin is another one where the ratio of iron to transferrin. So that also will be reduced, you can see. And another important aspect is that iron binding capacity will be naturally increased because there will be more free iron binding sites, because more of the iron sites will be free. So the iron binding capacity, TABC, will be increased, red cell protoporphyrin. So basically what we need to look at is not only hemoglobin, which with the other red cell indices, which like MCV and red cell distribution, that also is important. And apart from that, we need to look at the serum iron, which will be reduced, serum ferritin will be reduced, and TABC, which will be increased. This indicators definitely point out to an iron deficiency anemia. And they'll be falsely normal if for some reason iron-containing medications are taken, especially multivitamins, and falsely low if there is a hypoproteinemia is there. What to look for in a peripheral smear? Basically, it's the anisotropic difference in the variation, in the wide variation in the shape of the RBCs, in the size of the RBCs. What we call it as anisocytosis, poikilocytosis. Together, we may call it as anisopoikilocytosis. And many a time we see the indicator there in the hemogram is a red cell distribution with RDW. So RDW normally hovers around 13 to 18, and if it is very much above 18 or something, definitely it is indicative of the wide variation in the shape and size of the RBCs, which indicates which is very much in favor of an iron deficiency anemia for that reason. And platelet cell test can be normal or even a little high many a time. Stages of iron deficiency anemia, this is just for your information. Basically, if you are looking at the early stages, the first thing to go down will be the serum ferritin. Next will be go down will be the serum iron, and the TABC will increase, and then only the hemoglobin comes down. So basically, when you see the hemoglobin, if it's reduced something around 8 or 9, invariably, if there is a iron deficiency component, the serum ferritin has to be low by that time, serum iron has to be low, and TABC will be increased. So if you are really anticipating the nutrition anemia, you need to look at ferritin and iron also along with the hemoglobin, because hemoglobin, these are the early indicators which can really pick up even pre-latent iron deficiency, latent iron deficiency. And as you see here, pre-latent, latent, and iron manifest, hemoglobin is only a manifest iron deficiency. So if you really anticipate an iron deficiency in a particular patient, you look for ferritin and iron along with the TABC.
Dr.
Iron deficiency is most common at times in life where iron needs increase, like during menstruation for women, in early childhood, during pregnancy. And so all babies should be breastfed, but maybe by 2 years, the breastfeeding has to be discontinued. But complementary feeding is very important. Equally, you can see the mother how to making her baby having some complementary feeding from the family pot, whatever the family has prepared, the vegetables and whatever food items. And after 6 months of life, definitely complementary feeding is very important to prevent appropriate complementary diets. So preventing iron deficiency, you can see what exactly the iron folic acid supplementation is important. Children to 6 to 50, that is less than 5 years, you need say 1 ml of iron, 20 mg elemental iron. We always look at elemental iron and 100 microgram folic acid. And going up and above the older children, we have that 45 mg elemental iron and 400 microgram folic acid. And if it is a school-going adolescents, what we give as per the government program, and we all have 60 mg elemental iron and 500 mg folic acid. So this is the combination which we usually use. As you all are very much aware, in pediatrics, we go by the age-wise dosing is very important. So these are the combinations: iron with elemental iron with the folic acid. We start with the 20 plus 50, then 45 plus 400, something like. And vegetables, this is just to recap: green leafy vegetables, especially the palak, the spinach is the one which can be commonly the drumstick leaves, and spinach is one commonly which can give the maximum amount of iron. And apart from that, the radish is something which which can be the maximum content of iron. Radish and beetroot and even sweet potato and turnip. So these are all certain food items which are quite very, very rich in iron. And fruits, of course, the yellow and green fruits and yellow fruits like oranges, lemon, pomegranate, and even the gooseberries, they all give a good amount of iron. You can see the pomegranate is out here. Dry fruits, of course, the raisins, the walnuts and dates. Dates give a good amount of iron. And this is important. This is what we state as use jaggery in especially in when you give the complementary feedings. We started at the age of 6 months. We advise the mothers to go with the ragi with the jaggery. The ragi with the jaggery means jaggery contains a good amount of iron, which is prepared in iron vessels, iron utensils. So that jaggery will add on to whatever is deficient in the baby infant in the first 1 year of life. Iron deficiency can be compensated to a good extent by the jaggery, which is added to the ragi. So that's a good complementary weaning diet. And maida and other things should be avoided. Red rice is more nutritious, and iron utensils. This is important. This is why this is the ancient, the grandma's wisdom, where we use the iron utensils, and iron utensils they used to give a good amount of iron to the baby. And even jaggery is prepared in also some amount of this iron, big iron stores. Tea, coffee, or children could interfere with iron intake. And this is the plus or the dose that iron tablet, lemon water, green leafy vegetables, meat, sprouted pulses, vitamin C rich fruits, and don'ts is especially we say tea and coffee can interfere with the absorption of iron. And this is our calcium also to a certain extent will interfere with the absorption of iron. So this we need to promote these type of food eating habits in the children. And treating iron deficiency, 3 mg per kg per day of elemental iron, and once a day, or either can be 2 doses per day in between meals, or can give after meals. And again, it's important that the iron should be continued 3 months after hemoglobin normalizes, because the iron stores have to be normalized. It's many a time we see that the clinicians, the physicians, they stop iron once the hemoglobin is a desirable level of hemoglobin is achieved. But then for restoring the iron stores in the body, we need another 3 months. So this is important that you continue with the iron therapy even after 3 months. It is iron preparation, so the plus and minus. But then the ferrous sulfate is the bioavailability is good. Ferrous fumarate, the minimum of GI toxicity, lot of iron preparations. So the plus and minus is there for all the preparations. But the minimum GI toxicity for ions are polymaltose complex. But then the bioavailability is less for this. So that much of the elemental iron, even if you show a certain amount, what you say 20 mg, if you say 25 mg per ml, if it's the availability, the bioavailability, the iron from that particular formulation may vary depending upon the iron salt which is being used. So this is also understanding this iron preparation is also important. This is improving compliance. And many times children have complaint of abdominal pain and diarrhea, constipation. And strategies to be is to reduce that. You can give with food, but do not give with milk, because milk will interfere with iron absorption. And again, milk has got a 0 iron in it. So that both ways it's not that good. Lower doses, changing the salt, divided doses, and giving after dinner. And common adverse effects, they can be like abdominal pain, increased frequency, they can be managed with the splitting the dose, because iron is always, you advise iron, but many a time the complaints will be poor. Parents may come back maybe after a week. My child is not accepting, he has got a constipation, he has got a loose stool, he has got some abdominal cramps. So we need to address these issues also. Otherwise, the children naturally will resist the iron, and they will not accept iron thereafter at any moment. So we need to be a little, give some anticipatory guidance also to the parents that what is expected, some amount of iron, abdominal pain, some vast discoloration can be there, some loose stools or some constipation, and just ask them to revert if there is something is happening. We can overcome by the constipation, add foods and improve fiber to the back of the tongue. If there is a black discoloration, you can put it in inside the mouth, deep into the mouth. So some amount of anticipatory guidance should be given, counseling should be given by giving iron. It's not just like a B complex. You can just put it, prescribe it, and move away from it. Iron has always some amount of guidance has to be given. Presumed nutrition anemia, if no response, drug, wrong dose, malabsorption, heavy worm infestation, all these other issues also has to be addressed if there are, if you don't get the desired response. And especially we need to look at some beta thalassemia trait, sideroblastic anemia, or even B12 and folate deficiency can be there alongside. Megaloblastic anemia, quick look at megaloblastic. I have got, I think, 5 more minutes. So just megaloblastic anemia, deficiency of B12 or folic acid. vitamin B12, and again folic acid. These are the items rich in folic acid. You can see the cauliflower and the asparagus, broccoli, and other items, sprouted Brussels, which can give a good amount of folate. And again, anemia, regression, the neurodevelopmental manifestations can be there in folic acid. Megaloblastic anemia, you can see, as you noted earlier, the MCB will be elevated, mean corpuscular volume, maybe more than 95. And peripheral smear, you can say the macrocytes, and maybe a good amount of macrocytes can be there. Vitamin B12 assay is now available, easily available at every center. Folate assay is there. Maybe you may, whenever you look for a megaloblastic anemia, you always look for homocysteine, methylmalonic acid, and figlu as other markers of any ancillary diseases coming up. Again, we need to be B12 deficiency, adults 1000 micrograms, small children 50 to 100 micrograms, and that is the dose. Folic acid, again, you start with the 1 mg and 5 mg once a day is usually used. Poor response, diagnosis incorrect, iron deficiency coexisting, and neurological response is poor at times. And mother can also be deficient. So we have got a lot of programs running in our country preventing away. Just have a look at the nutrition anemia programs. So nutrition anemia prophylaxis started in 1970, and a lot of initiatives from the government side. We have the Anemia Mukt Bharat in India starting in 2018, and that has given a good impetus to the anemia-driven programs. You can see the anemia has come down from 2016 58% to 2022 11%. So what a drastic reduction is there in the pediatric age group, especially 6 to 59 months age group. 58% has come down. So this implies that given a proper with the iron deficiency, addressing the iron deficiency, especially in the schools, the tablets were given in the schools, in the adults and girls, and all those aspects. You can see the adults and girls, it has come down from 54% to 36%. So it has reduced like anything pregnancy. So we given good nutritional programs, good supportive programs, we can bring down the iron nutritional anemia in a big way. Weekly iron and folic acid supplement, especially the teenagers, 10 to 19 years, and more than 12 million beneficiaries. With just one blue pill a week, we fend from lazy and slow. This tells the story. Because that how much the many a time we see the adults and girls being a little hesitant or resistant, or the parents resistant. Once we just reassure them that this is something which can really go a long way in making their children more productive, they really comply with. So friends, this is just an overview of the nutritional anemia in children, and I believe I have just covered the iron deficiency anemia, the nutritional, the folic acid, the B12 deficiencies, and the anemia, the programs which are running right now in our country on this particular aspect. Thank you very much, and thanks the World Anemia Congress, the office bearers, Dr. Niranjan, as well as my chairperson, Dr. Shailesh, and all the office bearers for giving the opportunity for myself to represent Indian Academy of Pediatrics in this platform. Thank you. Good day.
Thank you, Dr. Ramesh Kumar, for such an excellent overview about anemia in children. As I said earlier, like women, the children are also vulnerable for nutritional deficiency, and like pregnant women, the nutritional anemia is very common in children also in India. So you really elaborated well about the causes and investigations and treatment, and particularly the simple treatment, the dietary advice, and the other differential diagnosis like thalassemia trait. So it was really a very good lecture, and we'll just check whether there are any questions. No, I don't think there are any questions. So thank you very much again for sparing a time with MOGS as a part of IAP representative and giving such excellent lecture. And also I thank Dr. Niranjan, Dr. Geeta, and Dr. Rajendra for arranging this Congress, which is way forward towards Anemia Mukt Bharat. Thank you, Niranjan, and thanks everyone, organizers, for giving me this opportunity.
In fact, I'm also happy to see Dr. Surendra Bist, my good friend from Indian Academy of Pediatrics, representing the Neonatology Forum, the treasurer, and he has been very active stalwart of IAP. Welcome, Dr.
Thank you.
Thank you, sir. So nice to follow you all that.
Thank you. Thanks, Surendra.
Dr. Zubin, we are not able to hear you, sir.
Hear me?
Yes, sir.
Yeah. Thank you so much, sir. And I'll pass on proceedings now to my batchmate and fellow Youth Council member, Dr. Sidra Kot.
Thank you so much, Zubin. Am I audible?
Yes.
We would like to take on the session and go on to our next event. We have the chairperson for the next session is Dr. Geeta Bilsalkar. Madam needs no introduction, but I'll just go forward to say that she is the head of unit at CGS Medical College and Wadia Hospital. Madam is an editor-in-chief of Journal of Obstetrics and Gynecology of India, librarian of MOGS, President Association of Medical Women in India, and many more titles she has to her name. We please welcome you, Madam Dr. Geeta Bilsalkar. Thank you.
Yeah, I'm very happy to introduce Dr. Surendra Bish today, who is from the Indian Academy of Pediatrics. He has done MD and DMD in pediatrics and long-term training in neonatology from All India Institute of Medical Science. He has got a lot of positions like National Treasurer 21-22 of NNF and National Executive Board NNF member 2019-2020, WHO Zero Master Trainer, Quality Improvement Technical Advisor, Nationwide Quality Care or Quality of Care Network, National Mentor Lakshya, MOHFW and NQOCN. He's a North India Zonal Coordinator and Regional Trainer, IAP, NRP, FGM Project, National Trailer Facility Based Newborn Care, and he is NNF Neonatology Quiz National Coordinator 2017-18, and he has got holding many other positions. So can I invite Dr. Surendra Bish to talk on his subject, that is anemia in the neonates. Anemic mother translates into a anemic neonate. And so here we have, which is a very, very important topic, both from obstetrician as well as a neonatology point of view, and anemic neonate.
Can you see my slides?
Yeah.
So first and foremost, I think this has been already been discussed. I am so thankful. Again, I'm blessed, in fact, to follow Dr. Ramesh Kumar, our IIP president, and he's a very, very good friend and a mentor to me also. I'm so happy that in his leadership, Indian Academy of Pediatrics is bringing out a lot of standard treatment guidelines, anemia being one of them, nutritional anemia being one of them. And in his leadership, we had forged a very good partnership with FOXY. So we have a perinatal module where we would be talking about issues come dear to both pediatricians and obstetricians. So that module was run in Padicon and trial run in Padicon, and hope for next many years it will be a module which will come forward for this. I must thank my president, Dr. Siddharth Ramji, the NNF president, who because of some exigencies could not represent today. So he has given me this opportunity to present NNF. And I'm so glad that I'm in the company of the best of world bodies who are presenting, who actually take care of anemia, whether it is about mothers in FIGO, Royal RCOG, it is your FOXY, MOCG, and children, Indian Academy of Pediatrics, National World Anemia Forum, and you have physicians, API. I'm so glad that all these logos are here, and it shows that the world can do great things together when they move together. And any Anemia Mukt Bharat will remain a dream until and unless all of us come together. So, Dr. Geeta, actually, what I got to know a day before that, I have to talk something about complications of anemia in newborn, rather than anemic mothers giving rise to babies in this. So I think whatever, it's just a twist of word from here and there can make a little difference. So, but since this is a congress where most of you are obstetricians, here any newborn topic which has implications will certainly be, I think, taken care of. Yeah. So So I will be going towards how anemia happens in a newborn, what are the causes, is there any definition? What if there is any incidence known of anemia in newborns? What could be the complication because of disease and treatment? And yes, iron deficiency anemia in a newborn. You are very well known because you take care of mother and fetus when all this is happening. This is happening when the baby is in womb. So the erythropoiesis in the fetus starts actually from some progenitors moving from yolk sac into the liver, and then it infiltrates the liver circulation. And it is around, if I just use my pointer, if it is somewhere around 6 weeks or so, that the liver starts becoming the main organ for hematopoiesis. And you look at this around 26 weeks or around 6 months or so. Now that liver is lesser and more of the bone marrow has started coming over. Spleen and bone marrow have started coming as the organs, the sites where erythropoiesis is occurring. And fetal erythropoiesis is an extremely active process, especially during the last 2 months of gestation, where the RBC production is 3 to 5 times greater than the healthy adult ones. So keep in mind, because you are looking of mothers and fetuses around that time. So anemia, is there incidence? So there is a physiological anemia of infancy which can occur, and you very well know, because there is now a change in tissue oxygenation as soon as the baby is born, from the placental circulation and the placental kind of oxygenation to a lung-based oxygenation, where suddenly the saturation, blood saturation rises from around 70 to 75% to around more than 90% within 5 to 10 minutes only, and that leads to decrease in erythropoietin level. There is these RBCs, the fetal RBCs, have a reduced lifespan. You all know that 60 to 90 days compared to 120 days in an adult red blood cell. And these cells, these RBCs and this hemoglobin is actually susceptible to oxidative stress, and that leads to more of RBC lysis or neocytolysis, which is occurring, the young RBCs which are breaking down in the newborns. And obviously with the increase in size, rapid weight gain, which is occurring later after birth, there is a hemodilution. And anemia is more so common in preterm babies, more so in very preterm babies. So in fact, so much so that somebody actually wrote in his review that almost 90% of the very low birth weight, in some time, it was almost a decade back, that very, very low birth weight babies, less than 1,000 gram or so, 90% of them would receive at least one RBC transfusion when they are being taken care of. And in preterm babies, it can be, more of it can be iatrogenic, because they are hospitalized and a lot of phlebotomy is occurring to them. So what are the causes apart from the physiological causes? Now I'm coming to the causes, because these are the causes which would have some complications as far as newborns are concerned. And these are babies which are under your care when they're as a fetus, or when they are born, they are taken care by us in our NICUs, when again it is in a shared care in the hospital. So before delivery, there is the causes are obviously fetal-maternal hemorrhage, fetal-placental hemorrhage, twin transfusion. During delivery, yes, the umbilical cord, the cord malformations, whether it is a filamentous insertion, vasa previa, hematomas, aneurysms, nuchal cord, malformation of the placenta, placenta previa, abruptio, some obstetric complication we are doing inversion. I think that is what you do. Placental incision during cesarean section, traumatic amniocentesis, umbilical cord rupture with precipitate delivery, or a rupture of short or entangled umbilical cord. Internal bleeding in a newborn can occur, whether it is because of the birth injuries which are occurring like encephalometama. It can lead to subdural, intraventricular, subgaleal, intraabdominal, ruptured liver, spleen, kidney, or adrenal hemorrhages which can occur, and there can be a retroperitoneal bleed and a pulmonary bleed, especially in a low birth weight baby. And obviously, I just talked about the blood losses which can cause anemia, phlebotomy causes, because of in the hospital we take too much sample, too many samples in time. Sometimes it is required. The other cause of anemia in a newborn is decreased RBC production. This is not a very common cause, but yes, you can see infections over here, which are congenitally or transplacentally acquired also. Parvovirus, B19, HIV, syphilis, cytomegalovirus, rubella. There can be disorders of bone marrow, which are rare, like diamond black fung syndrome, Fanconi's anemia, or transient erythroblasopenia of childhood, which is seen in some conditions. There can be nutritional deficiencies because of very poor iron status of a newborn, because of a poor iron status of mother. Just a second. It is running low. So, and there can be congenital pneumonia. The third major cause of anemia in newborn is increased RBC destruction. This all of you have encountered a lot of time. In fact, this is mainly because of immune hemolytic anemia, whether it is RH, ABO, minor blood group incompatibilities, maternal autoimmune disorders, SLEs, autoimmune hemolytic anemias, drug-induced like penicillin, valproic. There can be RBC enzyme abnormalities. Obviously, G6PD deficiency, I think that is seen in some part of Mumbai, Gujarat, and we see a lot of that in North India, G6PD deficiency, pyruvate kinase deficiencies, glycolytic deficiencies, and some nucleotide deficiencies. There can be a membrane defects also, like hereditary spherocytosis, eleptocytosis, stomatocytosis, pyropoikilocytosis, and there can be hemoglobin disorders, which are again very common in India, like thalassemia syndromes, like alpha thalassemia, beta and gamma thalassemias. And there are other causes of increased RBC destruction. Can be vitamin E deficiency, infections like infections also can have some kind of hemolysis, even TORCH, serious sepsis can have it. Anemia premature is one thing which I can just devote one slide for that. And there is anemia can be because of DIC and bleeding because of that. And there can be galactosemia or osteoporosis, which can infiltrate and may cause some RBC membrane defects and may cause defects and unstable hemoglobinopathies like Hin's bodies. So there can be physiological contributors and there can be non-physiological contributors, and I have gone through some of them. But if you see Motamoti, if you want to know about things, then it can be either physiological, where yes, the oxygen sensor has been set from liver to kidney now. There's decreased erythropoietin production because kidneys are still not stimulated. There's a rapid body growth. There's shortened RBC lifespan, and there's a left-sided shift of the oxygen dissociation curve. The iatrogenic or the non-physiological causes, in fact, in a preterm baby, certainly is laboratory blood loss, inadequate nutrient intakes, non-laboratory blood loss and hemorrhages, and some infection sepsis, if you are not considering the alloimmunization part. Anemia of prematurity, if you can look at these pointers. So at birth, the hemoglobin is around somewhere 18, 19 in a term baby. This is a term baby more than 3 kg. And then it falls to a nadir around 3 months of age, when it falls to around 12, 13. In 50th centile, it can go till 11 also. So this is what Dr. Ramesh said. In first 6 months, if it goes below 11, then it is anemia. So how to define? Because it is still a dynamic process which is occurring. So one single value, like aapne kaha 12 ka 12, 12 pe sabko 12 rakhna hai. There is no such value can be given in a newborn period, because it is dependent on the gestation, the weight, and obviously the time elapsed after birth, the postnatal age of the baby. So you need to refer to the 50th centile charts, and as the baby's weight falls or it goes down, you can see they have a lesser hemoglobin at birth also. Like in a baby who is born at preterm baby with 1,000 to 300 grammer babies, the initial hemoglobin can be somewhere around 15 or so, 14, 15, and it falls to a level of around 9. In a nadir, and the nadir does come little early. So it is an early nadir, and which comes, and it is a nadir which is actually going to a lower level. This level may have some impact on cerebral oxygenation and tissue oxygenation, because here the hemoglobin is 9.9. though it is still mostly most of the hemoglobin is fetal hemoglobin. Yes, it has a higher affinity. It has to oxygen and doesn't dissociate easily at the tissue level. So whether the tissues are getting compromised by this low level of hemoglobin is something which concerns a lot of people. That is why iron supplementation is done a little earlier. And you can see on the right the reticulocyte count effect is seen like this, and you have a very good reticulocyte count, which is going higher and higher in a preterm babies. So the complications of anemia in newborn, sometimes they are not recognized because anemia itself in a newborn is hardly discussed in nurseries. Because you're continuously doing testing, and sometimes you get to know, okay, the hemoglobin has come to this level. So nobody actually look at the symptoms of anemia unless there is hemorrhage in newborn, and most of them time it is concealed. Postnatal follow-up doesn't focus on anemia also. So as Dr. Ramesh, I feel he's still here. So this is something which NNF and IIP needs to look into this, that the continuum of care follows, and the baby when comes into follow-up in pediatric well baby clinic should be looked for anemia as well. Maternal undernutrition and poor iron B12 status, which Dr. Ramesh focused, and I think many speakers must have done before that also, that remains unrecognized still. And the effects of anemia like lethargy, poor feeding, a little increase in respiration, increase in heart rate is something which is non-specific, and they are subtle. So what are the complications like in fetal anemia? Because this is something which is important. And these are anemias which present immediately at birth, and probably these are anemias which present during the fetal life. Fetal line anemia is a serious complication of pregnancy that result from immune-associated conditions. Most in India, we see more of this Rh sensitization being the most common cause. And if you look at the ultrasound findings in a progressive order predicting from just a liver spleen dilatation to umbilical vein dilatation to increased placental thickness, leading to hydramnios, leading to ascites, leading to pleural effusion, leading to pericardial effusion, and ultimately a grossly hydropic baby leading to intrauterine death. All this we have seen encountered so many times. This is an anemia which we encountered in fetal and newborn line. So as a perinatologist, I would certainly urge all to kindly prevent this kind of condition and work towards treating this. So therapeutic management of fetal anemia, the review is here. And yes, intrauterine transfusions, I don't know how many centers are doing now. When I was doing my fellowship at AIIMS, Dr. Deka and team and Dr. Dan Kriplani their papers in this review which have come from AIIMS, and so many papers have come from India thereafter. It has been shown. So I think India is a country where intrauterine transfusions are being done. What is important for people to know that we need to follow the algorithm. This algorithm just get missed by many of the obstetricians in their practice. So they need to check whether they were the previously affected pregnancy or not. Even they need to confirm what the paternal blood group is, and then you can do fetal DNA testing also. And you look at the ICT titers and then follow with MCA Dopplers. So if your peak norm is somewhere more than 1.5 MOM, you do a chordosynthesis and you see whether IUT is required or not required. If it is not more than 1.5 MOM, multiple of medians, probably you would continue doing MCA Doppler. Then these are many of such babies we have treated at AIIMS when I was doing fellowship, and we could save those babies who were aborting. They had some 7 or 8 abortions earlier because of RH, very severe isolation and recurrent abortions and recurrent late fetal deaths. The other treatment modalities considered can be IVIGs, which some centers have used, not to that great efficacy, but yes, plasmapheresis is one more modality. So this is how it is being done. I think many of the centers are doing. You insert a needle, which can be seen here. The needle insert with umbilical vein, and you see the turbulence in the umbilical vein, and then you just connect the blood to that vein. Some people do in intraperitoneal transfusions as well, and it is considered now a very safe procedure. in fetal medicine, with the parental fetal loss of only around 2% or so, with an acceptable complication rate as well. So what is anemia in a newborn, the definition? So since I already told you, there's no clear-cut threshold. So there's a threshold for treatment, and in fact, different countries have different thresholds. So there were liberal transfusion strategy to a conservative transfusion strategy. So all our anemia threshold, because you cannot just treat with iron in a newborn and say anemia will get improved. So in a newborn, probably if there is anemia, and it depends on what age, postnatal age is it, and what is the cardiorespiratory status at that point, whether the baby is ventilated, whether the baby is being having symptoms other than that. So these are the criteria. If this is a no respiratory support, we can go up till 7 or 8 as well. You can, the Canadians are actually waiting till 7.5 to transfuse. So there's no hurry because there's always a time for body to, the erythropoietin to get stimulated in the kidneys. There's a production gets stimulated in the kidneys. Now telling about the symptoms, again, the apnea, bradycardia, increased oxygen need is something which, if there is an imbalance between oxygen consumption and delivery. These symptoms are very non-specific, and since the baby is already having some of those like sepsis, pneumonias, HMDs, these are some of the conditions which baby is already having at that point of time, so they get confused with this. So hemoglobin level at which these symptoms occur is therefore not well defined, and is also likely to vary between neonates of similar and varying gestation age. So like this is just a chart you can see. So these are the threshold, transfusion threshold. So in newborn it is easier because treating anemia is very simple. You just have to give packed RBCs. So you have a threshold. If it is less than 7, so this can only be given, you can wait till 7 only if the baby has no symptoms, the reticulocyte count is almost like low and it's not high, and so there's no hemolysis going on. So if then you can wait till 7. Otherwise, if the baby is on mechanical ventilation, his mean airway pressure, whatever the ventilation requirements are, is more than 8, and the fractional inspired oxygen requirement is more than 40%. Probably these babies need to be given at a higher threshold of around 12, 11 or 12. So earlier we used to keep a threshold around 13 and 14. Now we have become more conservative. So we have come down to a threshold of 11 and 12 in such babies.
Dr.
And obviously,
a gentle reminder.
Another 2 or 3 slides, sir.
Thank you, sir.
So, so the complications of transfusions in anemia, because your babies, when obviously you take care of babies and newborns in your NICUs also, so they may have some blood-related infections. Obviously, they are now rare because all our blood banks are good. The only error becomes the administration, how fast it is given, whether some mismatched blood group was given. Transfusion-related lung injury and transfusion-related circulatory overload are difficult to differentiate in sick neonate because otherwise they're also having some lung condition, ventilatory issues. Necrotizing enterocolitis is a condition which is seen ROP, a very kind of a very important and medico-legally very important conditions, which can result if you are giving too much of blood in a newborn. Neonatal period, last 3 years slides, sir. It is our iron deficiency anemia in mother and babies. And so neonatal period is a missed opportunity for prevention of iron deficiency anemia. And here it is a period when there is a rapid and critical brain development is occurring in a newborn. And they are at increased risk of iron deficiency as iron transfer to the growing fetus in utero is compromised by a number of maternal and pregnancy-related factors. And you know, what are the areas which can affect? There's iron, neurotransmitter metabolism, energy metabolism of in brain, and myelination. So neurotransmitters like dopamine, serotonin, and norepinephrine synthesis is somewhat dependent on iron. So any altered monoamine metabolism results in disturbed sleep cycle, memory, and social emotional development. Whereas the neuronal energy imbalance, especially in the hippocampus region, leads to memory processing alterations, and that may lead to abnormal arborization of the dendrite cascade. The myelination can get affected, which can result in decrease in production of myelin sheath, and this may lead to the kind of the nerve impulses going faster or no. So there are disturbances in the auditory and visual system of the infants if there is an iron deficiency in the newborn. What are the risk factors? Maternal iron status. So yes, this is what you are talking about. The maternal ferritin threshold should be somewhere around 12 to 13.6 microgram per liter. So this is a threshold where I think some of your speakers must have told that is a threshold which mothers should have when they are having babies. So prematurity and low birth weight, yeah. So 2/3 of the total body iron is getting accreted during the third trimester. And so the preterm babies are deprived of the significant iron accretion. And you know, all that has to be then being given by the whatever milk, and milk is not a good source of iron. So they need to be supplemented with iron very fast. And pregnancy complications, yes, many of the pregnancy complications may lead to uteroplacental hypoxia, and that hypoxia may lead to iron getting drawn from the hepatic storage to increase the erythropoiesis and to kind of counterbalance the hypoxia which is going in a fetus. But what does it lead to? It leads to a decreased iron status in the liver, and that may lead to later on, though the baby is now saved of the hypoxia, but the total iron status in a newborn, in a fetus, is decreased, and that may lead to iron deficiency later. Maternal smoking, yes, is an independent factor as well, apart from hypoxia also. Yeah, so maternal obesity itself, class 2 maternal obesity has been found to have decreased neonatal iron status. And mode of delivery, very surprisingly, infants delivered by cesarean section are twice as likely to develop iron deficiency anemia. So, and I was surprised because many of the centers were very laughingly telling me, oh, हमारे यहाँ तो आजकल normal delivery नहीं होता है. So I'm in Delhi, हमारे यहाँ तो 60-70% cesarean होते हैं. So this is actually you're putting your babies twice at a risk of iron deficiency, and not iron deficiencies, with the kind of a brain development which will occur and issues later on. So this is not the best thing to be offered to our newborns and of our countries, which will have less productivity for the future. What are the strategies for prevention? So yes, your mothers who are in the reproductive age group, their health and lifestyle, their food, nutrition should be taken care of. Delayed clamping of the cord. Yes, this is something which is close to both parentologists, the mother and the obstetrician and the neonatologist. And as a member of NNF, I would urge all to practice it. Though I believe now in India is a country where delayed clamping of cord is done in most of the centers. Delayed cord clamping results in increased hemoglobin and ferritin after birth without any increased risk of adverse outcome. These improvements in iron status and decreased risk of iron deficiency anemia last throughout early infancy. You imagine, not only during the first few months, it is throughout the infancy, in fact, till 8 to 12 months of age. And it leads to increased brain myelination at 4 months. So there are the randomized studies which was found, and they found these babies had an increased brain myelination 4 months and improved fine motor and social development at 4 years. So just by delaying it by 1 minute, 1 to 3 minutes, it has such a great effect, such good quality effects. कहाँ मिलेगा इतना return on आपका कहाँ मिलेगा सर, return on investment कहाँ मिलेगा? So, and there is a tailored supplementation regime which are to be given in high-risk infants, like we need to start iron in the preterm babies earlier, and in all babies around 2 months of age. And screening strategies should be adopted for early iron detection in our well baby clinic. I think that was all. Thank you.
Thank you, Dr. Bish. It was very, very important, actually, the last point that you said, delayed cord clamping. And it is the most practical thing that we can do to prevent neonatal anemia.
इससे सस्ता क्या होगा मैम? अब हमारे देश के बच्चे बच जाएंगे. अब ये हम क्या हमारे घर वालों के बच्चे होते हैं मैम. ज्यादातर हम सिजेरियन या डिलेड कॉर्ड सिजेरियन कर रहे हैं, इसलिए डिलेड कॉर्ड क्लैंपिंग नहीं कर रहे. सिजेरियन में भी आप डिलेड कॉर्ड क्लैंपिंग कर सकते हैं. Cesarean में भी आप skin to skin दे सकते हैं. All that have been proven in many studies. So and done as quality improvement also. So I urge all of you to kindly practice it, because you will be doing a great service to this nation.
Thank you so much, Dr. Bish, for this very refreshing outlook. We would like to go on to our next talk. For that, I would like to call upon our chairperson, Dr. Sujata Dalvi. Ma'am is the clinical secretary of. Sorry.
Just want you to say bye. Goodbye.
Thank you, sir. Our next chairperson is Dr. Sujata Dalvi. Ma'am is the clinical secretary of Mumbai Obs Gynecology Society. She's the first joint secretary AMOGS. and the Joint Associate Editor of Geogi. We welcome you, ma'am.
Okay. Thank you so much, Sidra, for a kind introduction. Our next speaker is going to be Dr. Shashank Joshi. To introduce Dr. Shashank Joshi, he is an endocrinologist, a diabetologist, and a medical researcher. He is a consultant endocrine and a metabolic physician at Lilavati Hospital and Bhatia Hospital, Mumbai. He is the president of Indian Academy of Diabetes and that of an Association of Physicians of India. He was also a president of Research Society for Study of Diabetes in India. He's been honored with Padma Shri by Government of India in 2014 for his effort to the cause of medicine. He's received many accolades and awards at national and international conferences, and he is one of the members of a task force for the management of COVID patients appointed by Maharashtra government during the time 2020 to 2022, and for which Indian Medical Association gave him a special award. So over to Dr. Shashank Joshi. He's going to be talking to us on anemia in COVID patients.
Thank you, Dr. Sujata, for your kind words of introduction. I think we are running a little late. The topic allocated to me by Dr. Niranjan has been anemia in COVID. And we all know that currently we have transformed ourselves from a Delta belt to a Omicron belt. And currently, as we talk today, on 7th May 2022, we are having BA1, BA2, BA3, BA4, BA5, and variants of Omicron which are in circulation. So conceptually, we all know that we are looking at health and impacts of COVID on malnutrition. So whether it is economic disparities, food systems, health systems, we have seen that in COVID, there has been a very bad form of aggravation of malnutrition. Very clearly, we know that there has been definitely a depletion of consumption of nutrient-rich foods across the world, and India is no exceptions. And very clearly, we saw from the previous speaker also that there has been disruptions. Up to 75% were reported in antenatal programs selected in the first few months of the lockdown. So clearly, the access has been restricted worldwide, and India is no exceptions. We also know that this is an anemia meeting, and there is a worldwide anemia prevalence, and we clearly see that India still flags, unfortunately, in the severe belt of more than 40%. So the highest prevalence of anemia on planet Earth, above 40%, is in sub-Saharan Africa, Eastern Mediterranean region, and Southeast Asia. And the lowest prevalence is in America. So how does really COVID and SARS-CoV-2 impact anemia and iron homeostasis? We all know that the SARS-CoV-2 is an RNA virus, and it has multiple pathways. Of course, it has a direct lung tropism, and it causes hypoxia. And we know hypoxia due to respiratory failure induces inflammations and changes in iron metabolism. So that is the first pathway. So the hypoxic induced changes linked to the the changes cause iron metabolism issues. We also know SARS-CoV-2 impacts the activation of hepcidin. We know that whenever innate immune system is reactivated, hepcidin gets activated, and whenever there is hepcidin activation, the ferroportin is blocked. So that is the pathway number 2. We also know that hepcidin blocks iron absorption. So that's the challenge. And we also know that from the first pathway, iron is blocked in the reticuloendothelial macrophages. We also know there are challenges with iron recycling in the liver and spleen. And clearly we know with hypoxia and hyperinflammatory state, there is a depletion of hemoglobin. So that's something very well known. Also, we know that with SARS-CoV-2, the erythropoiesis in the bone marrow is also affected. So clearly in COVID, we see that there is a cytokine storm, and there is excess ferritin and excess hepcidin, and there is a hyperferritinemia state. So what is the challenge which we are seeing is probably, is it the cause or is it the effect is not very well known. And also currently we don't have adequate data beyond reasonable doubt to suggest that COVID-19 is directly causing a hyperferritin state. But one thing is very categorical, that in the pathogenesis of the disease, altered iron status does matter. Now, we should have some things from the pandemics and the evolutions. And the current hypothesis is that the SARS-CoV-2 is an RNA virus. We know all RNA viruses are heavily dependent on iron. We have very clear-cut evidence to suggest, and the overarching role of iron in COVID infections include excess ferritin in severe cases. And the hyperferritinemia syndrome, which have been described in the pre-COVID era, as well as a cytokine storm of COVID-19 are very similar. Also, what is documented in diabetics, in obese, and in elderly is that there is an overexpression of hepcidin. And given this understanding, targeting iron from a therapeutic standpoint may have a decisive role as an adjuvant therapy against viruses. But we don't have sufficient data to suggest this hypothesis, and we need to generate some robust evidence. We also know that when COVID started in 2020, a lot of people, as a therapy of COVID, in the cytokine storm, attempted ion chelation. And we clearly know that ion chelation influences free radicals and pro-inflammatory cytokine production, which is strongly involved in the late phase of COVID-19 and eventually to acute lung injury. Including India, various ion chelators like desferrioxime, desferriox, etc. were tried as a part of an anti-COVID agent. None of them ultimately went into any form of an evidence. Now, the data on anemia, iron, and COVID has been beautifully analyzed in a meta-analysis. And you can see here that the mean hemoglobin levels, the mean ferritin levels have all been collated by this group in the European Journal of Epidemiology. It clearly showed that if there is a moderate to severe COVID, there is a linkage with lower hemoglobin, lower RBC count, and a higher ferritin and a higher red cell distribution. We all know that if the red cell width is more than 14.5, your likelihood of deterioration is more. And clearly, one critical link which we know as a biomarker for severe COVID is ferritin. And 606 is a level which has been found as a critical. So any ferritin above 600 actually differentiates between survivors and non-survivors, came from the early Chinese data. And this was sense data which I was alluding to, where they did a multivariate and univariate analysis, where they showed that simple anemia had a univariate hazard ratio of 3.9, particularly apart from, of course, male gender and age above 65. The other challenge, as I told you, is any ferritin above 150 was linked to severe disease. And clearly you can see that in the poor outcome of severe COVID, elevated ferritin probably had a role. So the severity of COVID was negatively correlated with serum iron levels, and after treatment was positively correlated with CRP, with serum amyloid A, D-dimer, LDH, urea nitrogen, and myoglobin levels. Also, what was worse is if there was an elderly person or old age or low post-treatment serum iron, there were independent risk factors for death with COVID-19 patients. Clearly, now we are trying to understand more and more from the virology of the various molecular pathways of the erythropoietin signaling within the cell. We all know that erythropoietin can attenuate respiratory distress syndrome and confront severe acute respiratory syndrome of SARS-CoV-2 through multiple mechanisms like cytokine modulation, anti-apoptotic effects, leukocyte release from bone marrow, iron redistribution from intracellular virus. So as I told you, one of the important entities in the iron kinetics is hepcidin. And hepcidin is one of the most important predictors of death. Other hand, iron levels don't affect survival and probably are low in all patients. So clearly you can see between the severe and non-severe group, and this is of course retrospective data published last year, anemia is clearly an independent risk factor for severe illness in general also, and COVID is no exception. So if you see any viral illness, if you see COVID and if you see anemia, it is a risk factor. So obviously awareness of anemia in the COVID times has a great significance. And anemia, especially anemia of inflammation, is always prevalent in patients with severe COVID disease and has always been associated with an unfavorable or a poor outcome. Also, what has been worse is the higher ferritin and transferrin ratio reflects more advanced inflammation predict subsequent insufficient pulmonary oxygenation and the need for ICU admission and mechanical ventilation. So, clearly you can see this is we are in an era of digitose home, and we are in an era where there's a lot of molecular mimicking which occurs. So this is a molecular docking diagram which approved an FDA approved iron oxide nanoparticle to treat and control COVID infection. This 3D interaction diagram shows a ferrous O3 F2O3 docking interactions with key amino acids in the receptor binding domain of SARS-CoV-2. And the F2O3 and F2O4 interacted efficiently with the S1 receptor binding domain of the SARS-CoV-2 as well as to the HCV glycoproteins E1 and E2. So obviously there is a nanoparticle of iron oxide which might have a role in COVID treatment, and currently these are undergoing clinical trials. So obviously, this is a little odd topic, but anemia clearly is associated with significant higher mortality in people living with COVID. Clearly, we know that the heightened inflammatory state, particularly excess ferritin, reportedly identifies people with higher mortality risk. And despite of strong association in mortality, currently we don't have sufficient evidence to show that hyperferritinemia is merely a systemic marker of disease progression or a modulator of disease pathogenesis. This is still an unanswered question. Iron metabolism, biomarkers, hemoglobin definitely allow us to risk stratify people in initial anemia, clearly has a linkage with increased mortality. Also, there is some excitement in the field of iron oxide nanoparticles as an attractive tool which may be used in the future to have an anti-COVID or anti-HCV effects. And these have now been processed in clinical trial situations. So this was as far as anemia and COVID was concerned. But obviously when somebody is having COVID and we are in the Delta wave, we had the monoclonal antibody. In the Omicron variant, we have molnupiravir and remdesivir injectable IM. And in hospitalized patients, we still have remdesivir, which is there. And then, of course, we have steroids and so on and so forth. So obviously, what is our current goal? Current goal in COVID pandemic, and this is nothing to do with anemia, is to have zero COVID deaths, no severe disease, mildly manageable seasonal flu-like virus, which becomes endemic. And clearly, Omicron has provided that chain breaker and has replaced Delta so that we can live in a freer environment. Of course, we recommend indoor masking in a closed, poorly ventilated space. So in COVID-19, as of 7th May 2022, still we need to be responsible. We know that this is a predictably unpredictable virus. We need to save lives, and anemia and COVID are important tenets which we need to recognize. Anemia being largely prevalent in our population, we need to be mindful of it, that is associated with poorer outcomes. And I just tried to give you an overview of what is in the global literature as far as iron, anemia, ferritin, and iron oxide nanoparticles are concerned in the COVID space. Thank you for the opportunity, and I'll be happy to answer if there are one or two questions.
Yeah, if we have, I'll just let you know. Otherwise, thank you for giving a very clear this thing on anemia as well as in the COVID patients. It's mainly the hepcidin which gets activated, which leads to decrease in the iron absorption along with hypoxia. And it's anemia which is directly proportionate to the severity of iron, and anemia cannot be ignored in a COVID patient as such. Any questions? We'll just let you know. Otherwise, we go ahead with the next speaker then.
Shweta madam, can I have a question for Shashank?
Yeah, tell me. Or
Yeah.
you can ask directly, no problem.
Oh, hi. Hi, Shashank. Good afternoon. Yeah, now in the COVID era is fairly okay, over, preferably, we say that. But, during the COVID time, Shashank, if at all somebody has to treat this anemia. Now, as you said that COVID, virus is so much heavily dependent on the iron correction. How would you actually approach these patients to correct anemia in the COVID situation?
So during the COVID times, we gave micronutrient correction, and we did give iron supplementation also. So it is not that we did not give it. And people who have long COVID, we have often seen that they have also been corrected with iron, and iron deficiency and has been one of those tenets in that space as well. COVID is not over, Mangesh. COVID is very much around. Only thing is, COVID has become a mildly manageable flu-like condition, and let us hope and pray that we don't get any more of the variants like the Delta types. And let us hope that we get we have a symbiotic relationship with the virus and a healthy friendship with the virus rather than animosity with the virus.
Thank you. Thank you, Shashank.
Yeah, we would love to be friendly with the virus and not enemy. I agree with you then.
Yeah.
Okay.
Even I agree that we need to make now little friendly and a deadly virus. I think COVID was one of the fear which we are having. But as everybody, I know the anemia which is underlying is always scary to all of us. And I think it was an excellent talk by you, and the correlation between COVID and anemia was so well highlighted. Thank you so much, Dr. Shashank.
Thank you.
Thank you so much, Dr. Shashank, for that talk. We would like to go on to
Hello, hi. This is Dr. Niranjan here. I'm really grateful to Dr. Shashank Shah, sir. Sorry, Dr. Shashank Joshi to join in. Can you hear me?
Yes, Niranjan. I know you're from Goa.
Yeah. Sir, excellent to see you, and we are very happy. More than 2,913 members are joined from India, and plus other members are from Sri Lanka, Nepal, Nigeria, Africa, and Southeast Asian countries, sir. Just to hear all of the expert people, and really amazing, sir. In spite of your busy schedule, you could come here. Thank you so much.
Thank you, Niranjan, and thank you, everybody.
Thank you.
Thank you, Sujata. Thank you, Kamal.
Thank you, Sujata.
Now we go on to our next session. I consider it quite a privilege to introduce our next chairperson, Dr. M.E. Yolekar. Sir is a former Dean of Science and KM Hospital and the Professor Emeritus in Veterinary Medicine, St. G.S. Medical College. Sir, we welcome you and we are very honored to have you amongst us. Yolekar, sir.
Yolekar, sir.
Sir has logged in.
He was on, yeah.
Thank you, Dr. Niranjan, for inviting me. Now,
yes, sir. Welcome, sir. Welcome, Munge, sir.
Yeah, now API is the largest organization of physicians in India, because this is the World Congress, I must say that. And to introduce Dr. Tivaskar, let me tell you that he has been a Secretary General of the organization, very dynamic and active. And right now he's shifting from the organizational mode to the editorial mode. He is an eminent physician and diabetologist. I request you to start your talk, Dr. Tivaskar.
Thank you very much, sir. Thank you. I really appreciate your kind words, and it's always a pleasure and a privilege to get introduced by the likes of Dr. Yolekar, sir, and everybody. I'm. Can you allow me to share the screen, please? I'm not able to share the screen.
We have enabled the same, sir.
Okay, I'll just try. Yeah. Okay. Is it visible?
Yes, sir.
Yeah, perfect. So Shashank has beautifully elaborated, anemia in an acute situation. So what I'll try and do in next 15 minutes time or so is, give a brief overview of how different anemia can be in the chronic disorders, because anemia in an acute situation or anemia presenting acutely is one of the challenges, but not only diagnosing the cause of anemia in the chronic disorders, but managing anemia in the chronic disorders is altogether a different ballgame. And before I do my deliberation, I would like to express thanks to entire team, not only of Foxy, Moggs, Dr. Niranjan, Dr. Komal, but also Science Integra team for giving me this wonderful opportunity. And we will all agree that Shashank showed this wonderfully well, that South Asian population has a very, very high prevalence of anemia, and almost every second person in this holy country has anemia as a challenge. But we also have a challenge of chronic metabolic diseases like stroke, obesity, diabetes, hypertension, dyslipidemia, malignancies, organ transplant. So we are all now currently caught up into a confusion of economic health-related burdens as well as the technology. And the outcomes are fairly worse when anemia is super added today. So it always reminded me of a beautiful National Geographic picture which got published in 2006 National Geographic magazine, showing a 4-foot kayak approached by a 20-foot great white, and you're caught up in the midst of nowhere. Exactly similar thing can be a problem when you are managing the patients of anemia of the chronic disorders. Prevalence, Shashank has beautifully alluded. And look at this. Every 9 out of 10 women in India has anemia in the fertile situation. Now that is an alarming statistics. And globally, we have around 2 billion people with crude anemia. And look at the cost which gets involved. Nearly $220 million per year US. So what exactly is chronic anemia of the chronic disorder is? Now this is, I would say, one of the most mind-blowing things of late I had come across. If you look at the red blood cell production in the bone marrow happening, you can really see that the total production of red blood cells is 173 billion cells every day, to give us an hemoglobin of 50.7 in men and 13.8 in women, plus or minus 1.5. So that means that you can imagine the amount of production that RBCs are made to. And that's the reason why the diagnostic criteria, according to the World Health Organization and National Kidney Foundation, is this: that when we label somebody to have anemia, that means we are talking about the hemoglobin of less than 13 for males and less than 12 for women, with a hematocrit of less than 39 in men and 37 in women. And to define anemia of the chronic disorders, I would say that anemia present in the chronic infectious and or metabolic or anti-inflammatory conditions or the neoplastic disorders, which is not due to the marrow disorder and occur even though the iron stores or vitamins are adequate. So irrespective of the iron stores, independent of the vitamins and the micronutrient stores, the anemia will present. And unfortunately, it has got a direct impact as far as the cardiovascular outcomes are concerned. Not only that, the longer the duration of anemia, higher is the mortality risk. And that is the reason why we need to not only diagnose them at time, but also manage this anemia adequately. And why we should learn about the chronic diseases related anemia, how common it is. It is the second most common anemia, I can say. After iron deficiency anemia, which is the first one, the anemia of chronic disorders is the second most common anemia that you're going to encounter in your day-to-day clinical practice. And it accounts for around 23 to 50% causes of anemia, cases of anemia. And it can be also labeled as anemia of chronic inflammation. What are the chronic, common clinical conditions which are associated? Usually, apart from the chronic infections and malignancies, diseases like chronic kidney disease, chronic heart failure, hepatic diseases, pulmonary diseases, diabetes, chronic organ transplant patients, autoimmune and connective tissue disorders, rheumatic disorders, all can be associated with anemia of chronic disorders. How do they really actually manifest? What is the mode of the pathophysiology and pathogenesis? It is usually through a dysregulated immune and inflammatory cytokine mechanisms. It leads to ultimately the blunted erythropoiesis production. This blunted erythropoietin production leads to reduced RBC lifespan. This reduced RBC lifespan, along with what is very, very interesting, is what we know it as a dysregulated iron homeostasis. So what do you understand by dysregulated iron homeostasis? And Shashank again beautifully alluded to the scenario of role of hepcidin there, where in a situation of anemia of chronic disease, there is, in the presence of anemia, there is a low or normal total iron binding capacity, the transferrin levels are low, and there is always a low reticulate cell. And the primary feature is the accumulation of iron in the reticuloendothelial macrophages. So that is extracorporeal iron deposition happening in the extracellular tissues apart from the red blood cells and the storage organs. And this is what exactly Shashank talked about, is the role of hepcidin. Now, I don't know how many of you are aware about this latest development in hepcidin science. Is this that this is one area which is continuously getting explored for one of the futuristic therapy for not only managing acute anemias, but also iron deficiency anemias, but also anemia of the chronic disorders. Now we need to understand that hepcidin is the key regulator protein for the iron absorption and distribution. It is generally produced in liver and is responsible usually for picking up of the iron and storing it either into the liver or into the bone marrow. Now, most importantly, it is the only known degradation product, the degradation enzyme which actually causes the degradation of the ferroportin, which is the only known iron transporter from the intestinal epithelium to the bone marrows. So depletion of ferroportin will ultimately stop the transfer of cellular iron to the plasma and bone marrow. That is the place where the role of hepcidin comes to. And any inflammation, no matter it could be acute or chronic, due to the excessive interferons or interleukin 1 or interleukin 6, as it happened in COVID as well, will cause increase in the hepcidin production. And remember that this will lead to reduced iron absorption. The iron will not get absorbed from the intestinal epithelium. It will get shed away from the stool in spite of the oral iron therapy. Usually, iron will not get absorbed. And this is the classic hallmark of anemia of the chronic disorders. Clinical manifestations are almost similar like anemia, usually pallor, fatigue, weakness, decreased exercise tolerance, shortness of breath, and the manifestations of the underlying disease, along with the night sweats, myalgia, anorexia, lack of zest, everything can be present. Are there any diagnostic parameters which can actually tell you how to diagnose anemia of chronic disease? Yes, of course. Always and always remember, pure anemia of the chronic disease will never present you with severe anemia with the hemoglobin of less than 8. In a situation where anemia presents to you with severe anemia, where hemoglobin is less than 8, you need to think cause additionally to anemia of the chronic disorders, or it can be the combination of anemia of chronic disorders and iron deficiency anemia manifesting together. The hematological markers usually are, always remember that if it is iron deficiency anemia, the serum ferritin levels will be low. They will be less than 30 nanograms per ml. But if the serum ferritin levels are more than 100 nanograms per ml, that talks and is an absolute classical diagnosis of anemia of the chronic disorders. You can look at any other markers like CRPs or ESRs, or even sometimes you can look at the total iron binding capacities. But remember that apart from the baseline investigations related to the cause of the chronic disease, purely the hematological investigations, actually the single most important investigation, which is the most important differentiating point between the iron deficiency anemia and the anemia of the chronic disorder, is serum ferritin level. Easily available, easily done. In anemia of chronic disorders, serum ferritin level may be normal or it can go up and usually above 100 nanograms per ml, where in iron deficiency anemia, the serum ferritin levels will always be reduced. A common question which is asked, is the bone marrow examination necessary in the patients of chronic anemia with the anemia of the chronic disease? Not necessary. Only in few select situations where you are suspecting primarily a hematological challenge as a cause of anemia along with the chronic disease, like patient has a myelodysplastic syndrome or probably a hematological malignancy. In that situation only, usually bone marrow is advised. How do you differentiate both anemia of the chronic disorders and anemia of chronic disorders plus anemia which is secondary to iron deficiency? These are all the list of the investigations which you can do. The commonest investigation we discussed is ferritin, but also there can be a soluble transferritin receptor levels which can be asked, and you can also do the ratio of soluble transferritin receptor and the log ferritin. Usually when the anemia of chronic disorders and iron deficiency anemia coexist, this log ratio of soluble transferritin receptors and log ferritin will be more than 2. So commonly, the easiest way to look at it is just do hemoglobin, where you can see that in anemia of chronic disorders plus iron deficiency anemia, there is always a severe iron deficiency and severe anemia. Hepcidin levels are usually high, and remember that few laboratories they do hepcidin levels. Also look at the mean corpuscular hemoglobin and also look at the red tick count, which will surely give you the clue. So overall algorithmic approach for the diagnosis and management is simple. Patient presents to you with anemia, look at the simple CBC report. Look at what first thing that you are supposed to look at is the mean corpuscular volume. If the mean corpuscular volume is above 100 femtoliters, you are directly dealing with megaloblastic anemia and start working in that direction. If the mean corpuscular volume is less than 100 femtoliters, then you start exploring the possibility of the iron challenges or the anemia of the chronic disorders. Then come to the next step of doing the serum ferritin levels and probably the transferritin saturations. Now, if the serum ferritin levels are less than 30 and the transferritin saturation is less than 20%, then you are dealing with iron deficiency. If serum ferritin levels are normal and transferritin saturations are less than 20, it's quite likely that this is anemia of chronic disorders plus iron deficiency anemia coexisting together. And if serum ferritin levels are above 100 nanograms per liter and the transferritin saturation is above 20, that tells you that this is purely anemia of chronic disorder. And then probably you can go ahead for the therapy. Lastly, how do you treat these patients? The basic treatment is the treatment of the underlying disease causing this anemia. What are the other therapeutic options? Can iron therapy be offered to each and every patient of chronic diseases, anemia of the chronic disease? No. Even though there are three prominent options which are available, either you are doing the blood transfusions to these patients, recombinant human erythropoietin therapy, or iron therapy. But remember that if the patient has ferritin of above 100 nanograms per ml, remember that whenever you are using an iron therapy, always be very, very careful, because extra iron load can trigger a very, very severe immune reaction, which is called as a Fenton reaction, and which can be a challenge. So whenever you want to treat, be certain that there is an additional iron deficiency anemia, and then only induce the iron therapy. Just by looking at the hemoglobin, please do not start iron therapy in these patients. And especially in the patients, those who have got combined anemia of chronic disease and iron deficiency anemia, the best mode to treat them is usually by the parenteral iron therapy, because oral iron therapy, because of the excessive hepcidin levels, will not be effective. Always remember that. And there are various iron IV preparations which are available. The latest ones we are all using are usually carboxymaltose combinations. We also have the dextrans. We do have got the iron isomaltosites. But always remember that whenever you are treating these patients, you need to have the facility to treat acute anaphylactic reaction in your setup if you're trying to manage these patients on a daycare basis or on the OPD basis. What are the emerging therapies in this area? There are so many. We are looking, Shashank has beautifully talked about the nanoparticles. There are anti-cytokine therapies which are available. Iron chelation, Shashank talked. Hepcidin antagonists are being explored. This is what I was meaning when I was talking about hepcidin. Ferroportin and agonists we are talking about, or a combination of erythropoietin plus iron therapy, or the recombinant erythropoietin modulation therapy. They are all the therapies which are on the horizon, and I'm more than sure about that in coming decades time, these therapies would be available for these patients. Finally, to conclude, I will end up with a beautiful saying of two people, our late great president APJ Abdul Kalam and Stephen Hawkins. The greatest reason for the failure is not ignorance. It is the illusion of knowledge. Thank you very much, Dr. Yevlekar, sir, for chairing this session. It's been always a privilege and a pleasure to have you as my teacher, my mentor, and my chairperson. Thank you very much. Over to you, Chair Yevlekar, sir.
Thank you, Doctor. Dr. Tivaskar has highlighted very, very carefully the problem of anemia in chronic disease. And he has also particularly highlighted the importance of serum ferritin in particular. And also, the both can coexist. That is extremely important. We are all aware in clinical practice, if there's a patient of hypothyroidism, unless we give thyroxine, anemia will not be corrected. Same way in CKD, we know that unless erythropoietin is given, the anemia will not stand corrected. And of course, nowadays, therapeutics, particularly of lupus and such other diseases, can induce anemia to long-standing chronic condition. I think you have highlighted all the points that are extremely important. And when we treat anemia, we have to be very careful. Of course, one or two important types that we deal with in tropical now, malaria with hemolysis, anemia will be rapid onset. Patient may be in ICU, all parameters compromised. So acute febrile anemia is also, that is of course the job of the physician, but mostly obstetrician gynecologists, I think they are well aware of how the blood can get lost, how PPH can be treacherous. In the recent times, you have seen some examples. All said and done, you are good at anemia pregnancy, but this chronic condition we have always to keep in mind. And let me tell you, let it be a joint work of appropriate correction anemia associated with chronic condition. Thank you once again. And I hand over the thing to the organizer.
Thank you so much, sir, for your wise words. It was a privilege to have you with us. Thank you, sir. We go on to our next session. I kindly request Dr. Komal Chauhan to chair the next session and introduce our next speaker, Dr. Carmen Choi.
Yeah, thanks, Dr. Sidra. And it is a great pleasure to introduce Dr. Carmen Choi. She is representing the Obstetrics and Gynec Society of Hong Kong. And she has been in a current position as the head of Department of Obstetrics and Gynecology at Seung Kong Ho Hospital, Hong Kong. Consultant gynecologist with special interest in oncology and minimally invasive surgery. She has devoted to improve the quality care of the gynecologic patients through establishment, enhanced recovery after surgery program, and patient blood management for gynecology patients in the hospital. So I think this is the blood management, something related to anemia, and actively involved in public education on iron deficiency, anemia, and patient blood management. I think you have a very interesting work which you are doing, and we are really eagerly waiting to hear from you the topic iron deficiency anemia in gynecology. Over to you, Dr. Khan.
Okay, thank you. Hello. Yes, so thank you very much for the kind introduction. And on behalf of the Obstetrical and Gynecological Society of Hong Kong, I would like to thank the Mumbai OG Society, President Dr. Niranjan Javan, and organizing committee for inviting us to join this great event. So my topic of presentation is iron deficiency anemia in gynecology. So please allow me to share my screen. So is it okay to see my slides?
Yes, we can.
Okay, thank you. So WHO has defined anemia as a hemoglobin concentration of less than 120 grams per liter in non-pregnant women aged 15 or above. And for pregnant women, a lower hemoglobin cutoff was used of 110 grams per liter. Mild deficiency anemia is defined as a hemoglobin level of 11 to 12 in non-pregnant women, and moderate anemia is defined as a hemoglobin level between 8 to 11, and severe anemia is defined as hemoglobin level of less than 8. I would like to draw your attention to the footnote here. It mentions that mild anemia is actually a misnomer of iron deficiency, of mild iron deficiency, because iron deficiency is already advanced by the time anemia is detected, because hemoglobin change is a late event during the course of iron deficiency. And the deficiency has clinical consequence, for example, a perception of fatigue or decrease in physical performance, even when no anemia is clinically apparent. And the prevalence of anemia is a global health indicator, which indicates poor health and poor nutrition. In year 2019, the prevalence of anemia in reproductive age women is 29.9%, which is equivalent to more than half a billion of women suffering from anemia globally. For non-pregnant group, the prevalence of anemia is 29.6%, and for the pregnant group, the prevalence of anemia is 36.5%. And over the course of 20 years, the global prevalence of anemia is relatively stagnant for both pregnant and non-pregnant group. For the pregnant group, there's a slight decrease. But for the non-pregnant group, the prevalence is rather steady over these 20 years. And anemia is also a global health problem affecting both low-income and high-income countries. The prevalence of anemia varies substantially across regions and countries, reflecting both economic status and the associated nutritional deficiencies in that region. Highest prevalence of anemia is seen in West Africa and also South Asia. The prevalence of anemia in Africa reaches 37.6%, and the prevalence of severe anemia is 1.6%. The reasons for the high prevalence in this area may be due to the high prevalence of malaria, sickle cell, and thalassemia in this region. Iron deficiency is the main cause of anemia in women, and it is estimated that 50% of anemia in women could be amenable with iron supplementation. Prevalence of anemia in reproductive age women is 30%, of which 50% is due to iron deficiency, which is much higher when we compare the prevalence in postmenopausal women, where the prevalence of anemia in postmenopausal women is only 2 to 5%, which is similar to the prevalence in men. And this reflects that this difference reflecting that the physiological changes during women's reproductive life, mainly the menstruation, pregnancy, and childbirth, are a main contribution to iron deficiency in women of reproductive age. Women during the reproductive age will have regular blood loss through menstruation. The average amount of blood loss during the menstrual cycle is around 30 to 50%. If the blood loss is more than 30 to 50 mil, if the blood loss is more than 18 mil, then the blood loss is considered to be excessive. If we know 1 mil of blood equals to 0.5 milligram of elemental iron. So if a woman persistently suffering from heavy menstrual period of more than 18 mil a month, which means that the woman may lose more than 500 milligrams of elemental iron per year. This amount could be substantial if this loss could not be replaced adequately by adequate oral iron intake. Secondly, pregnancy will also increase the demand for iron during the whole course of pregnancy. An additional 1,000 milligrams of iron is required during the pregnancy, while 300 milligrams is mainly for the fetus and placental growth. 500 is for the increase in the maternal hemoglobin mass. The daily requirements of iron increases from 18 milligrams per day during the non-pregnant state and increase up to 27 milligrams per day in the pregnant state. GI absorption of iron also increases during the course of pregnancy, from 1 to 2 milligrams per day increases to more than 6 milligrams per day in third trimester. Moreover, childbirth will also, the process will also involve some blood loss, usually less than 500 ml. And there are studies showing that increase in parity will increase the risk of iron deficiency anemia in women. Therefore, the impact of iron deficiency is great and which cannot be ignored. This table showing the different causes of iron deficiency, which could be physiological, could be environmental due to poor intake, could be pathologic with reduced absorption or increased blood loss, could be drug-related, genetic, or iron-restricted erythropoietic cause. In a high-income country, it is believed that excessive menstrual blood loss is the more common causes of iron deficiency anemia in women, accounting for 20 to 30% of the cases. In low-income country, the leading causes would include insufficient dietary iron intake due to poverty or worm infestation. It is important to know that causes for iron deficiency anemia are often multifactorial, and different causes could coexist at the same time. Heavy menstrual bleeding, as I've mentioned, is a significant cause of iron deficiency anemia in women. And heavy menstrual bleeding is defined as excessive menstrual blood loss which interferes in women's physical, social, emotional, and/or material quality of life. The prevalence of heavy menstrual bleeding reaches 37 to 38% and affecting both adult women and also adolescents. The impact of heavy menstrual bleeding, first, it may cause iron deficiency or iron deficiency anemia and develop symptoms of anemia. Or in severe anemic cases, the patient may develop heart failure. Anemia itself will also adversely affect on work performance and affecting the productivity. Heavy menstrual bleeding itself, even without anemia, can affect quality of life, relationship, work, and also social life. Women expresses that the heavy menstrual bleeding has significant impact on daily activities. It is a cause of major inconvenience to their lives. They tend not to participate in social activities during the heavy flow, and also have an adverse impact on sexual lives, and also negatively affecting their work or school performance, and may need absence from work or school due to heavy menstrual bleeding. We usually refer to the fecal pine-cone system for classifications of causes of heavy menstrual bleeding. PARM usually refer to the structural cause: P, polyp; A, adenomyosis; L, leiomyoma; M, malignancy and hyperplasia. While the corn usually refer to the non-structural cause, for C, which is coagulopathy; O, ovulatory dysfunction; E, endometrial; I, iatrogenic; and N, not otherwise specified. I'll just briefly go through the assessment for heavy menstrual bleeding because of time. We will ask for a detailed menstrual history, the cycle regularity, flow volume, and associated symptoms. Other relevant history, for example, anemia, bleeding tendency, which may direct us to do some coagulopathy screening, and virus symptoms. And also we need to ask the impact of heavy menstrual bleeding on quality of life. And also we will take a history on comorbidities and women's plan for contraception or fertility plan, because this may affect our choice of treatments. Pelvic exam will be done to exclude pelvic mass and other local genital tract pathology. Pregnancy tests will be done for all women presenting with abnormal bleeding to rule out pregnancy. For blood test, every woman will have their complete blood count done, and iron deficiency, if there's iron deficiency anemia, there will be a drop of hemoglobin, a lower MCV and MCH level, and an increase in red cell with indices. Ferritin should be checked for all women with a heavy menstrual bleeding as well, because as I've mentioned, a drop in hemoglobin or a change in red cell indices is usually a late change in the course of iron deficiency. And we will check a thyroid function test or other hormone profile or coagulopathy screen as directed by history and clinical suspicion. Pelvic ultrasound will be done if there is a clinical suspicion, and endometrial assessment will be done depending on risk assessment, usually in the form of bedside endometrial biopsy or outpatient hysteroscopy. Ferritin should be checked for every woman presenting with heavy menstrual bleeding, because in the past, we just checked the hemoglobin. If the hemoglobin is low or the red cell indices, for example, a low MCV and MCH is seen, then we will do the ferritin. But I think ferritin should be routinely checked along with the CBC at the same time, because serum ferritin is the most specific and effective test to reflect iron store, and it is usually the first test that could be checked during the blood when there is a loss of iron in blood. Usually, is the first index to turn abnormal, and for hemoglobin to drop, usually it is a late event. Usually, we will use the ferritin cutoff of 30 microgram per deciliter, which is highly suggestive of iron deficiency. A ferritin cutoff of less than 15 microgram per deciliter is confirmatory of iron deficiency. However, we need to be cautious when interpreting ferritin in case of inflammation, because ferritin is an acute phase protein. It could be raised in inflammation, infection, liver disease, or malignancy. CRP may be useful to identify coexisting inflammation in this kind of cases. If inflammation is present, a higher cutoff value may be needed to diagnose iron deficiency. Alternatively, we can consider checking serum transferrin saturation, but this test is not widely available. For the management of heavy menstrual bleeding, usually is twofold. And first, we need to treat the heavy menstrual bleeding, and secondly, we also need to correct the iron anemia and also replenish the iron store. And we need to remember that gynae and non-gynae causes of iron deficiency anemia can coexist. Therefore, if iron deficiency anemia does not respond well with adequate treatment, reassessment and further workup is required. For example, we may need to rule out GI tract pathology. For the treatment options of heavy menstrual bleeding, there are several factors to consider when we consider the treatment options. For example, the presence of structural pathology, for example, fibroid, polyp, adenomyosis, and the symptoms, the comorbidities, which make some kind of hormonal treatment as a contraindication, and also women's preference. For pharmacological treatment, it can be non-hormonal and hormonal. Usually, we will use the non-hormonal treatment first because there's not much side effects and it can effectively reduce the menstrual blood loss by 50%. But if the woman has contraceptive need and also willing to use hormonal treatment, then usually we will suggest levonorgestrel releasing intrauterine system as the first line of treatment, because it can effectively reduce the amount of menstrual flow and also it could significantly improve the quality of life. Ulipristal acetate and GnRH analog are mainly reserved for refractory and preoperative cases, and their use are mainly limited by their side effects. Surgical treatment include uterine artery embolization, endometrial ablation, myomectomy, or hysterectomy. For the treatment of iron deficiency, the treatment goal is to correct anemia and also replenish the iron store, but we also need to take account of the ongoing regular menstrual loss. For first-line treatment, oral iron will be the first-line treatment because it's simple, inexpensive, and effective. First form is better absorbed, and prescription advice need to be given to women to take with empty stomach, and also we usually prescribe vitamin C together with the iron sulfate. And we also need to advise patients to avoid some food which may impair iron absorption. And hemoglobin is expected to increase by 2 grams per deciliter every 3 to 4 weeks. And once hemoglobin has normalized, we need to continue iron treatment for 3 more months to ensure the stores are replenished. And before we stop the treatment, we need to check the CBC and ferritin to confirm the resolution of iron deficiency. Side effects are common and is also a cause of non-compliance to iron therapy. And if intolerance to iron sulfate, we can consider alternative preparation with iron polymaltose complex, which is associated with GI side effects, similar efficacy, and do not have any interaction with food. And however, cost is maybe a concern. In the past, we usually give iron, 300 milligram of iron sulfate 3 times a day, hoping that giving more iron to the woman, it it can increase the iron absorption. However, we are changing our practice because recent studies showing that if elemental iron dose of more than 60 milligrams were given, hepcidin concentration will increase, and this increase in hepcidin concentration will block GI absorption for subsequent doses and making GI absorption less effective. And studies showing that iron absorption is more efficient with intermediate dose and alternate days. If we are giving iron in alternate days and with intermediate dose, they could achieve same effectiveness in raising the hemoglobin level, but with the advantage of, and also have the advantage of fewer side effects and better compliance. However, it may take longer time to complete the whole course, and therefore this regimen is usually suitable for mild anemia. High dose of elemental iron do increase absolute iron absorption and can be considered in severe iron deficiency for a faster increase in hemoglobin concentration. Second line treatment will be intravenous iron, and actually intravenous iron therapy has reshaped our management of iron deficiency anemia in gynecology. There are 3 generations of iron. The first generation is now out of phase because of gastro-induced anaphylactic reactions. Second generation has fewer side effects in terms of anaphylaxis, and third generation IV iron in larger dose can be given in a shorter infusion time. Advantage of IV iron therapy is that it's more effective than oral iron therapy, allow rapid repletion of iron level, and allow large iron replacement in a single infusion, and reduce the need for blood transfusion. And most importantly, it is also safer than blood transfusion. In gynecology, the indication of IV iron is that it failure to respond to oral therapy and recurrent bleeding is excluded, cannot tolerate or incompliant to oral iron therapy, or poor absorption of oral iron due to underlying comorbidities, or rapid correction of iron deficiency anemia is required, for example, during severe anemia or before major surgery. And I don't really go through this one because it has already mentioned multiple times in the previous lectures, and the contraindication, adverse effect, and drug administration are just similar. In gynecology, transfusion is usually reserved for those with acute blood loss or severe anemia with hemodynamic instability, or if patient is stable hemodynamic, transfusion sometimes will be used to top up hemoglobin quickly if ongoing bleeding is anticipated or hemostasis may not be able to achieve shortly. However, there could be a risk of transfusion causing major morbidity, and 1 pack of red cell provide around 200 milligrams of iron, and therefore after a transfusion, we still need oral iron or IV iron therapy to replenish the iron stores. So although there are effective treatment for heavy menstrual bleeding and iron deficiency anemia, however, there are still a few barriers that affect effective treatment or eradication of iron deficiency anemia in gynecology patients. First is the low level of awareness of heavy menstrual bleeding. Only 20 to 50% of women with heavy menstrual bleeding will seek medical consultation because most of the women have lack of understanding what is normal periods, and they think that heavy menstrual period is just normal, and they also hold the belief that menstrual blood is detrimental to their health and ought to go out even if they're heavy. Taboo in talking about menstruation openly, because historically talking about gynecological health is a taboo, and also women will feel embarrassed when talking about the menstrual symptoms openly with their friends or family members. Or there could be lack of access to care. For example, they can't find a trusted female gynecologist, or poor experience with previous gynecological consultations. Secondly, patients' belief may also lead to inadequately treated heavy menstrual bleeding. For example, patients may think that menstruation is normal and menstrual blood is bad to their health, so they're very reluctant for any treatment targeting to reduce their menstrual flow. Also, women may have lack of knowledge on the different treatment options of heavy menstrual bleeding that are available to them, reluctant for hormonal treatment, surgical treatment, or hysterectomy because of the fear that these kind of drugs or treatment will have impact on their fertility. Also, sometimes we may not be treating iron deficiency very effectively. First, it is not a routine to screen for ferritin in the past, so iron deficiency anemia may be missed, and iron deficiency may be missed, and hemoglobin change is only a late event. Poor compliance to oral iron due to GI side effects or inadequate knowledge on iron metabolism, so that appropriate prescription advice was not given to the patients by the doctor. And or iron therapy duration is not long enough to replenish the iron store, and also sometimes gynecologists may have lack of knowledge on iron therapy, and also with hesitation to start IV iron therapy due to the worry of anaphylaxis. So as a gynecologist, our way forward in combating iron deficiency and anemia in women will be followed. First, we need to engage in public education and also raise women's awareness on heavy menstrual bleeding so that they know what is normal and what is abnormal. Secondly, we need to improve access for women with heavy menstrual bleeding. Third, routine screening of iron deficiency with ferritin should be recommended, and so that we can initiate treatment for iron deficiency early with oral iron therapy. We also need to enhance patient education on iron therapy, treatment options of heavy menstrual bleeding, so that hopefully we can improve their compliant treatments. And also we can consider early start of IV iron therapy if oral iron is poorly tolerated or absorption is impaired. And consider IV iron therapy and transfusion for severe anemic patients if the patient is hemodynamically stable. And at population level, or public health level, we can consider routine iron supplementation for women in areas with high prevalence of anemia. So that's the end of my presentation. Thank you.
Thank you so much, Dr. Carmen. It was a lovely, wonderful talk, and I think you covered the most common aspect of gynecology, that is a patient coming with a heavy menstrual bleeding. That is when we should definitely try to aggressively treat anemia. And there are barriers, as you said, very commonly, that patients are not aware. They are just aware about the bleeding, what they are having, but they're not aware about the anemia, which is going to have the weakness. They may come with weakness and symptoms like it, but they are not. They're ignorant of the fact that they are really anemic, and they have to really do something about it. And this is really very important, that we need to educate, I think, the common public, as well as, we need to diagnose, screen patients effectively very early and treat them. So this is very informative talk, and thank you so much for being here.
Yes, thank you.
I'm just checking the chat box for any questions. I think Dr. Sidra.
Hello. Am I audible?
Yes.
No questions as of now.
I think it was very informative and very lucid presentation. Thank you so much, Dr. Kathy.
Thank you.
Ma'am, we request you to introduce our next speaker, Dr. P. Balamba.
Anemia during pregnancy negatively affects both the mother and the fetus, accounting for half the maternal deaths worldwide. Although oral iron therapy effectively treats anemia during pregnancy, the associated gastrointestinal adverse effects often cause non-compliance. Therefore, pregnant women are recommended parenteral iron preparations like ferric carboxymaltose injection, or FCM. However, there is a dearth of data describing FCM usage in Indian pregnant women. To assess safety and efficacy of FCM, researchers from India retrospectively examined Indian women who received FCM during pregnancy. Having analyzed 271 women for safety and 168 for efficacy, this forms one of the largest cohort studies of pregnant women receiving FCM in Asia. Analysis identified the majority of women as moderately anemic. Both moderately and severely anemic women exhibited a significant increase of 1.2 and 4.23 grams per deciliter respectively in hemoglobin level after 25 days of FCM administration. Moreover, just 20 days post-FCM administration, the women reported significant increase in hemoglobin level. Continuous monitoring during FCM infusions indicated that there was no clinical deterioration of vital parameters such as heart rate, blood pressure, and oxygen saturation. This supports excellent safety of FCM injections. Itching and rashes were the most common adverse effects observed only in 4% of patients. Interestingly, FCM had no adverse effects on newborns of mothers who received it during pregnancy. In summary, FCM is safe and efficacious for treating anemia in a resource-limited setting without any significant adverse effects on the mother and the neonate.
Yeah, now I would like to introduce Dr. P. Balamma. She is the consultant of Shalini Hospital and a vice chairperson of AICUG 1998 in the organizing committee. She has also been a part of organizing committee of AICUG 2011, former president of OGSH, former secretary of OGSH. She's a very senior obstetrician among us and chairpersoning of government body of Prajwala, anti-trafficking agency, that is the NGO. She's into social work. We know her that she has trained all the government and private medical college staff for PPT-CT, that is HIV and AIDS, published scientific papers in national and international journal, and has been an advisory board, the Chief Minister of Andhra Pradesh, and advisory committee on surrogacy to government of Telangana. So we have a really respectable Balamma madam here, and definitely with her experience, she's going to talk on evidence-based management of anemia during pregnancy, focuses on ferric carboxy maltose. Over to you, madam.
Thank you. Thank you very much. Sana, can I have my first slide?
Yes, you can. Yeah, I think
Sana
is sharing. Okay.
Yeah, I'm going to speak on evidence-based management of anemia during pregnancy. My focus will be on pericarboxy maltose, which I have been using since several years now, very successfully, both in obstetrics as well as in gynecology. Can I have the next slide? Yeah. So worldwide, we all also know that 620 million people are living with anemia, and prevalence of anemia during pregnancy globally it is 41.8%, that is 56.4 million pregnant women. And India, if you look at the NFHS side, that is 2019 to 21 survey, 52.2% of pregnant women are anemic. Now, this really tells our story of anemia in pregnant women, where there is poor nutrition and beliefs and lots of traditional way of cooking and all those things, which makes them really anemic. And in the past 2 years, with the COVID pandemic, this has become worse, and we are seeing more and more anemic pregnant women nowadays. Next slide. So if you look at the anemia during pregnancy, forming a consensus, the CDC says less than 11 in first and third trimester and less than 10.5 in second trimester. WHO says less than 11, and according to WHO, mild is 11 to 11.9 in non-pregnant, but 10 to 10.9 in pregnant women, and less than 7 to 9.9 is moderate, and severe will be less than 7 grams percentage. And unfortunately, what we are seeing is whatever be the economic status or financial status of the pregnant women, we are seeing almost all women, in all status of women, all strata of women, more than 50% are anemic, and more than 50% are having less than 7 grams of hemoglobin. Nowadays, at least, for the past few years, this has been the trend. And I don't know what exactly is the reason. And maybe there is some poor absorption of iron, or maybe the way we cook the food, or maybe because of the junk food that most of the people are eating now. But whatever be the reason, the anemia in pregnancy is increasing, and the government of India is, of course, doing a lot to decrease this incidence, because it tells on the maternal mortality as well as morbidity, and also the perinatal mortality and morbidity. We have had lectures on how the neonatal babies, the babies, newborn babies suffer with anemia and what we have to do about it, and we have had lectures about it. Apart from anything, if the mother is anemic, obviously the baby is also going to be anemic. Next. So the cause of anemia in pregnancy, the most important is nutritional deficiencies. Hemolysis and abnormal hemoglobin synthesis, of course, thalassemia is more important, and G6PD deficiency is quite rare, but we have been seeing thalassemia more and more, especially thalassemia minor, where there will be hemoglobin, and without diagnosing thalassemia, if you keep on loading them with iron, and you're going to land with problems of hemosiderin toxicity. And of course, sickle cell anemia we do see rarely. Malaria mostly we see in tribal areas, and blood loss and defective iron, fortunately with the potable water available in many of the states, especially in our state, potable water is available almost every nook and corner. So the helminthiasis and sperm infestations have been very rarely seen now. But amoebiasis, giardiasis, and they are very common. Actually, giardiasis seems to be more common than amoebiasis nowadays. And schistosomiasis we rarely see, but with the women and the families migrating to Gulf, more and more schistosomiasis is also becoming common. Of course, hemorrhoids has become a big problem with all our women. Even in gynecological patients, we do see bleeding hemorrhoids. Antepartum hemorrhage, it's another ballgame altogether. And of course, chronic conditions, but usually in pregnant women, we don't see this. But yes, in HIV positive women, we do see anemia, especially if they are on zidovudine, because it can suppress the bone marrow. And there are many women who are now conceiving after chronic rheumatic and rheumatoid arthritis, and they are being on treatment with mostly HCQs. I don't know whether it prevents iron absorption or whatever it does. And of course, we are also having women who are becoming pregnant after bariatric surgery, which does prevent iron absorption, and they are deficient in most of the iron and other vitamins, also the essential minerals, as well as the trace minerals and trace elements, also also vitamins. Next. So common causes of iron deficiency, like I said, decreased iron intake, vegetarian or otherwise unbalanced diet. Yes, vegetarian actually, should not cause anemia, because if you are eating lots of greens and other things, why should you have anemia? But I think, the way we cook may be a little problematic. And when you overcook certain stuff, naturally the vitamins and other things will disappear from that. And of course, eating disorder, because many people now want to lose weight. And also the obesity, increasing obesity, because of the junk food. Of course, anorexia very rarely we see. And the decreased iron absorption, like I said, the bariatric surgery and other things. And I think H. pylori also has to be a culprit in this. And actually, the National Institute of Nutrition in our Telangana, they are doing some study, whether H. pylori really decreases the iron absorption. And we will be able to tell you after some time, when they finish their study about this. And of course, concomitant intake of drugs, like taking calcium along with iron. Of course, blood loss, maybe if they enter the pregnancy with previous anemia, like our adolescent girls, most of them are anemic. We have done a school health survey from our Family Planning Association of India. Both boys and girls, both groups have been found to be very, very severely anemic. And most of these girls, especially from the government schools, we have seen that they have lots of problems with nutritional diet. And that is why, the midday meal scheme has been introduced. But most of them, they do come to the school even without having breakfast, which is a very important meal. So that also, I think the government is going to introduce for all these school children, because adolescent girls, if they get married when they become adults, and they embark on a pregnancy, they started with anemic, with a decreased iron stores, and naturally they'll end up being anemic. And of course, frequent deliveries where the iron stores are not replenished. And like I said, gastrointestinal bleeding, which is usually because of constipation and bleeding hemorrhoids. Surgery, like I said, bariatric surgery. Blood donation, very rarely our women do nowadays. And of course, iron demand, because they are many people conceive, during lactation period itself. And of course, young girls getting pregnant, like adolescents. And endurance sports, rarely, because usually they will end up with amenorrhea rather than pregnancy. Next. So what are the consequences? We have heard lots of consequences of IDA, Dr. Carmen's talk also. The antepartum complications can be increased risk of preterm delivery, chronic placental insufficiency, premature access membranes, preeclampsia. And nowadays, when we were students, we thought it used to be a pseudo preeclampsia, but now we know anemia does cause preeclampsia because it interferes with the complement absorption, and it does interfere in the immunity, and it can cause Fenton-Harris reaction and can cause preeclampsia because of the free radical release, when we are giving iron. And intercurrent infections, of course, in COVID patients, in these past 2 years, when pregnant women got infected with COVID, we did see lots of women becoming anemic also. Of course, APH. When we were working in public hospitals, fortunately, nowadays we don't see so many cases, but there used to be women who are coming to us in labor with 4 grams or 5 grams hemoglobin in congestive heart failure. And then, it was a real miracle when we could save them. And of course, we had to transfuse them, and the transfusion itself used to be a problem also with this congestive heart failure. So all those conditions we have seen. And fetal outcomes, naturally low birth weight, prematurity, infections, because the babies are having low iron, mostly they're exposed, the immunity is less and they're exposed to more infections. Congenital malformation, not so much, but neonatal anemia, yes, definitely. And abnormal cognitive development is not only abnormal cognitive development, but I think, the fetal programming for adult diseases also takes part because of the oxygen carrying capacity is reduced and these babies don't receive enough oxygen for development. There must be some epigenetic transformations which can cause all these problems of fetal programming for adult diseases. And maternal anemia contributes to 18% of prenatal mortality and 20% of maternal mortality. And of course, the morbidity, the SAM, severe acute maternal morbidity, if the woman is anemic, and in the postpartum period, there will be more of postpartum blues and other things also. Next. Next. The diagnosis, of course, history and clinical examination. Clinical examination, like I said, nowadays you can't make out because you can't examine the nail because everybody is using a nail paint or some function they will at it. So the most important thing is history of fatigue and easy fatigability, and of course severe anemia, the breathlessness and other things. And the complete blood count is very, very important. Hemogram is very important because we do require the indices. And whenever the mean corpuscular volume is low and mean corpuscular hemoglobin concentration is low, we have to diagnose IDA. They are microcytes, and 40% of pregnant women with true IDA may not have these indices at all. They may have normocytic indices also. But the red cell width distribution has become very, very important in the peripheral sphere nowadays to diagnose iron deficient anemia, because the red cell width distribution will be elevated in iron deficiency. And if you're talking about when the red cell width distribution is not elevated, but in fact it is decreased with low MCV, we have to think of thalassemia, because the microcytes will exist because their hemoglobin level never goes beyond 8 grams, and we have to look at that. Now, serum iron and the total iron binding capacity, there is no point in doing during pregnancy because serum iron has a diurnal variation affected by dietary influences, whereas in pregnancy, naturally, there is a total iron binding capacity increases, even in the absence of IDA, because they have to absorb more iron in these women. Next. Almost everybody spoke about serum ferritin, though it is an acute inflammatory marker. But in iron deficiency anemia, it is very, very important because serum ferritin less than 30 micrograms definitely indicates that there is an iron deficiency anemia. And we do test serum ferritin whenever we want to give IV iron to our women. And in hemoglobinopathy, it is very important because when there is high serum ferritin and hemoglobin is low, you have to suspect either a chronic infection. It can be high even in a urinary tract infection, which is very common during pregnancy, or any connective tissue disorders, which is complicating the pregnancy. Also, the serum ferritin, if it is high, you have to think of thalassemia also, like I mentioned already. And the differential diagnosis of microcytic anemia under evaluation, chronic inflammatory leg toxicity, sideroblastic anemia, very rare. And then if the woman is not responding to oral iron, definitely you will have to test serum ferritin. Suppose the serum ferritin is not increasing in spite of you have given her oral iron, a good preparation of oral iron, and you have advised her to take it on empty stomach, and she has been very compliant. In spite of that, if she is not responding with a rise in hemoglobin, definitely you'll have to look for serum ferritin. In non-anemic women at risk of depletion, iron depletion, especially multifocal gestation, teenage pregnancy, pregnancy with high risk of bleeding, consecutive pregnancies without much of spacing. So prior to parental iron therapy, definitely we have to test serum ferritin. Next. Dr. Carmen has already spoken about the requirements during pregnancy, the iron requirements, the gross total. The fetus will require about 350 milligrams of iron, and the blood circulation, which increases, the RBC mass which increases, will require another 450 milligrams. So that will be about 800 milligrams. Even though the woman saves iron because she's not bleeding during this pregnancy, the daily loss of iron through physiological means, is 200 milligrams. So if you minus that, totally it will be about an increase of almost, 1000 milligrams, and you are 25% of that as stores. So you'll have to give 1,250 milligrams of iron to the woman during the 9 months of pregnancy. Unfortunately, during the first trimester, the iron absorption gets decreased. But in the second and the third trimester, it usually increases to 4.5 milligrams to 7.5 milligrams, sometimes even up to 8 milligrams. But are we giving, previous slide please, are we giving enough oral iron, that is in the diet? That is the moot question, because most of the women, they cannot take so much, because whatever be the diet, the daily diet, our diet, normal diet contains about 15 milligrams of iron, and only 10% of that iron gets absorbed. So if the 10% means 1.5 milligrams, and even if it increases much more during pregnancy, it cannot cope with the requirements of iron during the pregnancy. And that is the reason, we have to supplement them with oral iron. Next. Sorry. So how do we manage the iron deficiency anemia? Next. Next. Now the anemia management, the government initiatives were there. The National Iron Plus Initiative was introduced in 2013 to reduce the incidence and prevalence of iron deficiency anemia across all life stages, including adolescents and women in reproductive age who are not pregnant or lactating. And all healthcare providers at all levels have been identified under the NIPI framework for comprehensive package of continuum of care along with treatment and management of anemia. Next. Now the next was the 12 into 12 initiative, which the previous speaker spoke about also. A multi-pronged 12 into 12 initiative, that is, by the age of 12, all adolescents are supposed to have 12 grams of hemoglobin by 2012. Well, it didn't succeed at all, I feel. The initiative comprises of health and nutrition education, weekly supplements of iron, folic acid tablet, parasite control through periodic deworming, and of course immunization along with measures of capacity building. Next. Next. I'm sorry for this cough because I have a throat infection. Of course, the latest is Poshan Abhiyan Anemia Mukt Bharat, where the government of India is also committed to the World Health Assembly target of percent of 50% reduction of anemia among women of reproductive age by 2025 through Poshan Abhiyan and National Nutrition Mission, which was introduced between 2018 to 22. And the target was to reduce the prevalence of anemia among children, adolescents, and women of reproductive age 15 to 49 by 3 percentage points per year. They took lots of initiatives about this. Next. So in this context, the Anemia Mukt Bharat strategy has been designed building on the existing technical guidance from National Iron Plus Initiative with a multi-pronged approach and a more robust operational framework. In spite of which, unfortunately, the NHFS shows us that there is not much of improvement and still 54% of our pregnant women are anemic. Next. So how do we supplement? Dietary iron. I told you dietary iron is not sufficient to improve anemia during pregnancy. Oral iron. How many really tolerate oral iron? That is a moot question. And which brand of oral iron we have to keep? And of course, parenteral iron. Next. Next slide. Dietary, I told you, the cooking practices, and we do have, heme iron and non-heme iron. Heme iron gets absorbed much better. In our country, most of the population is vegetarian. And even if they are non-vegetarian, they are only facultative non-vegetarians because they hardly eat meat every day. Once a week, perhaps they eat meat. So naturally, they will be anemic. And there are enhancers of absorption like proteins, like heme iron, meat, ascorbic acid, fermentation, ferrous iron, gastric acidity. But ferrous iron, again, the Benton-Harris reaction, it has to get converted into ferric iron and then again to ferrous iron. So naturally, one electron will be released, and then this is a free radical, which can cause lots of side effects. Of course, gastric acidity. Now, every woman, knows how to take a antacid. So naturally, when they take an antacid, iron is not going to be absorbed. Alcohol, I wouldn't say so many people take alcohol, but yes, in Telangana at least, alcohol is a problem amongst women, especially the lower class women who do take toddy and low iron stores even before becoming pregnant and increase the erythropoietic activity, like high altitude hemolysis and all those things. And inhibitors, phytates, calcium, tannins, tea and coffee, herbal drinks, fortified iron supplements, all those things. So dietary iron we cannot depend during pregnancy to improve the anemia amongst pregnant women. Next. And of course, there are lots of fads also in food fads. Many women think that if they take greens, the child will be born dark. So that is another problem that we face. So all these food fads also add to the anemia. The limitations of oral iron, like I said, poor absorption. We don't know why there is a poor absorption. And I personally feel that more and more pregnant women nowadays are not able to absorb iron because most of my pregnant women, obstetric patients, when we prescribe oral iron, the best preparation, maybe the ascorbate we prescribe, we tell them to take on empty stomach, they do comply with the instructions, in spite of which, after 4 weeks, their hemoglobin in fact drops instead of rising. That is because the fetus is taking the iron and their hemoglobin is falling and then iron stores are falling. So we don't know where this the iron is going, which they are taking. Maybe something is preventing the absorption. And like I said, National Institute of Nutrition is doing a study on this. Of course, reduced complaints. Many people know nowadays, we ask them whether the motion is coming dark, and they know if they are not complained also, they will answer yes. And many side effects like bloating, diarrhea, heartburn, nausea, these things, they put them off from taking the oral iron. And comparatively longer time is required to rectify anemia to restore iron cells. And like I said, not sufficient treatment of moderate to severe anemias because we require quicker response. And we don't have sufficient time before they enter labor to increase their hemoglobin percentages. Next. Now here comes the role of parenteral iron therapy in iron deficiency anemia, because we have found that oral iron doesn't work, and in severe and moderate anemia, when we have less time to improve the anemia, we do require parenteral iron. Next. The indications, like I said, prelude of oral iron therapy, non-compliance, and severe and moderate anemia in late second and third trimester. Rapid rectification is required, and like I said, bariatric surgery followed, bariatric surgery followed by pregnancy, bleeding diathesis, when hemorrhage is likely to continue. And of course, contraindications are before 12 weeks, we usually do not give a parenteral iron because we don't know whether it has any problems with the organogenesis. So we don't use parenteral iron during the first 12 weeks of pregnancy. And lack of facilities for resuscitation. So it should never be given in a clinic. It should always be given in a nursing home where the resuscitation facilities are available, because we don't know when what will happen to a woman who is on a parenteral iron therapy. And of course, we should never give it when the ferritin levels are high. And IV iron therapy is superior to oral iron in terms of speed and absolute rise in hemoglobin and replenishment of iron stores. And we all know about the 3 generations of IV iron, like the first generation being the dextran molecule, the low molecular weight as well as high molecular weight. People of my experience, will know about the iron dextran, how we had to sit with the patient when we are infusing the iron dextran, the anaphylactic reactions, when the arthritis with which the women suffered, all these things, we have seen. And that is the reason, we're very, very wary of iron dextran. And of course, the second generation, like iron gluconate and then iron sucrose, sucrose was good. You could give it, Dr. Hema Divakar has done extensive studies on that, 200 milligrams directly IV, but you cannot give more than that because then the anaphylactic reactions are more. And you can't give more than 600 milligrams in a week. So that becomes a barrier for IV iron sucrose. And then the third generation, like iron ferric maltose, as well as the perumoxytol and the iron maltoside. Iron perumoxytol somehow is indicated only in chronic kidney disease, as also the iron maltoside. But ferric carboxy maltose, most of us now have very good experience with the ferric carboxy maltose, the ease of administration, and the higher dosage that we can give. Next.
Dr. Balamba, just a few more minutes, madam.
Sure, I'll finish it.
Thank you.
Yeah. The parenteral iron preparations are usually an iron oxyhydroxide core with a carbohydrate surrounding it. Next. Next. So I already talked about all these things. Next. Next. So the best is, to use the robust iron, so ferric carboxy maltose scores over all these things. And that is the reason, where we can give it quickly, 1000 milligrams at a time we can give, because the infusion, and we have found less and less side effects because of ferric carboxy maltose. Next. And the critical attributes is because it is best suited for real life clinical usage. Number of studies are there from India about this. Next. So the critical attributes, like I said, is robust, short infusion time, test dose is not required. The anaphylactic reactions are much, much less. Next. And this is the dosage schedule, but we usually use 1000 milligrams at a time for infusion. Next. Next. So the clinical evidence in management of FCM during pregnancy is less. Next. So this is a systematic review which showed, better efficacy in increasing hemoglobin, the FCM infusion, and increasing the ferritin levels, and very good safety profile and fewer adverse events. Next, it's a meta-analysis. And then, Indian RCT from AIMS also showed. Next, keep on changing. Yeah. Next. So the anemia Mukbara 6 interventions also, even government of India, wants to use prophylactic iron folic acid supplementation, then, intensified year-round behavior change communication, mandatory provision of iron and folic acid fortified foods in public health programs, periodic deworming, testing of anemia using digital methods and point of care methods, addressing non-nutritional causes of anemia in endemic pockets. All these are part of Anemia Mukt Bharat 6 interventions. Next. Next. And the prophylactic dose has been prescribed for children below 59 months and then 5 to 9 years and school going women of reproductive age and also pregnant women. And in pregnant women, 1 tablet of iron folic acid tablet starting from the 2nd trimester for 180 days and again postpartum also 180 days where it contains 100 milligrams of elemental iron and 500 milligrams of folic acid. Next. So the first level treatment, this is the one which we start, and if they don't improve, then we go for IV iron sucrose. Now FCM is also added on into Government of India guidelines. So naturally, it's a good thing that in our pregnant women we can reduce the anemia by using this even in public hospitals. Next. Next. So the global studies, there are 10 global studies, and Indian studies, there are 17 studies, which all say the current evidence highlighted the data of FCM usage in 3,821 pregnant women. The maximum rise of hemoglobin is 5.5 grams per deciliter, and ferritin rise is 180 micrograms per liter. And I think all of us obstetricians will use this so that we can make our women anemia mukt at least during pregnancy. Next. So these are all important studies which shows the ferritin rise as well as hemoglobin rise with FCM. Next. This is insights from an Indian real-world evidence. We saw Dr. Sanjay Gupta's study, and this is Vidya Bhatt and et al. Their study. Next. 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 270 women were given iron ferric carboxymaltose, and they studied, from baseline to follow-up, and they did find there's a lot of improvement in hemoglobin percentage as well as ferritin. Next. And the first thing which when the woman gets iron is, their cognitive improvement, they become active and they don't get so much tired because, iron is not only required for improvement of anemia, and it is also required for all the cytochrome systems, and especially the brain, brain uses a lot of iron, which we should realize. Next. So adverse events are less than 4%, and mostly it is the itching and that's all, urticaria, which can be easily solved with hydrocortisone injection. Next. Next. So there is no adverse effects in terms of perinatal and neonatal outcomes also in this study. They were studied. Next. And 206 pregnant women, this is global clinical studies. Again, these women, they didn't find any negative effects on the newborns. Next. 95 pregnant women, again, another clinical study which showed it. This is from Spain. Their neonatal outcomes were very good. Next. So the same thing again, next. Next, next. So the summary, to summarize, the dietary modifications may not be so effective. Oral iron supplementation is not sufficient for treatment in moderate to severe anemia. IV iron is superior to oral iron, and quicker results we can obtain. And FCM administration does not require test dose. That is the advantage. Not associated with hypersensitivity like in iron dextran, can be administered safely in higher dose, short duration. Substantial global and Indian evidence to show that there is no side effects on the neonatal outcome or in the maternal outcome. And in fact, we improve the hemoglobin of the pregnant women and their iron stores. The maternal mortality also can be reduced, which is again a Millennium Development Goal. And FCM administered to pregnant women, treatment of IDA is not associated with hypersensitivity reactions, which are adverse. Next. Thank you very much.
Thank you so much, Dr. Balamma. I think it was a real extensive, very lecture. You covered every aspect of iron deficiency, anemia, regarding emphasis on the diet, food fortification, government guidelines, protocols. I think it was very nice, and you have highlighted only the key points. The messages, what you have said, are real take-home messages for everybody. Thank you so much. And I can see Dr. Kavita Bapat and Dr. Niranjan Chavan joining, and she was there along with me for your talk, and I am asking some expert comments from you. Dr. Kavita.
Hi, thank you so much, Komal. I really congratulate Dr. Niranjan for having such a wonderful conference today. He is a president of MOGS, and I always wish him the best, and such a good wife he is having. So thank you so much for inviting me for such a nice conference. And I'm so happy with the Balama madam's all the description about FCM. So FCM is basically the molecule of today and a molecule of future. It's not only the one point with it, it's the point that in a future that this molecule should be used in antenatal patients only, and for each and every patient we should make some guidelines, we should have something for the FCM, and we can use it regularly because we know the amount of increased hemoglobin and everything. So for the not only the Bharat Mukta Anemia Bharat, but we are for the neonatal outcomes. We need this molecule very much. Thank you, Balama madam, for such a nice and elaborate description. And I was there throughout listening you. And though I was busy in inauguration, me and Niranjan. So thank you so much once again, Niranjan, for inviting me. Yeah.
Thank you, Balama madam. Wonderful presentation you have done. And Dr. Madhuri Patel is right now on the stage. So we are doing her locum. So we are in the habit of doing locum of each other. And we are blessed, madam, with your 50 years of practice in Hyderabad and the efforts which you have taken to reduce anemia. Even Shanta Kumari madam is here today, and it's a great opportunity for all of us to connect. We are having two actually programs relayed all over the world. So it was really great. And thank you, Dr. Kavita, for joining along with us today in spite of all this busy schedule. Now,
yeah, before I think...
I don't think that... Komal, just in 2 lines you can conclude, because probably we don't want to disturb, and we are both inviting Dr. Alia also for her lecture. Yeah.
Yes, welcome Alia madam, and it's a great honor that you are joining us from Pakistan. And Alia madam is currently the chair of the oncology committee of South Asian Federation of Obstetrics and Gynecology. It's an honor and privilege that I am working with her since last 2021. She's the professor of gynae oncology, a wonderful division they have at the Aga Khan University, Lahore. And she has a lot of efforts in preventive oncology and cervical cancer. And today we are going to speak, I think madam is going to speak on anemia in gynae oncology. I hand over the mic to Dr. Komal, and we will be with you. Thank you.
Thank you so much. Thank you so much, Komal.
Thank you so much. Dr. Alia, before you, just at the time you're sharing your screen, I would just like to read some comments from the viewers who have passed on such lovely comments for us. This was really nice to see such an expanse congress being put up with doctors from across the world. That is from Dr. Siddharth Saha. And this is one more really a nice one, that Dr. Niranjan and the various organizations have come together consistently for 2 years is real achievement of bonhomie for a common cause. Keep up the good work. This is from Dr. Sandra Lewitt from Birmingham. Brilliant effort, and so good to see all fellow gynacs and all doctors coming for a common cause. So these positive comments actually keep us going, and it really feels very good that we are touching, and so many people are viewing us. So Dr. Alia, you can share your screen and start.
Thank you. Can you all hear me clearly?
Yes, we can hear you.
Yes, and can you see my screen as well?
Yes, yes.
Thank you, Dr. Niranjan and Professor Kavita and Dr. Komal for this kind invitation to be in this esteemed Congress. I was listening to the previous speaker and Dr. Balamba, and this was really nice talk. And today I'm going to talk about a little different topic, which is very important because anemia in gynecologic oncology is a serious neoplasm correlated state and an important problem for patient due to a significant negative impact on quality of life, and for physicians also because it causes interference with the therapeutic practice. So today my roadmap is I'm going to talk about cancer-related anemia. the pathogenesis, differential diagnosis from iron deficiency anemia, workup of cancer-related anemia, and how do we manage it. Up to 39% of cancer patients, when they first present, they have anemia at the time of diagnosis, and up to 40% will have iron deficiency anemia. So what is cancer-related anemia? It is a significant, it does have a significant clinical impact in cancer patients. It is related to a decline in quality of life with progressive worsening of cognitive function and energy and activity levels. So patients exhibit fatigue, lethargy, dyspnea, anorexia, and have difficulty concentrating, which can compromise the overall functional setup and reduce adherence to anti-cancer treatment. Hence, patients, it is a negative prognosticator for disease progression and survival. So we can see that it does affect survival as well. The cancer-related anemia can be sorted into two main categories. So the first one is the patients will have normal hemoglobin values before starting medical treatment, and these are patients who have limited and locally advanced resectable disease. The second group is when we have not started any treatment and you diagnose anemia. These are often patients who have advanced cancers and they are receiving chemotherapy, and this is the real cancer-related anemia due to chronic inflammatory status existing in advanced cancer, and up to 30% of patients will have this cancer-related anemia. This is more common in lung cancers, in solid gynecological cancers, genitourinary cancers, and GI tumors. So if you look at the pathogenesis of anemia, there are different mechanisms which contribute to anemia. So if you look on this side, there may be blood loss because of surgery. There may be blood loss because of, in gynecological tumors, patients bleed before they are diagnosed and they receive treatment. And the colon and GI cancers, they bleed. They also have coagulopathy, and that's how they have blood loss. So also there is chronic inflammation leading to cachexia and malnutrition. There are nutritional deficiencies, and they lead to depletion of iron stores, and they both lead to, both these blood loss and nutrition deficiency will lead to absolute iron deficiency. On the other hand, there is inflammation will lead to increased hepcidin production, which will block iron absorption from gut or release from macrophages. So there is iron available, but there is iron in the stores, but it's not available for heme synthesis, and that leads to functional iron deficiency anemia. And both of these contribute towards anemia of cancer. Also, there is sometimes bone marrow infiltration. There is sometimes bone marrow suppression because of chemo and radiotherapy, and all this is a contributing factor to anemia. The role of hepcidin is very important because normally plasma iron is maintained at a stable level by the control of its intestinal absorption and storage. This is guaranteed by the hormone hepcidin, which is released from hepatocytes. Now, what happens is in advanced cancer, there is increased hepatic production of hepcidin, which is induced by high levels of interleukin 6. So this is an inflammatory cytokine which leads to increased hepcidin production by hepatocytes. This causes increased iron storage in hepatocytes and macrophages, and there is less iron delivered to the plasma transferrin. So there is restricted iron available for heme synthesis, and that is the main pathogenesis of cancer-related anemia. Now, how do we grade these cancer-associated anemia? This is a grading system devised by National Cancer Institute and WHO, and this has divided into 4 grades. So grade 1 is the mildest form, in which hemoglobin is from 10 to 11.9. Grade 2 is from 8 to 9.9. Grade 3 is less than 7.9. And grade 4 is the most severe one, in which hemoglobin is less than 6.5. It is life-threatening consequences, and it requires urgent intervention such as RBC transfusion. Now, how do we differentially diagnose cancer-related anemia from other causes of anemia? So this cancer-related anemia tends to be hypoproliferative with a low reticulocyte count and low value of reticulocyte index. RBCs are typically normochromic and normocytic on the peripheral smear, but they can also appear hypochromic and microcytic. Iron studies demonstrate reduced serum iron and reduced total iron binding capacity. The ferritin level can be either normal, that is from 30 to 500, or more often elevated as a consequence of malignancy. So a defect in iron handling instead of lack of iron, which is known as functional iron deficiency. This is the pathognomic sign of cancer-related anemia. Also, the erythropoietin levels tend to be low in the setting of cancer-related anemia. So how do we differentiate? So this is how we can differentiate iron deficiency from cancer-related anemia. The reticulocyte count could be high or low in iron, and cancer-induced anemia, it will be low. The mean corpuscular volume and mean corpuscular hemoglobin can be low or normal in both. Serum iron is low in iron deficiency. It can be low to normal in cancer-related anemia. Ferritin is always low in iron deficiency anemia. In cancer-induced, it can be normal or high. Transferrin saturation index is low or normal, and it is low in cancer-related anemia. Total iron binding capacity is high, and in cancer-related anemia, it is low. Bone marrow iron deposits are absent in iron deficiency anemia, and in cancer-induced, they are present. So you can see that by looking at some lab parameters, we can differentiate the two types of anemia. So how do we do the workup? This kind of workup requires a good clinical history, which includes personal history, status of the oncological disease, that is the type of primary tumor, is it a solid tumor, or does it belong to the tumors which do lead to cancer-related anemia, and stage of the disease. The different treatments received, chemotherapies with a high risk of hematological toxicity and their dates of administration, and of course a complete physical examination. So this will give us a clue about what kind of anemia we are dealing with. The most important clue is if the anemia was present at the time of initial diagnosis, even before the treatment was started. So how do we do these workup? We can do a complete blood picture. We can do ferrokinetic study, that is serum ferritin levels and transferrin saturation, biochemistry with creatinine to assess kidney function, C-reactive protein, which is a marker of chronic inflammation. So these are the basic workup. Since anemia is a multifactorial disease, so we can order some other investigations like occult blood in stool, coagulopathy studies, thyroid hormones, immunological studies, bone marrow biopsy, CT scans, and endoscopies if we are suspecting some GI blood loss. So how do we, based on these ferrokinetic studies, how do we diagnose cancer-related anemia? You can see that if ferrokinetic study is altered, it could be three ways. Ferritin could be very low, which is less than 30 micrograms per liter. That is a sign of iron deficiency anemia. If ferritin is 30 to 100 micrograms, it could be chronic disease with iron deficiency. And ferritin more than 100 is definitely a sign of anemia of chronic disease or cancer-related anemia. If the ferrokinetic study shows normal, and then we get vitamin B12 and folate. And of course, if it is low, then it is megaloblastic. If it is normal, then it could be other causes like bone marrow, drug-induced endocrinopathy, and renal causes. So how do we treat cancer-related anemia? We have three main modalities of treatment. One is iron supplementation. Second is blood transfusions, and third is erythropoietic stimulating agents administration. Iron supplementation is based on three lab parameters, which will guide us when should we give iron supplementation and should we give iron oral or IV iron. So we have to get a serum iron level, serum ferritin level, and serum transferrin saturation index. Now, there could be three possibilities. We might have a ferritin level which is 50 to 800, which is fairly high, and a transferrin saturation index of more than 50%. This is a possible functional iron deficiency. So treatment with an erythropoietin stimulating agent or with iron supplement is not recommended in this because they are already high iron storage, and this can lead to problems. The functional iron deficiency, when there is ferritin level between 30 to 500, transferrin saturation index is less than 50%, and serum iron is less than 30 units per deciliter, 30 microns per deciliter. This shows insufficient availability of iron despite adequate iron stores, and administration of IV iron together with ESA is recommended in patients who are receiving chemotherapy. The third is absolute iron deficiency, in which ferritin is less than 30, saturation index is less than 20%, and serum iron is less than 30. This indicates that iron stores are depleted. Oral or IV iron supplements can be given. Oral iron should only be administered in the absence of inflammation. If no response is obtained after 4 weeks, we have to switch to IV iron. This is an important information because cancer is a state of chronic inflammation, and they do not respond, these patients do not respond to oral iron that well. Blood transfusion, it is indicated in patients with severe anemia and symptoms that require rapid recovery of hemoglobin and hematocrit levels. So if a patient does not have any cardiovascular risk factors, transfusion is indicated if hemoglobin is less than 7 to 8 grams per deciliter. In patients with cardiovascular risk factors, particularly coronary heart disease, the minimum hemoglobin threshold is higher, that is around 9 grams per deciliter. Patients with symptomatic anemia should be transfused regardless of these hemoglobin thresholds. Then we come to erythropoietin stimulating agents. Patients with solid tumors and symptomatic anemia under treatment with chemotherapy or chemoradiation should be used. In these patients, we can use erythropoietic stimulating agents. Patients with hemoglobin level less than 10 or asymptomatic anemia with hemoglobin level less than 8 after correction of iron levels and other underlying causes. This is very important because the hemoglobin level should be less than 10 for use of ESA. It should not be used in hemoglobin levels more than 10. ESA should not be used in patients who are not receiving chemotherapy, and we'll discuss why this clause later. So there are certain risks and complications. In 2005, some studies revealed that the use of ESA has increased a rate of venous thromboembolism in cancer patients, and this effect was then studied, and they found out that this only happened when ESAs were used in patients with hemoglobin more than 12 grams per deciliter. So this was identified, and then it was rectified, and the guidelines were established that it should not be used if the hemoglobin is above 10, and that's how this VTE can be avoided. Other complications which can happen with use of ESA are pure red cell aplasia, which is caused by appearance of anti-erythropoietin antibodies, arterial hypertension, thrombocytopenia, and allergic reactions. So there is a controversy about survival and disease control. It is said that it is helpful because there are certain therapies do not work well if tissue hypoxia is present. So achieving hemoglobin of more than 12 with ESAs will improve survival receiving chemoradiation. But this was the theory which was not proven, it was not observed. And when they saw that patients in whom ESA was used, the survival was reduced, then they thought why it is happening in this regard, and they thought that it may be due to the appearance of thromboembolic phenomena in patients with hemoglobin 13 to 16 due to the presence of erythropoietin receptors on the surface of tumor cells that would promote angiogenesis, tumor growth, and therapeutic failure. So after this was observed, that is reduced survival, various agencies and scientific societies have maintained their recommendations for use of ESA, adding that they should be avoided in patients receiving therapy for curative intent and in patients with advanced tumors but long-term survival expectations. even if they develop anemia secondary to treatment. So that's how the role of ESA is maintained, but it is defined, where should we use it, or where should we use cautiously, or should we take the patient consent before using ESA, discussing the role of a little reduced survival and disease control. Now, if you look at this summary diagram, that which kind of treatment we use. So if we have losses, we have to control those losses by probably surgical intervention, or in cases of GI tract bleeding, by injectable therapies. If we have indication for IV iron use, we can use IV iron use. We can use erythropoietin stimulating agents where they are indicated, and the uses are now limited. The most important thing is the use of hepcidin antagonist, and we just discussed the role of hepcidin hormone produced by liver, and now there have been definite studies which have discussed the role of hepcidin antagonist, and they are much more safer than the erythropoietin stimulating agents. And of course, blood transfusion is the last resort, which is reserved for severe grade of anemia in cancer. So in summary, anemia is extremely common in cancer patients and has meaningful effect on symptomatic burden and quality of life. The diagnostic workup requires a thoughtful and comprehensive laboratory evaluation based on each patient's presentation and symptoms. Proper understanding of the individual patient's etiology is essential to guide treatment. Adequate management relies on treatment of underlying malignancy and correction of existing iron or other nutritional deficiencies. Packed RBC transfusion is also often a cornerstone of management. And for patients with chemotherapy-related anemias, erythropoietin stimulating agents are approved but have important safety concerns that include increased risk of VTEs and possibly deleterious effect on tumor progression or patient survival. And that's why they should be used very cautiously. Thank you.
Dr. Alia, it was really an excellent, I think, anemia with gynec oncology is actually not that well managed, and you highlighted every aspect of it, that how important it is to manage the anemia and what is the role of erythropoietin. I think it was the approach and everything was fabulous. You have covered every aspect and depth of the topic. Thank you so much for being here, and really pleasure having you as a part of the program. Dr. Sidra, do we have questions or anything?
No, ma'am. No, ma'am, no questions.
I think questions may be coming a little later or something, but I think it was really well covered, and whoever must have heard the talk has none in depth about the various aspects. So thank you so much. Sidra, we can go ahead. Dr. Krishna Kumari, madam.
Thank you so much, Dr. Komal. Yeah, thank you so much, Dr. Komal and Dr. Alia, for your presence. Thank you so much, Komal, ma'am. We go on to our next chairperson, Dr. Krishna Kumari. Ma'am is a professor at Apollo IMSR, Hyderabad, a senior consultant at Medicover Women and Child Hospital, Hyderabad. She's a national corresponding auditor at Jogi, national coordinator Foxy, and she has chairing many prestigious positions in multiple national societies. We welcome you, Dr. Krishna Kumari.
Thank you. Thank you so much. Thank you. Very good evening to all of you. I think at the outset, I would like to congratulate Dr. Niranjan and Dr. Komal. Am I audible? Yeah. Dr. Niranjan and Dr. Komal for this very important and very regularly topic which is being covered so frequently, but somehow we have never been satisfied with the outcomes of managing anemia. And we know that it is an underlying cause for many, many issues that come up in a women's health. And one of the important aspects of anemia is managing it in the elderly. With the increasing lifespan, it is very, very important that it is not only the life expectancy that should be increased, but quality of life is very, very important. And for that, to talk about anemia in elderly, we have none other than Dr. Sandeep Tamane, who's a consultant physician and geriatrician, Dinanath Mangeshkar Hospital, Pune, and he's also senior consultant in geriatric medicine. Doctor, I think Dr. Komal, should we ask Dr. Sandeep to make a women's wing where we can also be a part of taking care of women, elderly women? I think it's very, very important.
Yeah, it is the need of the hour now.
Yeah, very much. Yeah, he's from the Jahangir Hospital, Pune, and he's chairman of the Pune chapter of Geriatric Society of India, and he is a fellow of the Geriatric Society of India. Over to you, Dr. Sandeep, to enlighten us regarding this very, very, very important topic of managing anemia in the elderly. Thank you. Dr. Sandeep?
I can see Dr. Yeah, he's unmuted.
Hello.
Yeah. Hello.
Can you hear me?
Yes, we can hear you.
Yeah, we can hear you.
Okay. Can you share my slides, please? Right. So good evening, everyone, and thanks MOGS, Dr. Niranjan, Dr. Komal, and the entire organizing committee for giving me one more opportunity to speak on this topic as I had done last year. So talking about anemia in elderly, as I'm speaking as representative of the Geriatric Society of India. Next slide, please. Right. So why anemia is important in elderly? We know it is highly prevalent, as we have discussed anemia in pregnancy. So anemia is very common as we grow older. And it has been shown that even mild anemia can have adverse health outcomes in elderly because they have so many other comorbidities, and even slight drop in hemoglobin can cause problems, can exacerbate the pre-existing illnesses. It is also shown that anemia in elderly is independently associated with increased morbidity and mortality. And the mistake that we all do is we consider most of the illnesses or symptoms as a part of aging. And same is true with anemia. So we should remember that we can find the cause of anemia in nearly 80% of our elderly patients if we evaluate properly. If you take proper history, do proper physical examination, and do proper investigations, then in about 80% of our elderly anemic patients, we can find out a cause which can be treated and that improves their symptoms and quality of life. Next slide. So what is the importance of anemia in elderly? What all problems it can cause? Specific for elderly people. So we all know that severe anemia or even moderate to severe anemia is a risk factor for cognitive and functional impairment. So, the memory loss, then decreased quality of life, then problems with day-to-day locomotion, mobility, everything is affected if your hemoglobin starts dropping. There is a definite risk or association between cardiovascular disease and anemia. We all know that left ventricular hypertrophy, diastolic dysfunction is very common or more common in people with anemia. And worsening of heart failure, we all know anemia is one of the exacerbating or aggravating factors for heart failure in addition to many other factors. Then frailty and falls, two common problems, or what we say are geriatric giants. They are also very common and the risk increases with anemia. Of course, patients who are severely anemic, the need for hospitalization and complication goes up. And overall, we find that anemia, moderate to severe anemia, have impact on quality of life. And therefore, it is very important that we adequately approach and treat anemia in elderly and not just attribute it as a cause of or as a part of aging. Next slide. Right. So we know that atypical presentation is a very common phenomenon in elderly people. They do not present with typical symptoms. Very often the symptoms are non-specific and vague. So it is important that we understand that anemia can present with many non-specific symptoms like fatigue, tiredness, anorexia, breathlessness, reduced functional capacity, and which are easily attributed to age and disease. So somebody who is 80 plus, if he feels slight anorexia, gets slight fatigued or slightly breathless, then we all, not all, but some of us will feel that it is part of our aging. But that should not be done. So we should understand that anemia, like any other disease in elderly, can present with non-specific symptoms. So we should not ignore those symptoms. Now, we talked about geriatric syndromes. Those syndromes like immobility, falls, confusion, or cognitive impairment are due to multiple causes, among which anemia should always be excluded. Now, anemia, as I showed you in the last slide, can cause a lot of problems in elderly, and treating it, it's not difficult to treat anemia. And treating that anemia causes great improvement in the symptoms and the quality of life for these patients. Next slide. Now, two important aspects in geriatric medicine are polypathology or multiple pathology and polypharmacy. Because these patients have many diseases together. If you see an elderly man, he will have hypertension, diabetes, arthritis, cataract, prostate enlargement, so many things together. And because of multiple diseases, multiple medications are given by various specialists. So polypharmacy is also a typical problem in elderly. And multiple causes of anemia are often simultaneously present, and they may mask typical features. Now, I can give an example. Iron deficiency and vitamin B12 deficiency can exist together, can occur together. And then the peripheral smear that you will get is normocytic anemia. Unlike as in pure iron deficiency anemia, you get hypochromic microcytic picture. Or in B12 deficiency, if it's a pure B12 deficiency, you get macrocytosis. But if these are together, then typical features are masked. Similarly, we all know that dehydration will mask fall in hemoglobin level. And these patients, elderly patients, have chronic musculoskeletal diseases with inflammation, like rheumatoid arthritis, that will induce anemia, but they will mask the clinical symptoms of anemia because these patients have reduced mobility and reduced exercise capacity. So if somebody has, joint immobility, mobility problems, arthritis, then the mobility is reduced. So he cannot exercise. So typical symptoms of anemia will not be seen. A young patient who is anemic, when he walks or when he does exercise, he will feel breathless. So he can report it to the doctor, and even the doctors can take appropriate action. But unfortunately, in geriatric population, because these typical symptoms are not seen, and that is the reason why very often this diagnosis is missed unless you evaluate or investigate. Next slide. So what is the definition of anemia? So when do you say that this patient is anemic? The definition given by World Health Organization tells us that hemoglobin less than 13 grams per deciliter in males and less than 12 in women is considered to be anemia. So if we take that definition, I think we'll see many patients with anemia. In clinical practice, we see slightly different picture, but this is a typical or a definition which is given by WHO. Next slide. Okay, now let's come to the differential diagnosis or various causes of anemia in elderly. Once you have diagnosed anemia, you need to find out the cause and then treat it appropriately. There are four main etiologies, that usually exist in elderly anemic patients. The commonest probably is anemia of chronic disease. It is seen in about 30% of the population, and usual etiology is chronic inflammation. I will discuss the causes, and renal disease or chronic kidney disease. Then nutritional anemia constitutes about 30% of the anemic patient, and this anemia is because of iron deficiency, vitamin B12 or cobalamin deficiency, and folate deficiency. Many times we cannot find the cause. In spite of investigating extensively, the cause is not found. This is very common in about 20% of the patients. We cannot find a cause, and usually this anemia is then labeled as anemia of senescence, or sometimes myelodysplastic syndrome is a cause of this type of anemia. And there are some other causes, like less than 10% of the cases will be because of some other cause. I'm going to highlight those causes later. So one must remember that the two major etiologies of anemia in elderly are anemia of chronic disease, and nutritional anemia. Next slide. Now, anemia of chronic disease, which is also called inflammation-related anemia. So let's find out what are the causes of this type of anemia. So the infection, which can be acute or chronic and can lead to anemia of chronic disease. Then malignancies, either hematological malignancies or solid tumors. And we should keep multiple myeloma in mind because it's a very common neoplasm in elderly. They present with bone pains, hypercalcemia, and then when we do a bone marrow examination or protein electrophoresis, the diagnosis is made. Then chronic inflammatory disorders, autoimmune diseases, protein energy malnutrition, thyroid disorders, and chronic renal disease or chronic kidney disease. So these are some of the causes of anemia of chronic disease. Now let's try to understand the pathophysiology of this type of anemia. Like in many other cases, it is multifactorial. So what happens in these patients is that there is increase in the pro-inflammatory cytokines which interfere with the iron homeostasis. We know interleukin-1, TNF-alpha, IL-6, IL-10, IFN gamma. These are all pro-inflammatory cytokines, and increased levels of these are found in these patients which interfere with the iron homeostasis. There is inhibition of erythropoiesis or erythropoietin production by kidney. We know that erythropoietin is a hormone which is produced by kidney. And in patients with chronic kidney disease, there is reduction in erythropoietin production, which results in anemia. So these patients are treated with erythropoietin injection. And one more important factor that we have found out recently is that hepcidin, which is stimulated, the production of hepcidin, which is stimulated by interleukin-6 in the liver, also plays an important role in this disease, because what happens in that case is that there is a reduction in the GI absorption of iron. So iron absorption is reduced by hepcidin, and that results into anemia. Next slide. So what are the typical features of this type of anemia? So usually it's a mild to moderate anemia. The hemoglobin will usually not go down below 10. Usually normochromic, normocytic, but we must remember, as I said, there could be other cause for anemia, like these patients may have iron deficiency. So the clinical picture or peripheral blood smear may be different, but usually we say it's a normochromic, normocytic anemia. As we know, in many of our CKD patients, the peripheral smear is normochromic, normocytic. It is also found that the degree of anemia often correlates with the severity of underlying disease. So severe the disease, more severe is the anemia. Then in this type of anemia, there is reduced serum iron and TIBC. There is reduced transferrin and iron saturation. I think these are common with iron deficiency anemia. But one thing which differentiates anemia of chronic disease from iron deficiency is the ferritin level. We should remember that ferritin levels are usually high or normal in anemia of chronic disease, whereas if you take pure iron deficiency anemia, the ferritin levels are always low. So this is one of the important features. When we see the peripheral smear, we ask for ferritin, and that gives us a clue. And how do you treat this anemia? Obviously, you have to treat the underlying cause. And as I said, erythropoietin injections are also given in these patients to maintain the hemoglobin level. Next slide. Right. Now let's move on to the second type of anemia. The most important nutritional anemia is iron deficiency anemia. We have a talk by Dr. Neeraj Bhala from UK after my talks on iron deficiency anemia. So I'll just go through the salient features of iron deficiency anemia. So what are the common causes in elderly iron deficiency anemia? Chronic GI blood loss, often occult blood loss, which can be because of various diseases like esophagitis, gastritis, gastric ulcer, duodenal ulcers. Many of these patients are on anti-inflammatory medications, non-steroidal anti-inflammatory medications for various conditions, like mainly for the musculoskeletal problems. And this results into gastric ulcers, duodenal ulcers, and as you know, even chronic kidney disease. Then there are patients with CA stomach and CA colon, who often present with anemia. Anemia is just the only presentation that they have. And then when you evaluate them, you find the diagnosis. And conditions like diverticulosis or angiodysplastic lesions can also result into chronic blood loss and iron deficiency anemia. Then, as we all know, inadequate dietary intake, which is not uncommon in our country, is also an important cause of iron deficiency anemia, more common in elderly, because there are various other issues related to aging which interferes with their dietary intake. So there are various social factors, there are dental problems, swallowing issues. So all that results into inadequate dietary intake. Malabsorption, again very common. Your intake may be good, but if you're not absorbing iron appropriately or properly in proper amount, then it will result into deficiency. And celiac disease, which is not so common in elderly, but and again not so much common in our country, but is also described as an important cause of iron deficiency anemia. Next slide. Now this is the typical peripheral smear that you see in iron deficiency anemia. You see the hypochromic microcytic RBC. So the size of the red cell is less or small, and there is increase in the central pallor. That is hypochromia, as we have learned in our pathology days in our medical schools. Hypochromia and microcytosis are typical features of pure iron deficiency anemia. And then sometimes you can see these pencil cells or teardrop cells or target cells in some of the cases. Next slide. Clinical features are important, because one thing which I have told you, and we always need to keep in mind when dealing with elderly patients, is that they often do not have typical clinical features of disease, but you still need to look for those. We all know koilonychia, platinichia, pica, edema feet. There are many patients who just come to us with leg edema, which is so common in elderly. And then when we evaluate them, most of the things are normal, like the renal function, thyroid function, hepatic function, and then the hemoglobin sometimes we find low, and when we correct it, many times the edema disappears. And on examination, they are often tachycardic, especially patients with severe anemia, and very often we can hear the hemic murmur. So although we go for hemoglobin and blood testing and diagnose anemia, but I think we should not forget to look for these clinical features on examination, which would help us to diagnose anemia and treat it appropriately. Next slide. So these are some typical features of koilonychia, platinichia. Next slide. Next slide. Okay. So let's move on to the diagnosis. What are the laboratory features of iron deficiency anemia? As I discussed, usually it is microcytic, so the size of the RBC is less. The MCV, the mean corpuscular volume, is less. If you do iron studies, the serum iron will be low and TIBC is high. And here, as I was telling you, the ferritin levels are typically low. And you've seen patients with very, very low, extremely low serum ferritin levels, leading to the diagnosis of iron deficiency. And this is in contrast to anemia of chronic disease, where, as I told you, we get either high ferritin levels or normal ferritin levels. So it is very important to ask for ferritin levels to know the iron stores and find out the cause of iron deficiency. Then many patients would need endoscopy, either upper GI endoscopy or colonoscopy. I told you about various gastrointestinal diseases which can cause chronic blood loss and anemia. So endoscopy is very useful in diagnosing many of these conditions so that the treatment can be appropriately carried out. And it is very important to do the stool examination, a very basic test, stool routine and occult blood. It's very important to do this. If there is stool occult blood positive, that gives you a hint that there must be some bleeding. Again, many of these patients are on antiplatelets, anticoagulants. This results into this blood loss and anemia. So stool examination, a very simple test, but it's very important. Next slide. So treatment, we had a lecture by Dr. Balamma. She very nicely highlighted various treatment modalities for iron deficiency anemia. The most important thing in elderly, I think, is to treat the cause, because there is usually some cause which is causing the anemia. So it is important that you identify the cause and treat it, and the anemia would improve. Iron therapy, as Madam said, we have oral and parenteral iron. Diet, again, as she said, the role of diet is limited even in elderly people. Because of various reasons, the diet is anyway, compromised. So we need to, give them iron therapy, either oral or parenteral. And elemental iron, 50 to 100 milligram TDS orally is usually given. We all know problems of oral iron, the side effects that people get. Whichever brand you give, usually they complain with some GI side effects. Some people get diarrhea, some get constipation, abdominal bloating, abdominal pain, then black stool. So these are things that, patients are alarmed and they come to us. So we need to explain to them that some of these side effects may occur when they are put on oral iron, and they need to observe for this. And deworming is very important. We cannot underestimate the role of deworming, especially in patients with severe anemia. So deworming should be routinely done even in elderly people, which would help to prevent anemia, or at least reduce the severity of anemia. Next slide.
Dr. Sandeep, just 2 more minutes.
Okay, right. So vitamin B12 and folate deficiency anemia, they often occur together. So atrophic gastritis with or without H. pylori is an important cause. Then certain drugs like metformin, which we use for diabetes, can cause B12 deficiency. Alcoholism, gastric surgery can also cause B12 deficiency. Next slide. Next slide. So laboratory features, usually it's a macrocytic and megaloblastic picture. We see hypersegmented polymorphs. Pancytopenia is very common, and they often have high LDH and, of course, low vitamin B12 level. Treatment is giving B12 either orally or parenterally. Next slide. Folate deficiency is almost always because of inadequate dietary intake. Drugs like methotrexate and alcoholism are common causes. And we should do red cell folate levels rather than doing serum folate. It's a better indicator of folate deficiency. And usually 5 milligram per day folate is indicated. Next slide. This is a peripheral blood smear showing hypersegmented polymorphs indicative of vitamin B12 deficiency. Next slide. So myelodysplastic syndrome, a typical feature in elderly, you don't see it in younger people. It's an acquired clonal disorder of hematopoietic stem cell. It can affect all cell lines, but usually it affects RBCs, so anemia is predominant. Next slide. So these are some typical features. They get constitutional symptoms like unintentional weight loss, fever, night sweats. Laboratory features will show either bicytopenia or pancytopenia, thrombocytopenia, abnormal circulating WBCs or large platelets. These are the features which would suggest MDS. Next slide. So again, it's a macrocytic smear. Sometimes you get normocytic, you get abnormalities in the RBC shape. Treatment is supportive. You have to give them transfusion, then erythropoietin or growth factors, and sometimes oral thalidomide. Next slide. So other causes which are not age-related but should be kept in mind, intoxications like lead toxicity, then myeloproliferative syndromes like polycythemia rubra vera, like where you get JAK2 gene mutation, hemolysis, various causes of hemolysis, which would present with high reticulocyte count and low haptoglobin. And always remember drugs causing anemia. We use pioglitazone, the anti-diabetic drugs, and non-steroidal anti-inflammatory drugs which can cause anemia. And unknown causes, or as I said, anemia of senescence, where you don't find a cause on extensive workup. Hemoglobin is not too low, around 10, and examination should be done every 3 months for more than a year. You don't find any change in the levels. And half of these later on may develop either iron deficiency, myelodysplastic syndrome, or anemia of chronic disease. So you have to keep on investigating to see if you find out a cause. Next slide. And this is the last slide. So this slide is very important. In elderly, we need to take some preventive aspects. So regular hemoglobin monitoring is important. Clinical examination also would help us in checking hemoglobin at appropriate interval. Balanced diet, nutritional supplements, high index of suspicion. When you have some abnormal symptoms or clinical features, you must check hemoglobin. And as I said in my first slide, avoid ageism, because in nearly 80% of the anemic elderly patients, you find out a cause. There is a cause which is treatable, curable, and the anemia would improve. Next slide. I think this is the last slide. Thank you.
Thank you very much, Dr. Sandeep. It was very, very elaborate, and I think we have really given us an insight into the elderly, anemia in the elderly. And once again, I would congratulate Dr. Niranjan and Dr. Komal for this fantastic CME. Any questions, Dr. Komal?
No questions, ma'am.
No questions.
Yeah.
You can conclude the talk and
yeah.
you can go ahead.
Yeah, I think we have learned that we have to go on investigating in the elderly, and anemia of senescence was something which we have really have to understand about. Thank you so much. It was a very good, elaborate and lucid discussion. Thank you, Doctor.
Thank you.
Thank you so much.
Go ahead with the next session. Yeah.
Kumari and Dr. Tamne. I would like to hand over the proceedings of the program to Dr. Garima Sharma. Thank you. At the outset, I would like to thank MOGS, Niranjan sir, Komal ma'am, Radhendra sir, and Geeta Balsarkar ma'am for giving me this opportunity to be here at this assorted event. Thank you so much.
Thank you, Sidra. And I think we have all been glued to our screens. With this, I take the opportunity to move ahead with the next session. And for this, I would like to invite Dr. Pariksha Tank as the chairperson for the session. We all know him. He's the consultant at Ashwini Maternity and Surgical Hospital, Center for ART and Endoscopy, and at Jupiter Hospital. He's the managing committee member of MOGS and treasurer Foxy. I welcome you, sir.
Thank you very much, Garima. Pleasure to be a part of today's program. Today, we are honored to have a very eminent speaker. He is Dr. Neeraj Bhala, and he's a consultant physician and gastroenterologist at the Queen Elizabeth Hospital, Birmingham. He's Associate Medical Director of the University Hospitals Birmingham NHS Foundation Trust, UHB, of course, based in Birmingham, United Kingdom. So welcome, Dr. Bhala, and we are looking forward to the deliberations of the day today.
Hi, I'm Nij Bala here, speaking from Birmingham, and I'm humbled to be asked to talk about managing iron deficiency anemia in the elderly in 2022 as part of the Royal College of Physicians Symposium for Medicine of the Older People. And I would have very much enjoyed being with you guys, and part of the reason I'm pre-recording is partly because I'm on call at the moment. So hopefully I'll be able to join you for the live session after. So this is my declaration of interest, and I don't have any declarations to declare apart from particularly being co-chair convener of the recent BSG iron deficiency anemia guidance. And I'm going to talk about this in particular, and it's a collaborative effort to particularly acknowledge the efforts of Jonathan Snook and Andrew Goddard, driven quite a lot of this. I'll give the link to this open access guideline, which is in GUT, published in print earlier in the year. So to really put things into context, the burden of iron deficiency anemia remains considerable, particularly in trying to ensure the right patient arrives in the right place at the right time for both investigation and for treatment. The initial clinical review includes a risk assessment, but also doing some of the simple things as well, celiac serology, urinalysis, bloods, and from a gastrointestinal perspective also involves bidirectional GI endoscopy. There have been a number of different therapeutic investigation advances, including wireless capsule endoscopy, imaging modalities, particularly in recurrent and refractory cases. And I think one of the big take-homes is really about integrating iron replacement, oral in many cases, and in some cases parenterally, as part of investigation pathways. And the role as a physician is also very key, particularly including a consideration of the patient's age, which can be one of the key drivers, gender, demographics, and comorbidity, to optimize the treatment and try and help in terms of the ownership of helping these patients. So to try and put matters into context, I wanted just to put up a case summary, and we'll kind of see this from a number of different lenses. An 85-year-old woman, a little bit younger than her Royal Highness, very fit and well and with a very good exercise tolerance, who presents with tiredness and lethargy, no overt GI symptoms, but is on cardiovascular secondary prevention, and has a hemoglobin of 62 with an MCV of 75, so microcytic, and a ferritin of 20, and we don't have any previous ones. So she's referred to gastrointestinal medicine from the acute SPR, who's been managing her overnight. The question really is about how far would we investigate in terms of helping this this elderly lady. And I would, if I was there in person, I'd put it out as a question mark for the audience, partly to ensure post-lunch that you are still, on board mentally as well as physically. It particularly involves, thinking about whether additional blood and urine tests would be useful. Would we consider doing an inpatient gastroscopy test or upper GI endoscopy? Would we want to do an inpatient colonoscopy test? Urgent outpatient gastroscopy and colonoscopy? Considering modalities like a CT scan, would they be useful? And would we want to consider a wireless capsular endoscopy? And in time-honored fashion, when asking about MCQs, it's a question of, is it all of the above or potentially none of the above as investigation strategies? And I think, actually, what I want to probably put through as we go along is that there aren't sort of necessarily right or wrongs, but, it very much depends on the context of the patient in terms of some of this, because actually we would want to be pushing for non-invasive tests ideally, but also the appropriate invasive tests at the right time for some patients. So I think part of the reason I've been asked to speak is that gastrointestinal diseases throughout the GI tract represent the most frequent causes of iron deficiency anemia in the elderly. And that's not just due to nutrition and intake, but also due to blood losses, which can occur in both the upper and lower GI tract. In particular, we're keen to exclude cancer, particularly of the colorectal, of the lower GI tract as a cause, but also ulcers, and some of the etiologies linked with that, and malabsorption in the small bowel related to celiac disease or other causes. And so that's part of the reason we would be looking to consider not just holistic assessment of the patient, but also the appropriate test to do. And I think, as you probably gathered from some of the slides, I know that Donald Trump's no longer the president, but I think it does help us, consider different perspectives that people have in terms of both themselves and the clinicians that see them. And in terms of acute management of a patient like this coming on the front door, I think one of the important aspects to mention is that iron replacement rather than blood is often favored in terms of some of the acute treatments, and it can be intravenous. In an outpatient setting in particular, we would also consider oral replacement, and on discharge, but nutrition review is also important, including not just things like MUS scores and the weight, but also aspects like hematinics and other causes of anemia. And I think part of the reason I've put there about frailty and comorbidity is that there can often be a difference in viewpoint between the clinician who's seeing the patient and the patient themselves as part of some of the expectation management of treatment modalities and the like. I think one of the big changes in the last couple of years really has been about our use of blood transfusion. And it's changed from an arena where we were very liberal and very giving a lot of blood, where we're much more careful and restrictive. And some of the evidence base for that comes from different settings, but in a GI setting comes from this paper by Spanish colleagues from just over 8 years ago, where a restricted blood transfusion led to an improved mortality in a multi-center study. In the UK, actually, you know, although we haven't done a similar study, it's also been shown that the differences in transfusion use and feasibility have been borne out at a centre level as well in terms of a cluster randomised trial. I think it's important to note that really, although in the elderly, which is one of the principal areas we're looking at, there isn't little clear, you know, evidence of difference. But I think we would be more cautious about altering hemoglobin quickly in a stable patient, even in a patient with comorbidities, due to you know, bearing on board some of this change in the evidence base. And there's a number of other baseline investigations we do at the front door in terms of some of the blood tests mentioned. I think trends can often be quite useful because actually, you know, knowing that someone was anemic before, you know, does help put things in perspective. Serum ferritin remains one of the key markers, but it is important to note that it does have an acute phase response. And serum iron and transferrin are also important. There's a number of other hematinics, and as well as B12 folate and thyroid tests. One of the key other blood tests that's now readily available is tissue transglutamase or celiac. But in terms of other tests that can be done relatively simply, urine dipstick and microscopy can help exclude any renal cause. And I'll come on to discussing fecal blood and fecal immunochemical testing, which are some of the newer stool-based modalities to look if there's bleeding there. And although I'm principally coming at this from a GI perspective, it is important to also consider some of the role of other investigations. You know, as it gets more complex, the role of myelodysplasia and bone marrow also plays a role. And although anemia has very set thresholds, so particularly less than 13 grams in men and less than 12 in women, it's principally based on middle-aged patients. The limits don't change with age. So actually, because of that, you do get an increased prevalence of anemia with increased age, and particularly over the age of 70, as these lab thresholds are still used. In keeping with age, also clearly you'd also get an increased mortality risk, so we've got to take some of that into context. And for those over 85, it would be, you know, just under a fifth of women and just around a quarter of men, so pretty common. And it does vary as a reflection of general health and comorbidity. So those we see in the hospital and in nursing homes often have some of the highest amounts. This is borne out even in some of the patients we're seeing at in the front door. So I wouldn't expect you to be able to take all of this slide, but this 1-year informatics audit at the front door of the hospital I work at in Birmingham, which we've recently replicated with pretty similar numbers really, showed about 8% of patients over the year had a microcytic anemia. I think part of the reason I highlight this is that only 2 in 5, so definitely less than half of these, ended up having a ferritin measured, and only a third of these were screened for celiac disease in terms of some of the available blood tests. And again, only a fraction, so only a quarter, ended up having endoscopy or CT colonography, with trends for lower investigation rates in the elderly. So, you know, this has the standard caveats of big data in terms of we, you know, often can't look, you know, beyond what's on our own informatics system, but it would still really bear out what we, you know, for a very insidious common symptom like tiredness, actually, you know, 8% is still a pretty staggering amount of patients where that's who are coming to the front door. And there is considerable variation as well. So this is data looking at CCGs and hospital admissions for patients with iron deficiency anemia. Quite a marked range of diagnoses in CCGs in England. And part of the reason you mention this is partly to show, well, actually, there is the scope for improvement as part of this variation. And I started with talking about with Donald Trump, and then move on to bring it a bit closer to current times with Joe Biden and Dr. Anthony Fauci as the chief medical officer in the USA. And I think the role of as physicians is really pretty key. It's a spectrum of fitness, but and also in terms of acute situations, GI bleeding will dictate the timing of endoscopy. As going back to the initial tests I was talking about, but there are higher absolute rates of pathology in the elderly, and I think it is also important from a physician perspective to consider what the physiological age of the patient is and the likely gain in quality of life investigations. And important really as physicians to do good, but also to do no harm. And I'll sort of talk about some of that in terms of the investigations in a second. So going to the first test that I mentioned, apologies for that, real life colleagues coming in after doing some of this. But upper GI endoscopy, which is one of the key tests, I think it's just important to put some of the risks versus the benefits into context. So in the very elderly, previous retrospective studies showed actually that upper GI endoscopy demonstrated significant findings in about half of patients, which is a pretty good yield for an investigation, particularly in terms of GI bleeding and anemia, and around 10% of those were diagnosed with peptic ulcer or malignancy, which they actually had a threefold increased risk of. So it's a test that can alter management, and it's overall extremely safe. So in a cohort of 8,000 elderly anemic Japanese patients, there were no increased mortalities or perforations, albeit there was slightly high cardiopulmonary risks. So still not without risk, but pretty safe overall in an LD cohort. And the other test that as a gastroenterologist would be doing would be colonoscopy. And again, for the very elderly, there are similar crude completion rates. Or, it's a test where sometimes we do prefer to do as an outpatient, I think, if we're being pragmatic. But in some cases, particularly when it's difficult, it can be useful as an inpatient. There's a higher diagnostic yield and higher rates of cancer, the order of fourfold, but similar adverse events. So that's from a Sheffield cohort. Other centers, so I think particularly in South Asia, have suggested a slightly lower rate of complete colonoscopy, but still in the order of 88 versus 90%. And looking at the overall evidence, I think it is still important to note that octogenarians had a higher rate of adverse events and a slightly higher increased risk of perforation, albeit in absolute terms, probably not much higher. It still is important to not just be doing good, but also doing no harm. And I think part of that is also really in terms of patient selection and thinking about the GI investigations with increased frailty. And to give a similar case, this is an 85-year-old woman who's now got a comorbidity of heart failure with an exercise tolerance of about 100 meters. Very similar clinical and blood tests. And I think, I'd pose the question for reflection about how far would we investigate. And I think in this case, it really is a question of highlighting some of the advances in radiology, where we've had some pretty marked advances in technology that we often take for granted, both in terms of different CT, MR, other imaging modalities. But I particularly wanted to just highlight some of the CT evidence. And although we often think of it in a simplistic way of, there are a number of different CT modalities. Virtual colonoscopy, which can give quite detailed images, does also include bowel prep, oral contrast, and also rectal catheter. So it isn't really truly non-invasive, albeit probably still easier to manage than a colonoscopy. CTGI protocol is similar without a rectal catheter, and then you move progressively to other modalities which maybe won't involve contrast, including CT abdomen and pelvis. In some cases where we have concerns, we'd also use a dedicated small bowel imaging CT called a CT angiogram. And in an acute setting, you might well see that CT angio is used, which again, we're asking some of the questions about contrast or not. I think some of the other challenges with CT, including radiation risks, are arguably less of a concern in the elderly, but really it's about clinical judgment and careful consideration, particularly of longer term management. And the benefit as well as the risk is sometimes the unintended consequence of picking up incidental lesions, which aren't really related to the anemia at all and lead you down a different route. So again, the physician aspect remains very important. So in terms of some of the evidence from particularly UK studies, there wasn't a significant difference in detection rates of colorectal cancer and large polyps between CT, virtual colonoscopy and colonoscopy. But colonoscopy does have the advantage of biopsies and removal of polyps. But also conversely can miss some smaller lesions. And those can be argued in the very elderly population, but in which case you're also picking up quite a lot of extracolonic findings, which can alter management in approximately 10% of patients from some of the randomized trials. However, in terms of safety, CTVC is extremely safe, with a very low symptomatic evidence of any issues. And one surprising aspect of the looking at the evidence is really the lack of clear differences between some of the modalities, even though at a pragmatic level we're looking at different aspects. I think they can pick up other causes of importance like renal cancer, albeit that should have arguably been picked up, but with a urine dipstick. But the resource implications really are considerable, and there's a lot of variation as well. So the other big technological advance probably in the last decades has been the use of wireless capsule endoscopy, which is a small capsule. Does have a slight retention risk, so we wouldn't use this as a first line. It's really only in patients with recurrent iron deficiency anemia. But it's a very safe procedure, and again selected out in people without any obstructive symptoms has very few adverse events. And in some of the studies that have been done comparing those less than 70 and greater than 70, diagnostic yield again was higher in terms of particularly for anemia and occult bleeding, with age being one of the key independent risk factors. And this also led to alterations in management. So it shouldn't really be a barrier, but again, it's just important to choose the right group of patients in those greater than 70. So I think one of the aspects I mentioned, I wasn't involved, I've only been involved in the more recent BSG guidance, but there has been an evolution, even though many of the principles remain the same, particularly about, these patients going on fast track endoscopy pathways once iron deficiency anemias been picked up to exclude other causes, not just cancers of the lower and GI tract, but also celiac and other causes. But as part of that evolution, I think rather than, and this is over time where you can see that rather than barium tests, we're now talking about CT scans as we come to the beginning of the last decade. But rather than, in terms of management, rather than considering iron deficiency anemia separately, what we've done, particularly the most recent guidance, is to really firstly delineate in terms of that this is an iron deficiency anemia and not due to other causes of anemia or chronic disease, which partly could involve a test of hemoglobin response to iron replacement therapy. but then particularly also merging investigation and treatment. So being very focused as part of the pathway to still to do many of the same things in terms of bidirectional endoscopy in those people who do have a clear iron deficiency anemia, but also using some of the radiological modalities in a complementary way, making sure it's the right patient, right place, right time for wireless capsule endoscopy, but really using iron longer term replacement in quite earlier on in the algorithm. So I think, as a final case to present, I wanted to think of another case that may well come in for the take of a similarly 85-year-old woman with some of the similar blood tests and clinical signs, but unfortunately has got dementia, is bedbound, and has been deemed not for resuscitation. And I think one of the things is also thinking pragmatically about how far would we investigate. And I think it's a very tricky balance, really, and particularly on the front door. But it is important that over-investigation, over-treatment are avoided. But it's a philosophical question, really, also going back to doing good and doing no harm. And this can be challenging, particularly when considering withholding or providing therapies. So, I think it is. It very much does depend on some of that clinical nous. And, I come to this as a gastroenterologist, but I think it's also important to take on board what some of the viewpoints of other physician colleagues. So this is data from an online survey of physician members of the British Geriatric Society. So the other, I'm a member of the BSG, the British Society of Gastroenterology, but it's the BGS. And I think you can kind of see a different tolerance really comes out. So, in this survey, a third of them indicated they would accept hemoglobin levels less than 100 without further investigation, and that they would only occasionally use ferritin, although they do also sometimes use parenteral iron, particularly when oral supplements weren't tolerated. So, like all of us, there's always variation, and some of that's about knowledge of guidelines, and I'll give the link to the BSG guidance for any relevant healthcare of the elderly colleagues to have a look at. But I think but some of this may well be pragmatic in terms of the patient that they're seeing in front of them. So I think that's also important to bear in mind. I can't blame COVID for me not being able to travel, but like I said, I am on call, so I think I've got a reason, and I think we're all looking forward to face-to-face meetings. And I would just say, really, I think whilst COVID itself hasn't really been shown to cause anemia or even GI bleeding as a major modality, which is good, I think some of the changes, particularly in resource allocation for upper GI endoscopy, as well as colonoscopy, do need to be borne in mind, where it is also at a systems level raised our threshold for invasive management endoscopy. That said, I do think it still remains very important to try and ensure that the right patients are in the right place at the right time. And so if there are patients colleagues have concerns about, please do refer to get them on some of the fast track pathways once iron deficiency anemia has been definitively confirmed. So in terms of a summary, iron deficiency anemia is increasingly common and overlooked in acute take chronic populations all of us are looking after, not just in the UK but worldwide, and that very much includes elderly and comorbid populations. And some of the screening investigations involve blood, so not just full blood count, but also the ferritin, hematinics, celiac screen, and ideally upper and lower GI endoscopies where appropriate. There are alternatives available like CT modalities, and there are other new technologies that can be used like wireless capsule endoscopy. But as well as restrictive blood transfusion, I think one of the key aspects is making sure we commence treatment with oral and intravenous iron at the same time as investigation. and really treating the patient, not just chasing investigations, is a really key step. And so the role of physicians remains really paramount. So, as I mentioned, I don't have. I'm happy to sort of field any questions about the guidelines, but please do find the open access link enclosed, and please do feel free to email me with any questions. And very much thanks to the organising committee for asking me to speak, and look forward to meeting many of you in person.
Thank you, Dr. Bhala. I think it was an excellent summary and a very clear concepts about the treatment in the elderly. There is a comment in the chat box, if you would like to respond to it. This comes from Dr. Huda Al-Jufairi from Bahrain. And the comment is that there is underestimated aspect of age-related changes of organ function, such as erythropoietin production in the kidney, and that may become suboptimal. The management and treatment of anemia in older patients often requires a multidisciplinary approach and a detailed investigations of other organ functions as well. So I think some of this has been brought out in the talk, just what has concluded. So if you would want to make some comment on this and throw some light.
Hi there. I think hopefully you can hear me.
Yes.
So first of all, I just want to say I'm very grateful to the organising committee. It's always a humbling prospect, and I'm doing this on behalf of Royal College of Physician colleagues. And I think, I suppose the key word that stood out when you were talking was really about the suboptimal nature, and there are many different facets. I think the erythropoietin and the other complexities of anemia management, which Dr. Niranjan and other colleagues have kind of spoken about in depth over the day. I have been listening while I've been on call. Kind of conveys what we probably also have, as well as a suboptimal understanding, though, is also a suboptimal aspect of patient management pathways, which feed into that. So that's partly the challenge and the opportunity with anemia, because with whether it's blood tests or the insidious nature of the symptoms, I think we globally, I'm involved in the global burden of disease, and some of the anemia estimates still continue to be pretty staggering. But not just the translational aspects of science can hopefully help inform us further, but also the health service aspects in terms of the delivery clinically, whether it's not just in India, which has a considerable burden, but across the world. So I suppose in a way I'm in agreement with the comment, really. Suboptimal understanding and the need for some further collaborative efforts, which I think this World Congress epitomizes.
Thank you very much, Dr. Bhala. With that, and before I finish, I must thank Dr. Chauhan, Niranjan Chauhan, Dr. Komal Chauhan for the organization of this meeting and the opportunity to listen into this brilliant talk. Thank you, Garima and Sidra, for conducting the session so well. And I hand over proceedings back to you.
We do look forward to face-to-face as well. Yeah. Stay safe, take care all.
Thank you, everyone.
Anemia during pregnancy negatively affects both the mother and the fetus, accounting for half the maternal deaths worldwide. Although oral iron therapy effectively treats anemia during pregnancy, the associated gastrointestinal adverse effects often cause non-compliance. Therefore, pregnant women are recommended parenteral iron preparations like ferric carboxymaltose injection, or FCM. However, there is a dearth of data describing FCM usage in Indian pregnant women. To assess safety and efficacy of FCM, researchers from India retrospectively examined Indian women who received FCM during pregnancy. having analyzed 271 women for safety and 168 for efficacy, this forms one of the largest cohort studies of pregnant women receiving FCM in Asia. Analysis identified the majority of women as moderately anemic. Both moderately and severely anemic women exhibited a significant increase of 1.2 and 4.23 grams per deciliter respectively in hemoglobin level after 25 days of FCM administration. Moreover, just 20 days post-FCM administration, the women reported significant increase in hemoglobin level. Continuous monitoring during FCM infusions indicated that there was no clinical deterioration of vital parameters such as heart rate, blood pressure, and oxygen saturation. This supports excellent safety of FCM injections. Itching and rashes were the most common adverse effects observed only in 4% of patients. Interestingly, FCM had no adverse effects on newborns of mothers who received it during pregnancy. In summary, FCM is safe and efficacious for treating anemia in a resource-limited setting without any significant adverse effects on the mother and the neonate.
Thank you, everyone. And with this, we move to the next session, and I would like to invite Dr. P.K. Shah, sir, who has been my teacher as well. We know, sir, as the retired professor and unit head of Obstetrics and Gynec Department of St. G.S. Medical College and KEM Hospital, Mumbai. He has been the past Dean of Indian College of Medical Ultrasound and has been the past President of Indian Association of Gynecologists and Endoscopists, FOXY, and Mumbai Obstetric and Gynec Society. He has been the fellow Will Start International US, and there have been several accolades to his name. I welcome you, sir.
May I request Dr. P.K. Shah to kindly introduce Dr. Anath Doctor?
So can you hear us?
Dr. Garima, may I request you to introduce Dr. Gafter?
Yes, please.
P.K. Shah.
I think I see sir logged in. I think there's some network issue. I'll go ahead. We know Professor Anath Gawale is Professor Institute of Hematology, Rabin Medical Center, Israel. She's been the head medicine and Davidoff Cancer Center, Institute of Hematology, Rabin Medical Center, Belinson Hospital, Israel. And academic career is decorated with several reputed awards and funding. I can see sir back here.
So we are not able to hear you, sir.
Sir, you are on mute, sir.
Yeah, I know. Now can you hear me?
Yes, sir.
Okay. Thanks a lot. Sorry for that technical glitch. And we welcome Professor Annette Gafter-Willig, Professor Institute of Hematology, Rabin Medical Center, Israel. She is the head of Medicine A and Davidoff Cancer Center, Institute of Hematology, Rabin Medical Center, Billingson Hospital, Israel. In academic career is decorated with several reputed awards and funding. And you would like to hear her talk on safety with intravenous preparations in mild to severe IDA cases. Dr. Annette, stage is yours, please.
Good afternoon, and thank you for the invitation to present my lecture in the World Congress of Anemia. I'm Professor Anath Gafter-Willig. I'm from Israel, and I'll be talking about intravenous iron for the treatment of iron deficiency anemia in pregnancy. We'll talk about the efficacy and mainly the safety. A few words of anemia. Anemia is a common disorder considered a global public health problem. It may affect up to a quarter of the world's population, especially in young children and women. And this is according to data from the WHO. Prevalence is estimated at 9% in developed countries, and it may reach 43% in low-income countries. That was anemia as a whole. Iron deficiency anemia is the most common anemia. Iron is the most common micronutrient worldwide, and the deficiency is estimated to affect more than a third of the world's population and more than 40% of pregnant women. The majority of pregnant anemic women living in under-resourced countries are indeed iron deficient. Iron deficiency anemia is a direct contributor to 20% of maternal mortality. And in India, iron deficiency anemia is associated with 80% of maternal deaths. We'll talk about iron deficiency anemia in pregnancy. In India and much of South Asia, the rates of anemia among pregnant women may exceed even 50%. And that represents the largest number of cases of anemia in pregnancy worldwide. Most of the women having moderate to severe anemia live on plant-based diets. And despite 40 years of proactive government intervention, not a lot has changed in the anemia rates, especially for pregnant women and female adolescents. The definitions of anemia. In general, anemia is an hemoglobin level of less than 13 grams per deciliter in male and 12 in female. In pregnancy, the definition according to the WHO is a hemoglobin level of less than 11. And the severity is that less than 7 is called severe anemia, between 7 to 10, it's moderate anemia, and between 10 to 11, it's mild anemia. The Center for Disease Control, the CDC definition, is that in the second trimester, the hemoglobin level less than 10.5 is considered anemia. In the first trimester and third trimester, it's hemoglobin less than 11. The difference in the second trimester is to account for the increase in the plasma volume relative to the increased RBC mass. Anemia has impacts both on the maternal and fetal and neonatal. As per the maternal impact, most published studies among iron-deficient anemic women, and especially in the first trimester, report adverse maternal outcomes, increase in mortality, postpartum hemorrhage, and preterm delivery. Anemic women may have a weakened immunity, reduced work capacity, and usually the more significant the anemia, the more likely the potential for poor clinical outcomes. As for the fetal and neonatal impact, also there are studies that report adverse fetal outcomes such as stillbirths, low birth weight, small for gestational age newborns, and there are changes in the infant's brain secondary to iron deficiency that may affect the growth, the myelination. And also, anemia may be associated with motor and neurocognitive changes in infants. As per the iron supplementation recommendation, the daily requirement of iron increased from the first trimester with about 0.8 milligrams per day required to 7.5 in the third trimester. The daily iron supplementation recommendation by the general guidelines, the CDC recommend for any pregnant lady 30 milligrams daily, the WHO 60 milligrams. The British guidelines have no recommendation for supplementation of iron. How do we diagnose iron deficiency? Basically, like iron deficiency in pregnancy, we do as the usual iron deficiency with a ferritin considered the most accurate test, a ferritin level of less than 30, and a plasma transferrin saturation of less than 15. Hepcidin is under evaluation as a biomarker in pregnancy. When we want to treat iron deficiency anemia, we need to choose the route of iron depletion according to the degree of the anemia, according to the stage of the pregnancy, and other factors influencing gastrointestinal absorption. There are advantages and disadvantages, both the oral iron and intravenous iron. We'll start with oral iron. The oral iron supplements should be taken between meals without acids or milk or tea, and they should be taken with water or orange juice, which has vitamin C. Currently, we believe that less is probably more, meaning that lower doses of oral iron once daily or even alternate daily are better than large multiple daily doses, because the large multiple daily doses may cause a paradoxical decrease in the iron absorption owing to an increase in the hepcidin level. This is a systematic review and meta-analysis assessing oral iron versus either placebo or intravenous iron. There were 43 trials of about 7,000 patients, and they showed that there is a higher incidence of gastrointestinal adverse events with oral iron compared to placebo. So if we conclude the session of oral iron, globally, oral is considered the frontline drug and the standard care for both prevention and treatment of anemia. Oral iron has been shown to increase hemoglobin level and decrease the low birth weight rate of patients. Multiple evidence failed to show significant benefit from increasing the dosing. So usually we give either between 30 to 60 milligrams or 40 to 80 milligrams of elemental iron, and it can be given either daily or every other day. But still, 50 to 70% of pregnant women who are given oral iron complain of side effects and are not adhering to it. That's why we need to talk about intravenous iron. Intravenous iron generally in different settings has been published in more than 100 trials. Use has been proven to be both efficacious and safe, including in pregnancy. The newer intravenous iron formulation allow a full course of iron in one single infusion, and probably with similar and positive safety profiles. This is just to show the current intravenous iron preparations. The three on the right column, the ferromoxetol, the ferric carboxymaltose, and the isomaltoside, are the newer preparations that may be given in one single administration. These are the three that I mentioned. We can give between 500 milligrams in 17 seconds in ferromoxetol, and if we talk about ferric carboxymaltose, which is also called FCM, we can administer 1,000 milligrams in only 15 minutes. This is different from the original formulations, ferric gluconate, iron sucrose, for example. How does the intravenous iron work? Simply, it's a complex made of a polynuclear iron core, and it's surrounded by the carbohydrate ligand. And this carbohydrate ligand is what stabilizes the complex. This complex is actually a prodrug. Since iron has to be released from the core, become available in the macrophages at the site of action. The type of the carbohydrate ligand is essential to the release of iron. With weaker complexes, such as in iron sucrose and ferric gluconate, they cause increases in labile iron, which means that less iron will be received into the macrophages. The rate of the release of the bioactive iron is inversely related to the strength of the complex. In FCM, it is considered a strong complex, so there's slower release of labile iron. And this is possibly an explanation for less adverse events, because the adverse events may be related to the labile iron. In pregnancy, the use of intravenous iron has consistently shown a rapid and a robust response in raising the hemoglobin level and an increase in iron parameters, both ferritin and transferrin saturation. This is a systematic review and meta-analysis that was published in 2019. 20 randomized controlled trials were included, and they compared intravenous iron to oral iron in pregnancy. You can see the numbers, about 1,300 women in each arm. Iron sucrose was the most common intravenous iron in 14 of the 20 trials. And what we can see with all intravenous iron formulations, a higher maternal hemoglobin level. What we can also see is higher maternal ferritin level on admission for labor with intravenous iron. As for other results, there was no significant difference in blood transfusions, cesarean sections, or neonatal hemoglobin. Intravenous iron was associated with higher birth weights, and as for safety, there were fewer medication reactions with intravenous iron. This is another very recent systematic review. It was published in Lancet Hematology in 2021, called FRIDA. And this review was an indirect meta-analysis that included trials of pregnant women with iron deficiency anemia and evaluated all available iron preparations, irrespective of the route, both intravenous and oral, with a minimum of 60 milligrams of oral iron. And they compared everything. There were 53 eligible trials reporting on almost 10,000 women, and 30 of them, which reported 15 interventions, contributed data to the network meta-analysis for the primary endpoint, which was hemoglobin level. And if we can see here, as we saw in the previous meta-analysis, there was the higher maternal hemoglobin level with intravenous iron compared to oral iron. When you see here in the red box, iron sucrose, there were 7 trials and improved hemoglobin level, as well as ferric carboxymaltose in 1 trial, 1 randomized controlled trial. So let's talk about ferric carboxymaltose for iron deficiency anemia and pregnancy. And this is the same randomized controlled trial published in 2017. It's called FAIR-ASAP, FCM, with it was multi-center, open label, randomized, 2 arms. There were 250 patients and total, with 125 in each arm. There were 40 sites. It included pregnant women 18 years and above, 2nd or 3rd trimester, with a ferritin level of less than 20, and different definitions of hemoglobin level, either between 8 to 10.5. For gestational weeks 16 to 26, or less than 11. And it took into account the total iron dose, took into account the baseline hemoglobin level, and the weight of the patient. It was between 1,000 to 1,500. And what we can see, that hemoglobin levels improved with both study treatments at each visit. The red line is the FCM compared to the black line, that's ferrous sulfate, that's the oral iron. So we see better changes in hemoglobin level with the intravenous iron. The pregnant women treated with FCM were twice as likely to achieve anemia correction, meaning hemoglobin level more than 11, than those with the oral iron, 84% versus 70%. And they did it quicker. The median time to achieving this correction was shorter with FCM treatment. And this we can see a significant increase in the serum ferritin level with FCM compared to oral iron. There were also positive results of quality of life scores with the FCM in red, in the vitality score and the social functioning score. The incidence of adverse events was similar between treatment arms. In the FCM arm, 49% of the women experienced adverse events, and in the ferric sulfate, the oral iron, 40% experienced adverse events. The majority of events were mild. There were higher rates of gastrointestinal disorders in the oral treatment compared to the FCM. And this is a prospective observational study, 1-arm study of pregnant women that received FCM. And what we see here is that FCM, the ferric carboxymaltose, significantly increased hemoglobin values above the baseline level in all women. The ferritin level increased as well, and there were no serious adverse effects. There is also a randomized controlled trial comparing ferric carboxymaltose to the previous iron sucrose, and it was conducted in India and demonstrated the superiority of a single dose FCM over iron sucrose. This was an open label randomized clinical trial. It was conducted in a tertiary hospital in New Delhi between 2016 to 2017. Here, they included women with a hemoglobin level less than 10. 100 women were randomized to either FCM or iron sucrose. And what you can see in the red box, the change in hemoglobin level was significantly higher at 12 weeks in the FCM compared to the iron sucrose group. There were better improvement in the quality of life fatigue scores. There were less visits to the clinic in the FCM group, and there were no serious adverse events in any group. So when is intravenous iron preferred in pregnancy, in specific populations, in celiac disease, IBD, in gastric bypass surgeries, in situations of malabsorption? And in the second and third trimester, if there is symptomatic anemia, if the anemia is moderate to severe, meaning less than 10, or if there's insufficient time for oral repletion, meaning after week 30. Also in patients intolerant to oral iron. And this is a review that me and my colleague wrote a few years ago, published in Blood, and how we treat anemia in pregnancy. When we diagnose anemia according to hemoglobin of 11, then we need to know if it's iron deficiency anemia according to the ferritin level. And if it's less than 30, then iron deficiency is indeed diagnosed. In the first trimester, we recommend oral iron for at least 2 weeks. If the hemoglobin increases, this is usually enough. If it doesn't, we wait to the second trimester. In the second trimester, we can give, if the hemoglobin level is less than 10.5, or in the third trimester, if it's less than 11, meaning if there is iron deficiency anemia, we recommend intravenous iron. As for the safety issues, over the years, many concerns have been raised regarding the safety of iron. The most feared adverse reaction is anaphylaxis. It's extremely rare, and it was only associated with the early formulations of the high molecular weight iron dextran, and these formulations are no longer available. Adverse events can occur with all formulations, but the frequency of severe adverse events is extremely low. When high molecular weight iron dextran is avoided, the SAE, serious adverse event rate, with other formulations is less than 1 to 200,000. This is a systematic review published by our group a few years ago, assessing all intravenous iron preparations compared to either oral iron or no iron. They were all randomized controlled trials, more than 100, and the intravenous iron was given across a broad spectrum of diagnoses, pregnancy included. And what was shown, this is all the type of preparations. Most trials were, 57 of them were of iron sucrose, and 15 trials were of ferric carboxymaltose. And overall, there was no increase in the risk of serious adverse events with intravenous iron to control. The control was either oral or placebo or intramuscular. There was no increased risk of serious infection, and the risk of cardiovascular, neurological, thromboembolic, or gastrointestinal severe adverse events was also not increased, and there was no increase in mortality. There was no death or anaphylaxis reported. So this showed that intravenous iron was not associated with an increased risk of severe adverse events or infections. This is another review of intravenous iron, and based on the meta-analysis, I just wanted to show you the frequencies of adverse events. And we see when we take all of the randomized controlled trial, the frequency of adverse events in the intravenous iron group is 4.3% compared to 5% in the comparator group, with no difference. The only difference in intravenous iron was more adverse events, infusion reactions, with 0.4 compared to 0.1%. The mechanism for the infusion reactions, we don't really know. It could be activation of the complement system, and it's related as pseudo-allergy caused by the label-free iron that I showed you before. This may cause symptoms as flushing, myalgias, and sensation of fullness. Hypophosphatemia has also been reported. To conclude, intravenous iron has been shown to be superior, with superior efficacy compared to oral iron in pregnancy. Intravenous iron is safe. We have different formulations, but with the advent of new intravenous iron formulations, as the ferric carboxymaltose, we can complete the replacement dosing in between 15 to 60 minutes. We can give 1,000 milligrams. With a favorable safety profile, we should be motivated to consider giving a high priority for the use of intravenous iron for iron deficiency anemia in pregnancy. Again, only in the second and third trimester. Thank you very much, and for all of the viewers, and thanks again for the invitation to the World Congress of Anemia.
Thank you, Professor Jay. Professor, for covering this subject so comprehensively and not leaving any point behind, because it is so essential in a country like ours, where we have a large population of pregnant patients at that time coming to us, and many of them, around 60%, are anemic. We need to give them something whereby we are sure that you have delivered the dose at one time. And that is why when IV sucrose was available, we used it in a big way. And now that ferric carboxymaltose is available, we are using it so commonly. Thank you very much. Do we have any question, Garima?
No, sir.
Okay. Thank you.
Yeah.
And I thank Dr. Niranjan Chauhan, the Mumbai Obstetric Gynec Society, for giving me this opportunity to chair this session. Thank you.
Thank you, sir. To all our delegates viewing us live across the globe, the certificates are now available for download on the WCA portal. With this, I move on to our next session, and I invite Dr. Bhaskar Paul to chair this session. We know him as the Senior Consultant Gynecologist at Apollo Glendale Hospital, Kolkata. He chairs the AICC-RCOG, Vice President for IAGE, President Bengal Obs and Gynec Society, FOXY representative to CEFOG for 2021-22, Chair of the Organizing Committee of AICOG 22, and Clinical Examiner of MRCOG Part 3. Thank you, sir.
Thank you. Yeah, after the crisp talk on injectable ions, we now move on to a relatively rare subject, and it's my pleasure to introduce my friend, Dr. Jyotsna Acharya. Dr. Acharya is a clinical lead and consultant obstetrician and gynecologist at Macclesfield Hospital in Cheshire, UK. Her special interests are in minimal access surgery, high-risk obstetrics, and medical education. She was the past international convener for MRCOG Part 3 courses. She is an MRCOG and lab examiner, and she is the current RCOG Council representative for South Asia. Dr. Jyotsna would be speaking on thalassemia and pregnancy. Over to you, Jyotsna.
Thank you very much, Bhaskar, for that kind introduction. I know you all had a very long day, so I just wanted to start with some poll questions, just to get some basic knowledge on thalassemia in pregnancy. And could you please put the questions up? I want to reiterate that it is all anonymous, so please do answer the questions so that we can assess knowledge before and after the talk. Thank you. Can we move on to the next one, please? Nobody's answering. Looks like. Please feel free to answer.
I think the audience are on a different portal. They're not on the Zoom.
Is it? Okay. So will they not be able to answer these then?
So Bo?
They will be taking this up in the course of time, Mother.
Okay. So next question then. There's only 4 questions. Perfect. Okay. So I think we are done with that. So I'll just share my screen. So just give me a minute. I'm struggling with sharing my screen. I'm sorry.
Subbu, could you just look into this?
Dr. Jyotsna, do you want us to share?
Yes, please. But I have to send them to you, isn't it?
Yeah, it should take a minute.
Sorry for this. Normally I can share. I don't know what happened here. Let me try again. No, I'm not able to share. I'm so sorry.
You're not on a new device, no?
So I don't know. Should I email them to you? Then we'll be delayed with the talk, isn't it?
No, that should take a minute. You can quickly mail it.
Okay. Sorry for this. Yeah, I've sent it through.
Yeah, it should come. Just are you on a new device by any chance? No.
Yeah, no, what happened was my Mac actually crashed, so I had to set it up again. So maybe that's why it's
I
not.
think there's an issue with permissions. You know, every time you set it up, you have to give permissions to share.
Okay.
I think that is what.
Yeah, because I've shared before, and
Yeah,
I think
absolutely.
that.
So I think it is a question of giving permission to share to your system.
Subbu, did you receive it?
Not yet. Just a second.
So sorry for this delay. Should I start speaking while we wait for the slides to load up?
Subbu, have you received it?
Not yet, sir. We're just trying to refresh and.
I sent it to the science intake.
Just come. It's just.
Yeah. So just now you can start while Subbu shares his screen.
Okay. So I'm going to talk about thalassemia in pregnancy. Thalassemias are the one of the hemoglobinopathies, and they are quite common, as you know. So they are disorders of globin chain production. The hemoglobin is part of the RBC, as you all know, and the hemoglobin is consisting of 4 globin chains, a pair of alpha and a pair of non-alpha chains. And the majority hemoglobin within an adult is consisting of hemoglobin A, which is more than 95%, consisting of alpha 2 and beta 2 chains. While hemoglobin A2 is a minority, and fetal hemoglobin, as we all know, consists of less than 1% in adults, but it is the most common one, which causes, because it actually helps with oxygen carriage in the fetus. Next slide, please. Like I said, there are globin chain quantitative problems, these thalassemias, and they are one of the most common genetic diseases worldwide. Their inheritance pattern is autosomal recessive. And globally, as my previous speaker said, it's about 7% of women do have gene carriers for thalassemia or sickle cell anemia. And in 2011, they estimated that there were 100 million individuals with thalassemia trait, and more than 70,000 babies were born with thalassemia each year. Next slide, please. So it's just to understand a little bit about thalassemias. There are 2 types of thalassemias that we are aware of, but it's a whole plethora of symptoms. So alpha thalassemia, the alpha globin chain, is available on chromosome 16. And its inheritance pattern is on 4 genes, 2 from mother and 2 from the father. As you can see, if you get 2 all normal, then it's a normal hemoglobin formation. If there is 1 gene deletion, as you can see, it causes a silent carrier state. So basically what it is that person has the gene deletion, but don't have any symptoms. If there are 2 gene deletions, that leads to thalassemia trait. Again, they are quite asymptomatic, but when they are pregnant, then there is risk of anemia later on in pregnancy. 3 gene deletion leads to what we call hemoglobin H, and that can cause moderate to severe hemolytic anemia and problems with erythropoiesis. And then if there's 4 gene deletion, that is not compatible with life. So any fetus who has 4 gene deletions will have severe hydrops because of fetal anemia. And but recently there have been some studies with in utero transfusion, but they have not been very successful. But the implications are in pregnancy as well, because the mother can then have hypertension and things like that early on in pregnancy. Next slide, please. Now looking at beta thalassemia is on chromosome 11, and instead of pair of chromosomes, there is 1 chromosome from mom, 1 gene from mom and 1 gene from the dad. And if both are normal, there is no normal hemoglobin. If there is 1 gene deletion, then it can lead to what we call beta thalassemia trait. Again, it's quite asymptomatic in healthy adults, but it can cause anemia in pregnant women. And if there is 2 gene deletions, then it causes a plethora of symptoms ranging from beta thalassemia intermedia to severe thalassemia, which is beta thalassemia major. Next slide, please. So as you can see, it can be a range of symptoms ranging from the traits where there are no symptoms and non-transfusion dependent thalassemia to the worst case scenario when the women are transfusion dependent, as you can see in this slide. Next slide, please. So it's just an explanation of what happens with severe thalassemia. As you can see, the globin chain synthesis is disrupted. So the shape of the RBC changes, and therefore this splenomegaly, because all these are ingested in the spleen. But also because of poor erythropoiesis, there's bony deformities leading to obvious bony deformities in the child. And all this leads to iron deficiency and therefore blood transfusion leading to deposition of iron on the heart and the liver. Next slide, please. So the screening tests that we have, one of the basic ones is a full blood count or CBC. And we see a microcytic sort of picture where MCH and MCV are reduced. In UK, we have an ethnic origin questionnaire where when women come from certain backgrounds like South Asia, African, or South America, where the prevalence of thalassemia is more, then we would go on to do the other screening tests such as HPLC, high performance liquid chromatography, hemoglobin erythrophoresis, and isoelectric focusing. When a newborn testing is done, we do a blood spot test in various things are checked for, and thalassemia is one of them. Next slide, please. So, like I said, it can range from the trait where there are minimal symptoms going on to quite severe thalassemic symptoms affecting the pregnancy. So because of paucity of time, looking at alpha thalassemia, the trait and hemoglobin H, where there was 3 gene deletion, most of them are quite asymptomatic. But as pregnancy progresses, with the trait, you can see symptoms of anemia. One thing to note is that thalassemia can be coexistent with iron deficiency anemia. So we should be checking for iron stores like ferritin levels. If the ferritin levels are normal, that means there's no iron deficiency, and the ideal way of managing them is by blood transfusion. If the ferritin levels are low, then we should be considering oral iron. Next slide, please. So again, same thing with beta thalassemia trait. Like I said, check the ferritin levels, and depending on that, treat with iron or not with iron. Next slide, please. There was a very recent study which was just published in March this year, where they were looking at comparison between the thalassemic traits with equal number of controls, about 1,300. And what they found was the women with thalassemia trait did have lower hematocrit levels compared to the controls. So it is important to know and monitor women with traits, because they do get anemic early on in pregnancy, and this anemia increases as the pregnancy progresses. And the other interesting fact they found was that these women tended to have hypertension in pregnancy much higher than the controls. Next slide, please. This is another recent study which was done in Vienna University between 2008 to 2020. And they've compared thalassemia minor women with controls. And their aim was to check if there was higher incidence of gestational diabetes. But instead, what they found was all the women with the beta thalassemia minor tended to have lower hemoglobin and hematocrit compared to the controls. And that was significant. Next slide, please. So now let's look at beta thalassemia major, which is the major issue, because we need a multidisciplinary team to manage these women, because they are quite symptomatic and there are quite a lot of pregnancy issues. To start off with, actually, the fertility is quite affected in these women. And the reason for that is the iron overload damages the anti-pituitary function, and that reduces their fertility. So majority of women do tend to have artificial reproductive techniques. And if they do, obviously we do need to check the partner. And if the partner tests positive or a carrier state, then we should be offering them pre-implantation genetic diagnosis if we can, because the fetus is at high risk of carrying beta thalassemia major. And also, like I said before, it is MDT management, and at bare minimum, we need a hematologist and an obstetrician to look after these women. Bear in mind that all iron chelation therapies are teratogenic, and we consider them to be teratogenic because we don't have enough evidence otherwise. But desferoxamine is considered to be quite safe in the second and third trimester of pregnancy. Next slide, please. So preconception is very, very important, counseling in these women. And we should be establishing the cardiac iron loading, because these women, remember, need regular blood transfusion. So therefore, they are at risk of iron loading on the cardiac, iron loading, liver, and all organs of the body. So we should be checking their cardiac function. And the other thing is they are very prone to gestational diabetes. So we should be checking their HbA1c level. But it's a double-edged sword, because sometimes HbA1c is not as reliable, because if they are requiring frequent blood transfusion, then they tend to have hemodilution. So the other one, which is more reliable, is serum fructosamine. And we aim for it to be less than 300 nanomole. And because the antipituitary is affected by the iron overload, we should be checking for thyroid function tests. And bones are affected, so check for bone densitometry and give them some vitamin D. Next slide, please. So as I said, very quickly, these women are prone for cardiac iron overload. So a cardiologist should be involved in the care of these women, especially those who are requiring frequent blood transfusion. And the aim is to have a cardiac T2 MRI of less than 20 ms. And the women who come to you preconceptionally should have aggressive chelation therapy, so that their iron overload is the least, or their health status is the best for pregnancy. Next paragraph, please. Next slide, please. Yeah. So the liver, again, we want the iron to be less than 7 milligrams per gram, if we can help it. And the other thing is, it's good to note that these women tend to have cholelithiasis, and they can also have cirrhosis. So you have to check for liver cirrhosis. And because of frequent transfusions, they are prone for viral hepatitis. So you have to screen for those as well. Next slide, please. I did say that the bones are affected because of poor erythropoiesis and things like that. So these women tend to get osteoporosis very early on. So we should optimize vitamin D therapy for these pregnant women. Next slide, please. Because of frequent blood transfusions, many women, up to 16.5% of individuals, tend to have some sort of alloimmunity to, therefore, you need to be careful when you cross-match blood. Next slide, please. Right, very quickly on the antenatal care, MDT management, again, like I said, these babies of these pregnant women tend to have fetal growth restriction. Therefore, we should be doing regular growth scans, and they do need, to be seen quite frequently, 4 weekly until 28 weeks of gestation, and then 2 weekly after that. Those women who are, previous slide, please. Those women who are transfusion dependent, we should aim for a pre-transfusion hemoglobin of 100 grams per liter. And they should have cardiac assessment and everything ongoing as well. Next slide, please. Next slide, please. Yeah, thanks. And they are more prone for, because thalassemia itself is a hypercoagulable state, those women who have had splenectomy or high platelet counts, we should be considering giving them low molecular weight heparin and also low dose aspirin. Next slide, please. Intrapartum care. So timing of delivery should be based on their obstetric condition and on the national guidance. So there's no fixed time to deliver them. But when they are in labor, we should give them IV desferoxamine 2 grams over 24 hours, and they should have continuous monitoring in labor. It itself is not a condition for cesarean section, although we do find that more than 50% end up with a cesarean section. And one of the reasons is because of cephalopelvic disproportion, because of growth restriction in the women. And then we should aim for active management of third stage of labor so that the blood loss is minimum. Next slide, please. Postpartum, low molecular weight heparin for 7 days if vaginal delivery and for 6 weeks if cesarean section. And we should also be starting the desferoxamine again, even if they are breastfeeding, because although it's secreted in the breast milk, it's not absorbed by the newborn. Next slide, please. Yeah, just a quick one on transfusion-related risks. So they should be vaccinated adequately. And if they have had splenectomy, they should have penicillin prophylaxis and vaccinations. Thank you very much. I'm so sorry for the delay in starting. I've overrun, I think.
No, you're fine, Jyotsna. We have, thank you for the crisp talk. We have some questions. The first one, I think you've answered. We do not know what is the national policy for screening of hemoglobinopathies. Since we have the audience from a variety of nations, it's difficult to say what is the nation the question relates to. Yes. I think Dr. Jyotsna has already spoken about the policy in UK that you do an ethnic questionnaire, ethnic origin questionnaire. And if you are a South Asian or you are from South America or you're from Africa, then you get a hemoglobin electrophoresis or an HPLC done. Yes. In India, it is difficult to put a recommendation on doing a screening for hemoglobinopathy for all pregnancies because there are resource implications, but it is definitely one of the desirable investigations. The question for you, Jyotsna, here is that is there any relationship between thalassemia and leukemia?
As far as I know, no.
Okay. The second question is, what is the best time to give a chelating agent? How can I choose the best time for the best response to for each patient, and how can I categorize the patient? That's the question.
So I'm not a hematologist, but only in the second trimester because we don't have data on first trimester. And the only chelating agent which is considered safe is desferoxamine. So only after 20 weeks is what is recommended in all the research that I've done.
Okay. And what is the indication for giving a chelating agent?
So I told you about cardiac loading and liver loading. So MRI scans are done to check that, and they want a minimum. So I think they want less than 20 ms for cardiac, and for liver 7 milligrams per gram dry weight. So these are from the guidance that we have from the British Hematology Society combined with our COG.
All right. And so essentially, and you said that you'll give it routinely in labor. Are there any more questions, Minal or Subbu?
I think we are done with
We are
questions.
done. Thank you very
Who
much,
do you
Joseph.
have? Thank you. I was thinking that I think we have overrun. Otherwise, you would have
No,
done
it's
the
fine.
poll again. It's
Okay.
yeah.
Thank you very much, Josna. And I take this opportunity to thank my dear friend, Dr. Niranjan Chauhan, for inviting me and the entire team at MOGS. And thank you very much. Back to you, Garima.
Garima? Dr. Niranjan, are you there?
Yes, I am there, and thank you so much, Dr. Jyotsna, for joining us today from London, and thank you, Bhaskar, wonderful lecture presentation of AICC RCOG being done, and it's a really great feeling of joining all of you together. And now I have with me Dr. Madhuri Patel. She is there.
Thank you, sir. I'll just invite and introduce Dr. Madhuri, madam. We know, ma'am. We welcome you, ma'am. She's the Secretary General of FOXI, Joint Secretary FOXI 2009, former committee member of FIGO Peterborough, and several accolades to madam. Ma'am, we'll love to hear from you.
Garima, thank you very much. Before that, I would like Dr. Shanta Kumari madam is with me.
Welcome,
She's the
ma'am.
president of FOXI. So I would like madam to say something.
Hi everyone.
Welcome, ma'am.
Thank you. I know this has been a very important webinar, but we were in the middle of the FOXI RPL conclave, which is happening. That's the reason why we couldn't join earlier. And this is such an important topic, anemia and OB-GYNs. And it's a pleasure. I've seen everyone from FOXI and FIGO were there. Jean and our CN sir and everyone. And I'm sure like all the delegates would have really benefited a lot from the exchange of opinions. And let's all work together to see that we actually reduce anemia so much that we don't need to talk about it. I think that should be the end point of our CMEs on anemia. Right. Thank you.
Thank you. I must thank Dr. Niranjan Rajendra for giving me this opportunity. And as Dr. Shanta Kumari said, that we were all busy with the RPL conclave in Goa. We have just finished, and Dr. Niranjan and myself are just sitting and say that hi to everybody. And this anemia is a very important, our World Congress on this. Very important part, because majority of the anemia can cause indirect or direct maternal mortality. And if we have to reach to this 2030, SDG Sustainable Development Goal by 2030, then we have to treat anemia, and will definitely indirect and direct causes will reduce tremendously, and we will definitely achieve 70 maternal mortality rate below 70 per 100,000 live birth. I must thank Dr. CN Purandare, Dr. P.K. Shah, Dr. Kiara, and Dr. Jenny Conray, Dr. Shanta Kumari, all the people, Dr. Nandita, Dr. Sanjay Gupte, and all the people who have joined over here. And I thank all of you for being here and giving their expertise and experience, so we can use in day-to-day practice, and which will benefit to our women. Thank you once again for giving me this opportunity.
Thank you, Shanta Kumari madam and Madhuri madam. It's a great pleasure to have you when the entire globe is watching, and to get the message from the president and the secretary is in itself very invaluable.
Thank you. Thank you. I can see a slide which wonderfully displays the analysis which has happened, and we have crossed more than, I think, 3,500 members. I can see from Indonesia 4, Seoul 7, Sri Lanka 16, Singapore 17 members joined from Nepal, 22 United States, wow, 49 from Hong Kong, 67 United Kingdom, 129 members joined, and from the African countries. I think that is amazing. And anemia is very prevalent there and in our subcontinent, madam. And that's what Jean ma'am and even Annie Chiara ma'am, CN sir reiterated that we need to, Niranjan, also not only take the obstetricians together, but we need to make some small clips, madam. So on behalf of Foxy and the World Congress of Anemia, you being at the helm of affairs, we need to understand that the message is also given to our patient. It's not only the obstetricians which we teach. Thank you so much for that wonderful place. And now I hand over the mic to Garima.
Thank you, sir. And it is an honor to introduce Sir himself, who's the professor and unit head at the Obs and Gynec department of LTMMC Sain and Sain Hospital in Mumbai. He's the current president of Mumbai Obstetric and Gynec Society, joint treasurer for Foxy, joint secretary of Association of Fellow Gynecologists, managing committee member of IAG, and several accolades to Sir's credit. I welcome you, sir.
Thank you. Now it's my privilege and honor to welcome our professor. Can I have the slide? We have Professor Omondi, who is joining us from Nairobi University, and he is a great leader. He is a great speaker. I have heard from him many of his lectures, and really a lot of efforts he has been doing. I can read here that he is also served as the Secretary General of KOGS for 5 years, and his interest of field is fetal medicine and hypertensive disorders in pregnancy and HDP. He has published many peer reviews and is also a member of several international and local professional societies. He is very active in his clinical practice, and his research is on the role of UNK cells and uterine microbiome in RPL in the African population. I am really thankful for his valuable time being present today, and he is going to talk on a very interesting topic, which I can see here being present. The topic today is universal access to anti-Rh immunoglobulin and effective management of D-negative pregnancies, in turn leading to hemolytic anemia. I think this topic is also very common and rampant in India and sub-Saharan and Southeast Asian countries. Welcome, sir, and nice to catch up with you soon. Thank you.
Thank you, the organizers of the World Council of Anemia for the invitation. And I'm happy to state that my colleague and the current president-elect of FIGO, Dr. Ann Kihara, had given the initial discussion, so that now we'll be able to try and see if I can share my slide. Let me just, I don't know whether, I hope I will not get into the previous speaker's problem again of sharing, but let me see if I will share. I think I'm on. Are you able to see them? You can see the slide.
We can see the slide.
Okay, let me go to slide presentation now. Where is the slideshow? Let me start from the start. Okay, thank you, colleagues. I want to talk about a subject which is very close to our hearts here in the country, and I will give it a country perspective and also some regional perspective, so that we can be able to look at the importance of this subject and also the issue of anemia and what it contributes in terms of the neonatal outcome and also the socio-psychological aspects which we find in the women in our country and also in the region as a whole. So I'll give it an overview and give some information and the statistics as we go along. So I've got no conflict of interest to declare. So this is basically the outline I will be able to give, and I'll be going back and forth so that at least we try, because it's a very big subject and we may not be able to cover all the aspects, but I'll try and give it perspective to be able to capture as much. This is just to give you a schematic presentation of our city, Nairobi in the night. I know in India it's nighttime, here it's in the evening. And this is one of our major tourist attraction, the sub 2 hour mile Cape Keino, who is one of the people we are very proud about, and it does a lot to uplift the social status within our community other than just being an athlete. He's also a philanthropist. We know what basically the hemolytic disease of the fetus and the newborn and what happens, how the anemia process takes place when you get the destruction of the maternal red cells, when you have the IgG crossing the placenta. This is a major problem. And the main event is that you get hemolysis, and this hemolysis leads to anemia. And once you have anemia, then the rest of all the other complications sets in, okay? And some of these complications will be, if it's extreme, you get hydropic babies. And if not so, then you get status of hyperbilirubinemia. And if this is not corrected in time, then you get kernicterus in the newborn. And we know the end result is that you get, you may lose that baby, or if the baby survives, it will not be able to be of interest to the mother. In terms of the general well-being of the baby. And most of these babies are usually lost early in life. Okay, sorry. Okay. Now, we know that the rhesus negative blood group varies in groups, races, ethnicity. We know that among the Caucasians is almost up to about 20%, with the highest percentage we know we get in the Basque region in Spain. According to the race in Africa, we get a population prevalence of about, on average, of about 3 to 5%. And then we know what happens in ethnicity, which I've just mentioned. What we have in our region is that not much information is available because a number of the women may not be able to access, and this happens in most of the low and middle income countries. They do not access antenatal care, and therefore you may not be able to get a good population sampling of the extent of the disease. In the high income countries, it's almost eliminated, but we still have a lot in our countries. And I think in the African countries quite a bit, because you know, with our prevalence, which is very high relative to what you find in among the Asiatic communities. So it's a big problem which we have here. I've talked about the fetal red cell destruction, which is a major issue which leads to anemia and all the others. Now, before the introduction of the rhesus negative, the anti-D, up to about 21% of the newborns were generally affected. In areas where it has been introduced, the numbers are so few. And these are people who may be either immigrant population or those who just choose not to attend antenatal clinics and for reasons which may be best known to themselves. This is just a schematic representation. We have a very big percentages amongst the Caucasians, then the African, and then in the Asia. So it's a bigger problem for us than maybe in the Asian community because of the prevalence. But what we know, once we have, even if it's one patient, a mother who has got immunization, it's a major, major issue. This is to give us a representation of the negative blood group we have. In our country is about 3.9%. The highest you get in Nigeria, which is about 4.2. South Africa is a bit higher than the rest of the sub-Saharan countries because of the number of the mixed race which you have in South Africa. So they get a bit of higher numbers of rhesus negative blood group. But the rest of the African countries are almost at par. Now, this is a slide which I had borrowed from Professor Weiser, Gerald, about 2 years ago when there was the 50-year celebration of the onset of the RH anti-D. for immunization of the mother, for as a prophylaxis. These numbers have generally increased. You can see the numbers, which is alarming, 373,000. Now the numbers are even increasing, with very high numbers dying in utero, and then those who get connectors with the resultant brain damage. So this gives you an idea of the magnitude of the problem in which we need to be addressing. And the end result of all this is that destruction of the red blood cell and giving us all these problems, the net result is the baby becomes anemic, and all the other complications which you get of the atrophic baby, the ones you get because of the portal hypertension they develop in these babies, the enlarged liver, enlarged spleen, are all simply because of the anemia. The process of sensitization, most of us know, just to remind ourselves, when you have got the escape of the rhesus positive blood group into maternal circulation, we know we need even as little as 1 ml of fetal red cells into maternal circulation to eventually cause isoimmunization. This process is time bound. That's why the first babies may be able to survive the process, but subsequent babies are always affected. And the speed will depend on subsequent pregnancies which the mother gets, and there's no intervention. So it becomes more like a cyclic event. Now I've talked about when use of anti-D. We know when it was introduced around 1968, and it has really made a lot of difference. Unfortunately, in some of the areas where it is really, really needed, the uptake is very low, especially in the African countries and also in some of the low and middle income countries. So it is still a major concern. This just to give you a reference on the worldwide prevalence. This is what we have worldwide, but the numbers are much higher in the regions where we have already indicated in the previous presentation. What is the burden we have if I come closer home to Africa? The burden is because there's a problem of access of adequate blood and blood products, challenge of infrastructure, availability of funds, availability of structures to be able to disseminate, availability of fully trained healthcare providers who should be able to provide the kind of treatment which would be required. Then, of course, the infections, occurrence transmissible infections, like what we recently, we are still having of COVID infections. And we noted that in our setup, I was looking after quite a number of patients who were rhesus negative, were not isoimmunized because they had taken their prophylaxis and their ICT levels were all undetectable all through. But when they got COVID infection, especially in their second trimester, about within 2 to 3 weeks, the patient started showing evidence of isoimmunization. So we know what happens at the placental bed, therefore we get escape of the fetal cells into circulation, and that now causes very fast stimulation within the maternal circulation, and therefore you start getting very high levels of ICT, which rises very, very fast. And you are always being forced to deliver those mother babies before we got into the irreversible situations. I've already mentioned about this, the burden and what we have of the rhesus negative, and why we still have there's still a lot of problems of availability of blood products, even if you had to use the O negative, if there's need of doing an exchange transfusion, because there's a lot of cultural, social, religious beliefs against blood donation. So that ends up making availability of the blood products for use becomes a challenge, okay? Now, the failure of adequate prevention or sensitization of the mother is what causes all this. And why does this happen? This happened because of non-attendance of adequate antenatal clinics, so that we pick up these mothers and they are advised appropriately. And that's why you tend to have lots and lots of mothers who still end up getting sensitized. Also, deliveries at home, because most of the low and middle income countries, you still find that hospital deliveries is never 100%. In some areas, it's between at most 60, 70%. In our country, we have it now at about just approaching 70%. We had a big leap from 43, 46 to 70% within the last 5 years. And that was a bit of a plus within our status. You remember WHO has brought in this handbook of what you should be able to use for antenatal prophylaxis, and so that you can be able to identify what are your priorities, and you should be able to assess the area in which you are working in, so that as any care provider, we should be able to plan, implement, and disseminate guidelines which would be able to help the policymakers to be able to make a difference. Because sometimes we say that this is what we need to do, but maybe as a healthcare providers, we do not intervene appropriately so that our voices are heard. We know what happened in 1968. We know the contribution of the gentleman who started the RH disease prophylaxis. It's almost 53 years down the line. And it's one of those diseases which we thought should be easily eliminated. But since then, we are still almost, especially in some of the regions, the lower income countries, the difference and the impact on it is not as significant as would have been thought. This one we know, we all give anti-D, you know how it looks like, okay? The timing varies depending on the region. And this is important because the timing is all to ensure that you do not allow these patients to be able to get sensitized. So in some of the areas, like what we do in our country, if you're not very sure when you get contact with these mothers and you didn't have time to do their blood group so that you decide the blood group of the baby, then we go ahead and just give anti-D. Okay? Now, I've mentioned this, the bottom line is the destruction of the red blood cells. How do we stop this so that we can stop the anemia? One, we must recognize the possible events which lead to immunization. That is the early pregnancy bleed. That is the previous deliveries where the blood group of the baby was not detected. We must ensure we have got good infrastructure so that we have adequate materials to be able to take care of these babies. And we must be able to perform tests if you're not sure on the extent of the fetal-maternal transfusion, so that you give the adequate dosaging, so that you do not give a lower dose and you think that you have already given. What do we do about the cost of anti-D? It's still expensive. And we need to have the cost brought down. And this is one of the things which should actually be advocated for. The cost of anti-D is still relatively expensive for most of the countries which may not be able to afford, and they can afford it, but may not be easily available for everybody because the cost is still prohibitive. So we should be able to lower the cost to as low as maybe the cost of aspirin, so that we are able to ensure all our people who need it get it. So that, and then we should be able to know how do we take care of the complications of the anemia, either in utero. We be able to do exchange transfusion, or what else do we do? Are we giving medication to be able to reduce these complications from occurring? This is just a pathway of the immunoglobulin discovery synthesis, because this is one of the things we know we can be able to use intravenous immunoglobulins to be able to reduce the use of the complications of anemia. We all know the cost of immunoglobulin is still quite prohibitive. So for my practice and what we are doing a lot in our region here is to give the mothers who are showing very early sensitization, low dose steroids of dexamethasone, anything between 4 to 6 milligrams weekly, and we are able to maintain their ICT levels, those who are already sensitized, to anything between at most 1 in 32. They come down to maybe 1 in 16, and we are able to get our mothers, and they go until almost term or near term, and they get babies who are not compromised. It's cheaper, much cheaper than IVG, and that's now what we do. Okay. I've talked about this, so maybe I'll just push this. Okay. Now, antenatal care, this is some of the things we should be able to do. Should we be able to ensure these ladies come always give immunoprophylaxis, which is an important aspect, and then laboratory follow-up of risks cases. These are also expensive tests, which should also be made cheaper, which we do so that you can be able to look at them. Obstetric ultrasound to be able to monitor the fetal well-being. This is crucial. And you find that you're only available in the tertiary centers in most of the LMIC countries, so that you can be able to use an ultrasound so that you can be able to monitor and determine what is the extent of the injury to the baby. So the push here, and this is now what we are encouraging, and we are teaching our students so that by the time they qualify as OBGYNs, they are able to carry out ultrasonic and sonography monitoring of the fetus so that they pick up some of the early elements of fetal compromise so that adequate decision on management of the patients is put in place, okay? Our women, all women must know their blood group. Not everybody knows. We have that challenge. And those who need to be given anti-D must be given when indicated. We get a lot of women who do not get of maternal-fetal hemorrhage. Okay. Now, some countries in Africa have really had very good work done. And Ethiopia is one of the countries, and South Africa, who have done much work on this, and they have made better strides than most of the other African countries. And their use of anti-D is quite high. In our country, we are now coming to about nearly about 10–12%. We still have up to about 8% isoimmunization. In one of the last studies I did just about last year, about 6 months ago, we are still having 8% isoimmunization. And most of these patients are those who are sitting at home and they come just to deliver, or they come when they already have got problems. And you can see South Africa is quite high, or up to 44%, which is good. So this is just to represent what I've just talked about in schematically, okay? So some of these consequences, without appropriate monitoring, we have problems. We will not be able to make heads and tails out of all this. And although the rhesus negative African population is much lower, but the burden of RH is still quite high because of being able to pick them up. And that is now our major stride. How far can we go to ensure that all our mothers who are expectant know their blood group? And for those who are rhesus negative should be able to get the appropriate anti-D when needed, and as a prophylaxis, and also after delivery if the baby is positive. I just put in a representation here of some of the management, this is basically done by our neonatal colleagues, the issue of exchange transfusion, and also I've talked about the issue of, we can be able to, this one we can give IV to the mother, the use of intravenous immunoglobulin. It's quite expensive, so we only use it in selected patients in our tertiary teaching hospital. The exchange transfusion, this one is easily done because we nowadays have got, in most of the hospitals across the country, have got trained pediatricians who can be able to carry out this very well because they get adequate training during their training sessions at the university. For those who have hyperbilirubinemia, to be able to ensure that we reduce the chances of developing more of the anemia on the baby, these are basically what we all do, the physiotherapy and no phototherapy, sorry, not physio, adequate hydration, at birth issue of delayed cord clamping, and then I've talked about exchange transfusion, which has been there since we remember 1940, okay? Now, I mentioned this in passing earlier on, and we are using a lot of low-dose steroids, up to be either 3 milligrams or 6 milligrams, depending on the strength which is available. And as I've told you, it's really bringing down the ICT levels, and we are delivering quite a number of babies. And I'm the one who's spearheading this, and the results are quite promising. Once you have got enough data, we should be able to share it with our professional colleagues to see what we can do in a low setting. We don't have any complications which one can be worried about, maybe intratrochanteric bleed or anything compromising the baby, or things like diabetes in the mother, because the dose is very low. These are some of this is for the policy people to ensure that everything is in place and we can be able to refer as and when necessary, and having adequate and trained personnel to be able to help us. We know of this FIGO position when we attended the FIGO conference in Rio, to be able to awaken awareness, and also we ensure that the routine blood testing and to be able to get free and unfettered access to immunoglobulin prophylaxis. This is what I was mentioning at the beginning. It is still too expensive. We need to encourage easy access and cheap access for everybody who requires it, okay? So I'm just 2 more slides. We know the prevalence is low in the African population. We know the utilization of anti-D is also low. We need to improve our antenatal care awareness, which we are actually improving on. And the more we increase participation of our colleagues, the pediatrician, neonatologists, the obstetrician, and then the hematologists. And then also what we are doing now is that we are not leaving our colleagues, the psychiatrists, because they bring in a lot of psychosocial support to most of these mothers who have been losing babies. Until now, they will say, they always tell us that I'm only wasting babies, I'm not delivering babies. So can something be done? Okay. I've talked about that. Thank you, ladies and gentlemen. Sorry I've taken long.
Thank you, sir. May I invite Dr. Sangpal also to say a few words here?
Am I audible?
Yes, sir. Sir, can you conclude the session, please?
I wish to thank Dr. Omandi for this really, really interesting lecture. And I'm sure the delegates at this moment of time also must have enjoyed thoroughly your lecture and your message to the audience. Thank you, sir. And I wish you again to see you again some more time in our own conferences. Thank you.
Thank you. Thank you so much.
Thank you. Can we have a slide? Sir, we just have one quick slide.
Okay.
So I request all the viewers to kindly go and click on the participation certificate link. The moment they do, they'll be able to download the certificate, which will come like this. Thank you very much. And I pass on the call to Dr. Garima.
Thank you, Session. And I would like to now invite the Secretary General of Mumbai Obs and Gynec Society, Dr. Rajendra Sangpal, to give us the official vote of thanks.
Thank you. What can I say? I mean, really, it was indeed a successful World Congress of Anemia. And I wish to congratulate MOGS President, Dr. Niranjan Chavan, and the entire managing committee for having such a successful World Conference on Anemia with attendance of more than almost 3,000 delegates all over the world. And a really appreciable number on a working day. On behalf of MOGS and entire managing committee, I wish to thank guest of honor, Dr. Jean Connery, FIGO President, Dr. Shyam Desai, our own President-elect from Suffolk, Dr. Nandita Palshetkar, Foxy representative to FIGO, Dr. Sanjay Gupte also was a Foxy representative to FIGO in the past, and also the chief guest, Dr. Annie Chiara, President-elect FIGO, Dr. CN Purandare, our own and being a past president of FIGO, and the entire national faculties for putting their efforts and giving their valuable time for making this World Congress a successful example. Every faculty has put their heart and soul and made a justice to their topics, and I'm sure whoever and they have contributed to our more understanding of anemia, and I'm sure everybody will agree with that. I wish to thank Managing Committee and Master of Ceremony, Dr. Garima, Dr. Sidra, Dr. Zubin for the valuable contribution. And I also wish to thank Managing Committee and the office bearers for their support. I also like to appreciate the efforts of the Science Integra for successful coordination and uninterrupted show. At last, without our delegates, the conference would not be appreciated, and I appreciate their efforts to remain present in such a large number. And we feel proud when the delegates are more in number and we can set up an example. Thank you all delegates for being there with us to see our work. Thank you so much, I would say at the end, and have a good evening.
Thank you, sir.
Thank
Yes,
you all.
Garima.
Hi, Rajendra.
Hi.
I hope everything went well. Thank you all of you being there. Is it offline now?
No, it
Recording
is going on.
stopped.
Okay.